just increase treatment. Previously we were giving 200 budesonide. Now we will switch over to step 5. So we are adding LAMA and we are increasing ICS dose to 400, 4 puffs in a day. So in this patient we have increased ICS dose to 400 microgram and we had added second bronchodilator, that's a tiotropium. But this patient still have uncontrolled symptom despite step 5 treatment. So this is called difficult to treat asthma. Means patients are having asthma, uncontrolled asthma, and in spite of increasing treatment, still patient is having uncontrolled asthma. So what is difficult to treat asthma? If asthma is uncontrolled despite describing medium to or high dose ICS, or patient we have added second controller despite that patient is having uncontrolled asthma, or patient is having control of asthma, but once we are reducing the dose, then patient is losing control. So this is a definition for difficult to treat asthma. And most common cause for difficult to treat asthma is incorrect inhaler use, poor adherence, comorbidities, smoking, and last, incorrect diagnosis. So if you address this issue, probably difficult to treat asthma may convert into normal asthma. So what is severe asthma? So severe asthma is nothing but subset of difficult to treat asthma. So in this patient, we have increased all dose. We have to rule out any other contributing factor, like patient is taking regular inhaler, correct dose, all comorbidity was addressed. In spite of this, if patient is having uncontrolled asthma, this is called severe asthma. So also called severe refractory asthma. It is relatively refractory to high dose ICS corticosteroid and rarely complete refractory. So severe asthma, despite of all measures, patient is not getting relief. That is severe asthma. So this is summary for uncontrolled asthma. If uncontrolled asthma is there, you can increase medication and see whether patient is getting control or not. If there is uncontrolled asthma and we can find contributing factor like adherence, incorrect inhaler dose, like that, if we correct this, then it is difficult to control asthma. If all, despite of all measurement, if patient is having uncontrolled asthma, this is severe asthma. So if we see prevalence of difficult to treat asthma, so 1/4 of all patients of asthma is having uncontrolled asthma. If you see 100 patients are there, out of that 24 patients are having uncontrolled asthma. And 17% is difficult to treat asthma. But if you see the prevalence of severe asthma is only 3.7%. So you can imagine if you are dealing 24% of uncontrolled asthma, out of that only 3.7% is having severe asthma. All other asthma we can manage either by increasing the dose or by addressing the contributing factors. So this is beautiful chart given in GINA 2023, and there are 4 steps for difficult to treat asthma, how to approach. So in step 1, we have to confirm diagnosis and we have to rule out other comorbidities, or we have to look for other diagnosis. In adult, most common diagnosis is COPD, and another one is bronchiectasis, cardiac failure, pulmonary embolism. So we have to rule out other diagnosis to confirm the severe asthma and look for contributing to symptoms, exacerbation and poor quality of life. Say for example, incorrect inhaler use. So this is one of common mistake the patient is doing. We are prescribing inhaler, but often we are not checking. So patient taking incorrect inhaler technique, suboptimal adherence, patient is taking inhaler but is not using inhaler after some time. Comorbidities like obesity, GRD, chronic rhinosinusitis, OSA. So this factor, chronic rhinosinusitis, this is one of common factor. We often miss this in our diagnosis. So once we are treating asthma, we have to look for allergic rhinosinusitis. Without addressing allergic rhinosinusitis, we cannot control asthma. Modify risk factor like smoking, environmental exposure, allergen exposure, medications like beta blocker, NSAID, and overuse of sour liver. In GINA itself, they told that if a patient is using 12 canister per year, he is having high mortality and medication side effect, anxiety, depression, social difficulties. So we have to look all these factors to make uncontrolled asthma to controlled asthma. Then once we have seen comorbidities, then we have to optimize treatment again. We have to educate patient about asthma, how to take inhaler, means what dose we have to take inhaler, consider non-pharmacological like smoking cessation, exercise, weight loss, COVID-19 vaccination, treat comorbidity if it is there, consider non-biological treatment like LAVA, LAMA, or if not used earlier, consider trial for high dose ICS LAVA if not used. So by these measures, we can try to control asthma. And we have to wait for 3 to 6 months before labeling severe asthma. So once patient is coming to your OPD first time, you cannot label severe asthma. This is retrospective diagnosis. So once we are labeling severe asthma, we have to wait for 3 to 6 months. In 3 to 6 months, we have to address all comorbidities, all contributing factors which lead to uncontrolled asthma. After 3 to 6 months only, we can say severe asthma. So how to approach a patient with severe asthma? So this was difficult to treat asthma, now severe asthma. So once you find severe asthma, you have to look for phenotype, endotype. So what is phenotype? This is observable characteristics like exercise-induced asthma, obesity-induced asthma, steroid-responsive asthma, phenotype. Another is endotype. So what pathophysiological mechanism is going on in the patient of asthma, and because of that patient is not getting controlled, we have to look for this endotype also. So based on endotype and pathological physiological mechanism, we can divide asthma in type 2 high asthma and type 2 low asthma. So what is T2 low and T2 high? In T2 low, there is pathophysiological mechanism. I am not going in detail, but one thing we have to remember that asthma is mainly two types, Th2 low, Th2 high, or eosinophilic or non-eosinophilic. So in eosinophilic is T2 high. So different cytokines are there like IgE, eosinophilic, and eosinophilic IL4, IL13, IL5. So we have to label severe asthma patient as T2 high, or this cascade is T2 low. It's also called neutrophilic or polygranulocytic. So patient is having neutrophilic, he will be having these cytokines like IL-23, IL-17, 22, 8. So by this pathophysiological mechanism, we can identify T2 low and T2 high. So this is difference. So majority of patient is having T2 asthma, T2 high asthma, and 1/3 patients are having non-T2 high asthma. So T2 high type asthma. So there are certain markers by which we can label as T2 high asthma. So there are 4 markers given in GINA. Blood eosinophil more than 150, pheno is more than 20, sputum eosinophil more than 2%, or asthma is clinically legend driving. So any one of these markers we can label as T2 high asthma. And this is the treatment for T2 high. I am not going detail because there is separate lecture by Dr. Alok Nath. So, but in brief, I can tell you that IgE, if there is high IgE or allergen-driven asthma, if you find that skin prick test positive or this thing, we can start omalizumab. If there is eosinophilic asthma like high anti-IL5 or IL5 receptors, we can start benelizumab, mepolizumab, reslizumab. So if there is high eosinophilia, we can start this group. If there is blood high eosinophil but less than 1500 or pheno is more than 25, then we can start anti-IL4, dupilumab. This is a beautiful chart given in GINA. And at last, this is new drug, tezepelumab. It is not available freely, but those patients who are not eligible for above these 3 drugs, then we can go for anti-TSLP. This is theoretical, it's not available right now in India. So once we are starting biologicals, we have to see response for 4 months. If there is good response, we can continue. If there is doubtful response, we can wait 6 to 12 months. We can extend treatment 6 to 12 months. If there is no response, then we can stop treatment and we have to find what is the factor which is making asthma uncontrolled. Now, non-TH2 asthma management. So this is posigranulic or neutrophilic. So once you find non-TH2 type, these are really difficult to treat asthma. So we have to review our basics. We have to rule out differential diagnosis, inhaler technique, adherence once again. Avoid exposure, consider investigation if not done earlier. And this is the treatment we can add. We can add LAMA if not used earlier, low dose azithromycin, anti-IL-4, anti-TSLP. And last resort, if asthma is still uncontrolled, we can add low dose ICS. And last, consider bronchial thermoplasty. It's not means used routinely, and stop ineffective add-on treatment. So these subgroup of patients, non-TH2 is really difficult to treat asthma. So these are few phenotypes like fixed obstruction, ACO, late onset non-atopic asthma, poorly steroid responsive asthma, obesity related, pre or perimenstrual. These are phenotype of TH2 low asthma. These are very difficult to treat. So this is few treatment like fixed. If there is fixed airway obstruction, we can add LAMA. If there is chronic bacterial colonization, like patient is having associated bronchiectasis, we can add low dose azithromycin. If there is cough reflex hypersensitivity, we can stop AC inhibitor and add treatment for GRD. If there is steroid overuse, we can hold for a few days. We called holiday, steroid holiday. If there is vocal cord dysfunction, we have to treat by speech therapy and with the help of ENT people. So this is azithromycin study, a major study, and in this study, patients divided into two groups. One group is receiving azithromycin and other is receiving placebo. And at the end of this study, so we found that azithromycin reduced asthma exacerbation, significantly improved asthma-related quality of life. So azithromycin is helpful in subset of patients where there is chronic bacterial colonization is there. This is bronchial thermoplasty, not used routinely, but by this we can manage those patients who are having fixed airway obstruction. And by this we are means that airways by bronchoscopic method that involve delivery of radio frequency energy to heat the target airway to 65 degree, mainly large airway. So it involves 3 sessions. So other therapies management of asthma, these are smoking cessation, already I have told you, physical activity, healthy diet, weight reduction, breathing exercises, vaccination, influenza, pneumococcal, COVID-19, avoid of exposure to environmental occupational pollutants. So this is for occupational asthma. If we are not controlling occupational exposure, we are not going to get control of asthma. And few subset of patients where there is allergy, and we can find by skin prick test or this thing, we can start allergen immunotherapy. There's a separate lecture for that. So to summarize, for any difficult to treat asthma, we have to confirm diagnosis. Because in periphery, especially periphery, if patient is having breathlessness, the doctor is labeling as either COPD or asthma. But patient may have anything. Patient may have bronchiectasis or anything. So we have to confirm diagnosis before labeling a patient of asthma. Look for factor contributing to symptoms and exacerbation. Most important is allergic rhinitis, allergic sinusitis. Once we are not addressing allergic problem in rhinitis or sinusitis, we are not going to get control of asthma. Review and optimize management. Review response after 3 to 6 months. So before labeling severe asthma, we have to wait 3 to 6 months. Then only we can label as severe asthma. Assess and treat asthma phenotype, TH2 and non-TH2 type. Currently, the limited treatment option is type 2 low asthma in contrast with TH2 high, where we are having biologicals. And most of the studies nowadays going for TH2 high asthma in biologicals. So type non-TH2 type is really a nightmare, very difficult to control that asthma. So with this, I'm thank you. In the outset, I thank organizing team for giving me this opportunity. Thank you.
Thank you, Dr. Hemant sir, for the nice lecture. Questions, Dr. Sachin, abhi lena hai kuch? Any questions from the audience?
Thank you, Dr. Hemant, for beautifully summarizing all the aspects of severe or difficult to treat asthma. One of the things which I wanted to add is if we are deciding to give azithromycin, it is better to rule out atypical microbacterial infections before starting treatment and do a baseline ECG and do a ECG after 1 month.
Yes.
Otherwise, I think, yeah, as you said, that a non-TS2 type is really difficult to treat.
Yes.
Thanks for the nice presentation.
Thank you.
Thank you, Dr. Hemant sir, for that insightful presentation and sharing your valuable insights. I now request Professor Ved Prakash sir to kindly come onto stage and felicitate our guest speaker and chairperson. May I request Professor Viren Singh sir to please come onto stage and felicitate our guest speaker and chairpersons. Thank you, sir. Our speaker, Dr. Hemant Kumar sir. Dr. Muhammad Amir sir. Dr. Rajneesh Srivastava sir. Dr. Abhishek Verma sir. Thank you, sir.
Moving ahead, for our next session of the day, newer classification of hypersensitivity reactions, may I request the chairpersons to please grace the stage and take their seats. Dr. Puneet Kumar sir, Head of Department of Rheumatology, KGMU. Dr. Mukesh Maurya sir, Assistant Professor, Department of Rheumatology, KGMU. Dr. Abhilash Krishnan sir, Assistant Professor, Department of Rheumatology, KGMU. I now request the chair to kindly introduce our speaker and take over the session. Thank you.
Uh, Good morning, sir. Dr. Vikas Agarwal is a graduate and postgraduate from King George Medical University, and he has done his DM in clinical immunology from Sanjay Gandhi PGI. He's a good researcher, good clinician, and good orator too. His work of tadalafil on in systemic sclerosis is world known. So I request Professor Vikas Agarwal to give a talk on newer classification of hypersensitivity reactions. Please, sir.
Uh, Many thank you, Dr. Puneet, and I show my gratitude to Dr. Ved who actually invited me. It's my OPD day, so I'll not go into any further details and start with the topic right away. Uh, Disclosures are none, so I'll straight away start with what is hypersensitivity. This is a concept which was brought about by Philip Gell and Hind in 1951, and it was referring to the reaction of tuberculin, where they were trying to identify patients who are already exposed to the mycobacterial infection. And subsequent to this work in 1963, the famous classification of hypersensitivity reactions was given by Gell and Coombs, because they realized that hypersensitivity is a very undesirable, uncomfortable or damaging response initiated by overreaction or overstimulation of immune response in response to an external stimuli. It comprises of both allergies which are triggered by external stimuli, and later on it was also realized that there could be certain autoantigens which can trigger autoimmunity, and therefore these hypersensitivity reactions are known to play a role in the damaging the organ system. So they gave 4 major types of hypersensitivity depending on the initiating mechanism of this. This word is important. Initiating mechanism was the founder principle of this Gell and Coombs classification of hypersensitivity reactions, where type 1 hypersensitivity was believed to be triggered by cross-linking of surface immunoglobulin E, which are present on the surface of basophils and mast cells, and which leads to release of various histamines and vasoactive peptides which cause reactions. Followed by the second type, that is type 2 hypersensitivity, which is because of IgG mediated cytotoxic reactions, where IgG forms an immune complex, and this immune complex, which is present on the surface of a cell or an organ, and it causes activation of downstream immune system, whereby it can trigger the cytotoxic T cell responses. Type 3 is classical hypersensitivity that we know as type 3 or Arthur's type reactions, where a lot of immune complexes are formed because they are binding to the soluble antigens. And these immune complexes get deposited into the various porous capillaries of the body, including the joints, your brain and your synovium. And then the type 4 is basically a delayed type hypersensitivity, which was realized that once you have an exposure to an allergen or an antigen, it can cause immune reactions few hours to few weeks to few months later, and it is based on basically activation of T cells. However, it was realized that this does not explain the major mechanisms, and as my previous speaker, Dr. Hemant, has already shown, that asthma, which is believed to be based on type 1 hypersensitivity reactions, is not always type 1, and it is type 2 also, which is difficult to treat. So a new nomenclature was needed to describe diseases based on combination of their intrinsic biology and in addition to their typical signs and symptoms, but also should reflect the understanding of the etiology, the pathophysiological mechanisms which can be targeted for prevention, diagnosis or treatment. And also it should be flexible so that if we in future develop some new information, it can be incorporated in this newer classification, and it can help us in better understanding of the disease pathophysiology. So this European Academy of Allergy and Clinical Immunology actually tried to classify hypersensitivity reactions in 2001. They classified based on IgE mediated reactions or non-IgE mediated reactions, which involve typically T cells, and also non-allergic reactions that do not have the immune mechanisms involved. Now, this was a very new thing. Up till now, it was only based on the immune hypersensitivity reactions. But now they are also talking that non-immune mechanisms can also play a role in hypersensitivity, and I'll come to that in subsequent slides. In late 90s, Werner and the group actually proposed that delayed type hypersensitivity, which is based on T cell hyperreaction, is not of one type. It has many subtypes, or you can say as endotypes. Don't get confused with this word endotypes, because that doesn't mean anything specific except subtypes. And they classified into 4 subtypes: 4A, 4B, 4C, and 4D. 4A was basically like Th1 type of a T cell response. 4B was Th2 type of T cell response. 4C was based on cytotoxic T cell responses, and 4D was based on T cell responses like Th17, which causes stimulation of neutrophils in addition. Just to bring out the understanding of the T cell biology for the audience here, that naive T cells, when it is stimulated by antigen presenting cell, it can convert into these many subtypes: Th1, Th2, Th9, Th17, 22, T regulatory, or T follicular helper T cells. All these T cells are known to have a very specific function, a specific reaction, and they mediate adaptive immune response in a very specific way. And I will be coming to these cells subsequently in the subsequent slides. In addition to T cells, a new type of cells which were also realized to play a very important role in the hypersensitivity reactions is the innate lymphoid cells. And they were classified as type 1, type 2, and type 3 innate lymphoid cells. Type 1 innate lymphoid cells behave more like natural killer cells, and they secrete a lot of gamma interferon and TNF alpha. Whereas type 2 innate lymphoid cells secrete a lot of Th2 type of cytokines like IL-4, 5, 13. And type 3 innate lymphoid cells, they actually behave more like Th17 cells, where they secrete a lot of cytokines like IL-17, 22, 21, and cause activation of or stimulation of neutrophils. So the new nomenclature is based on the understanding of distinct characteristics and functions of type 1, type 2, and type 3 complex immune responses, which I will be narrating in very briefly here, and also not only immune responses but tissue driven responses also. This is the new thing which has come out in this newer classification. So what is a type 1 immune response? It is basically directed against intracellular pathogen like mycobacteria or viruses, and it comprises of activation of Th1 type of T cell, innate lymphoid cell type 1, natural killer cells, NKT cells, cytotoxic type T1 cells, and the various cytokine milieu is basically characterized by secretion of a lot of gamma interferon and TNF alpha. It also causes activation of macrophages and the neutrophils. Whereas type 2 immune response is characterized against large protozoal infections, poisons, and venoms. And it is comprised of Th2 cells, innate lymphoid type 2 cells, cytotoxic type 2 cells, and the responses are driven by immunoglobulin E. The major players here are also basophils and the mast cells, and the typical cytokines which are involved in the reactions are IL-4, 5, 9, 13. The type 3 immune response is characterized against extracellular bacteria and fungi, and these are characterized by activation of Th17 cells and cytotoxic 17 cells and innate lymphoid cells type 3. And with IL-17 as the major cytokine which is playing a role, and the neutrophils are the predominant cells which are playing a role here. So this is a new nomenclature of allergic diseases, where it was classified as antibody mediated, type 1, type 2, type 3, which remains almost similar to what was described by Gell and Coombs in 1963. And the cell mediated has been further subdivided into type 1, type 2 and type 3, or type 4A, type 4B and type 4C. And in addition, two newer classifications were brought in here. One is tissue driven mechanisms, and the last one is the direct response to the chemicals. I'll be touching upon these classifications subsequently. So now the definition of hypersensitivity, where it was initially only the immune response which is undesirable, has now also incorporated a damaging response that arises from a tissue cell dysfunction in addition to the immune system overreaction. And allergy is now defined as abnormal or exaggerated reaction to exogenous stimuli, which involves various types of hypersensitivity reactions, immune mediated, cell mediated, tissue driven or metabolic mechanisms, resulting in development of an organ system dysfunction and the manifestations. So let's look at what is type 1 hypersensitivity. Classically, we know this is driven by IgE. Yes, it is. And what are the common manifestations of these? Are allergic rhinitis or allergic rhinoconjunctivitis, asthma, dermatitis, acute urticaria, angioedema, allergies to food, venom or drug allergies. And these are the list of allergens which has been listed here. But actually type 1 hypersensitivity is comprised of two types of reactions. One is the sensitization phase and the other one is the effector phase. Sensitization phase is dependent on type 2 hypersensitivity reactions or Th2 cell mediated reactions as seen here. Once the allergen is getting exposed or the body is getting exposed to the allergens, the dendritic cells, which are the antigen presenting cells, they become activated and they lead to activation of type 2 cells, that is Th2 cells, which secrete a lot of IL-4, 5, and it also cause activation of follicular helper T cells, leading to a B cell activation, causing generation of IgE antibodies. Now once a load of IgE antibodies is generated, various mast cells and the basophils which has got Fc receptors for IgE, they bind to these IgE receptors. This is called as sensitization phase. On subsequent exposure to the same allergen afterwards, there is no need for dendritic cells to present the allergen to the immune cells. Because there are already IgE present on the surface of basophils and the mast cells, it causes their activation, leading to degranulation of the mast cells, leading to release of histamine and the various symptoms. The type 2 hypersensitivity reaction is basically characterized by a drug. Predominantly, the drug binds to a protein on the surface of a cell, and now this either drug antibody or a drug and this protein antibody, they cause activation of the various effector cells like complement mediated pathway or direct release of granules by eosinophils or activation through monocyte or neutrophils through phagocytosis pathway. Type 3 hypersensitivity reaction, the immune complex is formed. It is basically directed against soluble antigens. So once an immune complex is getting formed, the Fc portion of the immunoglobulin start exposing certain epitopes which were earlier covered because the antibody was not activated. Now these exposed sites of the Fc portion are the targets for Fc receptors of various phagocytic cells like neutrophils or monocyte macrophages, and they start engulfing these immune complexes and leads to activation and cause various kind of immune mediated damage. Type 4 is the cell mediated hypersensitivity reaction. Basically depends on the memory of the T cells, and I will be showing you subsequent types. The type 4A is basically a Th1 type of a immune reaction which is mediated by Th1 or cytotoxic type T1 cells, and it is characterized by high amount of gamma interferon, TNF alpha and lymphotoxin secretion, and there is a formation of granuloma. So this is how it is. The allergens, they start getting engulfed by the antigen presenting cell, that is dendritic cell, and these dendritic cells now bring it to the domain of naive cells, convert them into Th1 cells, and these Th1 cells secrete a lot of gamma interferon, leading to granuloma formation. Also causes activation of innate type 1 cells. They cause perpetuation of this inflammation because they secrete again lot of gamma interferon, leading to persistence of the type 1 or type 4A hypersensitivity reaction. Now, one interesting part is here that sometimes the patients of bronchial asthma who are having a phenotype of Th2 driven pathophysiological mechanisms, they can also convert into this type of a reaction. How? The Th2 cells, when they go into the periphery, they convert into Th1 cell and they start secreting a lot of gamma interferon and TNF alpha, leading to damage to the organ, especially the lung. Type 4B innate immune response is basically like Th2 type of immune response, which is characterized by secretion of lot of IL-4, 5 and Th2 cell activation, and also type 2 innate lymphoid cell activation. Type 4B hypersensitivity reactions overlap at a very final stage with IgE synthesis. So there is a sort of a combination of both type 4B as well as type 1 hypersensitivity reaction in some of the hypersensitivity mediated mechanisms. Type 4C is characterized by Th17 cell activation and also innate type 3 cells, and it is characterized by secretion of effector cytokines like IL-17, 21, 22 and GM-CSF. They cause activation of neutrophils, and neutrophilic infiltration is the hallmark of this type of hypersensitivity reactions. Neutrophils also secrete various extracellular traps which bring in more inflammation and can also lead to some of the microthrombotic episodes. So this classification has left room for other possible type 4 hypersensitivity reactions with the concept of pi concept, that some of the drugs can directly bind to the immune receptors or HLA molecules and can stimulate the cells. So, but they have not been able to classify them as such as of today, but they have left the room for possible classification in the future. Now, this is important, type 5, which is an epithelial barrier defect. Now, various pollutants which are there in the environment, when they come in contact with the epithelial cells, whether on the skin, our gut mucosa or the mucosal lining of the respiratory tract, they cause activation of the breakage of this epithelial barrier. And once this epithelial barrier is broken, they start releasing a lot of alarmins. Alarmins are nothing but the cytokines secreted by the epithelial cells, and these are IL-25, IL-33 and thymic stromal lymphopoietin, which Dr. Hemant was referring to in difficult to treat asthma cases. Also that there are antibodies against anti-TSLP which can be used in such cases. And these epithelial barrier breakage actually lead to activation of all these cells which has been listed here: macrophages, innate lymphoid cells, Th1, Th2 and Th17 cells. So there is a chance that you may have a lot of severe hypersensitivity reactions when these epithelial barriers are broken. Type 6 is important because this is a metabolic induced immune dysregulation. Not only the allergens but also certain short chain fatty acids, branch amino acids, they can also bring in immune dysregulation. And this has been realized that patients who are obese, their gut microbiota is different. So their gut microbes are secreting different type of proteins or branch fatty acids or amino acids, which can trigger the immune response and can lead to difficult to treat asthma. This is also one of the known causes for difficult to treat asthma. Type 7 reaction is basically a direct cellular and inflammatory response to chemical substances. Like we know that aspirin should not be given if somebody is allergic, because it can directly trigger the immune response. You don't need any sort of immune cell to become activated. As soon as aspirin is taken, it causes the inhibition of cyclooxygenase and also lead to disturbance in the icosanoid mediators in these individuals. So there is an imbalance in the metabolism of the arachidonic acid, leading to overproduction of cystenyl leukotrienes and a decrease in the anti-inflammatory prostaglandins, leading to sort of hypersensitivity reaction. So previously it was 4, now we have got 9 different type of hypersensitivity reactions as per this newer classification. And this gives a great insight into the pathophysiology of different mechanisms, which I have enumerated here. But for the sake of the time, I didn't go into the details of the immunological basis of these newer classification of hypersensitivity reactions. The last one is this novel G protein coupled receptor known as mass related GPCR, which has been described, and lot of drugs are known to bind to this GPCR and can cause activation of the cells and can lead to hypersensitivity reaction by causing an imbalance in the prostaglandins and arachidonic acid metabolites. So I conclude that this nomenclature is based on disease mechanism and endotypes rather than the typical phenotypes that we know of. It enhances our insight into the link between different allergic diseases, and we now realize that many different coexisting diseases can exist in the same individual. Endotype driven thinking can lead to development of new diagnostic tools and improved therapeutic strategies. And the major advantage of this immune response and tissue based allergy nomenclature is that we can move forward and we are open to newer suggestions as and when the new research emerges. Thank you.
Thank you, sir, for the enlightening talk. As you all know, sir has a nuanced way of teaching very complex stuff into simple language, and sir has incorporated a lot of immunology inside this. Like he has incorporated both immunology and the classification, and has brought it together. So, as far as I understand, I would like to underline that they brought in tissue dysfunction as also part of the classification of hypersensitivity reactions. It's quite complex, but they have incorporated a lot of mechanism-based subtypes of hypersensitivity, and that was a very enlightening talk. Thank you. Any questions? Anybody wants to?
Just want to add one line actually. See, the world is moving towards precision medicine. So not all asthma patients are the same. So this gives an insight. If you know the endotype of the patient, then you can certainly better treat this patient, better prognosticate this patient, and can develop better therapies in future. So that is the whole concept of this newer classification, which has come last year only. I think it was published in October 2023.
Thank you, sir. As I know that you have a busy OPD today,
Yeah.
So I thank you, sir. Thank you.
Thank you.
Thank you, sir. That was a wonderful presentation. I now request Professor Ved Prakash, sir, to kindly come on stage and felicitate our guest speakers and chairperson. Professor Vikas Agarwal, sir. Dr. Puneet Kumar, sir. Dr. Mukesh Maurya, sir. Dr. Abhilash Krishnan, sir. Thank you, everyone.
In words of John Harrison, the first thing you did at birth was inhale. The last thing you did at birth, the last thing you will do at death is exhale, and everything in between is life. And asthma, in real sense, is indeed a breathtaking experience. So, for our next breathtaking session, we have a very eminent speaker whom we all like and love to hear. And to introduce him for our next session, that is on assessment and monitoring of asthma, may I now request our chairpersons to please grace the stage and take their seats. Professor K.B. Gupta, sir, Head of Department Respiratory Medicine, Era Medical College. Ex-Director, PGI Rohtak. Dr. S.N. Gupta, sir, Director and Consultant Pulmonologist, Sanjeevani Super Speciality Hospital, Lucknow. Dr. Rajiv Garg, sir, Professor, Department of Respiratory Medicine, KGMU. Our next speaker will be joining us online.
Very good morning to everyone. First of all, thanks to Dr. Ved Prakash and his team for giving me this opportunity to chair this session. Now, next lecture is online, and the eminent speaker is Dr. Deepak Talwar. He will be speaking on the assessment and monitoring of the asthma. Dr. Talwar is DM in the pulmonary critical care from the PGI Chandigarh, and he is at present the senior consultant and chairman, Metro Respiratory Center and Respiratory and Sleep Medicine, this Noida, Delhi. He is the faculty member of the various national conferences such as the NEPCON, BronchoCon, so many things. And Dr. Talwar has this name featured in the Limca Book of the Records, and Dr. Talwar has various national, international, and research publication papers under his name. So, friends, enjoy the lecture online from Dr. Talwar.
Thank you, Dr. K.B. Gupta, sir, chairpersons. I must congratulate Dr. Ved Prakash for organizing the entire day devoted to World Asthma Day, and especially when the GINA 24 has arrived. I think it makes a lot of difference today to the lives of many people who are going to share the information, and I have become one of them. I'm sorry for not being there physically. I just actually came back last night only, very, very late, in fact, today morning. I'm going to talk about assessment and monitoring in asthma. So can you hear me and see my screen? Is it okay?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Okay. Thank you. Thank you, Rajiv. Thanks a lot. So now what we do first is that after making our diagnosis that this patient has asthma, we move on to the next step, and that is the treatment, obviously. And if you look at this track 1, track 2, GINA 23, and if you look at it, what is going on in 24, the new guidelines which has just been released, it's almost the same. The track 1 is actually not having step 1 and step 2, which has been combined. So mild asthma, then moderate asthma, and then severe asthma, which makes life much more simpler because it decides on the dose of inhaled corticosteroid from low dose to medium dose to high dose. And there are some little changes which have come up, and especially to one clear liner which comes is that you need to keep your dose of inhaled corticosteroid perhaps to the medium and try to not continue long-term high dose inhaled corticosteroid. So, and they have defined long-term is about 3 months. But the most important thing is that which are these patients in whom we have to choose track 1 or track 2. It's not just that where it is available. Is it the formoterol combinations available in a country or a salmeterol? But it's also on many other factors, which depends upon their assessments. And assessments is the first step which you need to do before you write the treatment. And that is something which we most of the times forget in very busy practice, because diagnosis of asthma is more of a clinical, supported by many other things. Once we have made up our mind, then obviously the next thing is to start the treatment. And this is the same as it has been done in the previously for the last almost 4 years with no significant change in GNAF. But in the assessments, the most important thing is that we rely on what the patient talks about, but what we observe about it. But the most important thing is that there is a discordance between what is asthma control as per the patient or as we decide from the physician's perspective. So this kind of assessments in asthma have been given three verticals, and it continues to be in GINA 24 also. The first vertical is to actually look for the asthma control. Second one is to look at the treatment related issues in an individual patient. And lastly is related to multimorbidities which invariably come up with a patient of asthma, which can be either pulmonary or extrapulmonary. So the issue about asthma control is assessment is that it needs to be more precise than just looking at the patient or listening to the patient. Because 50% of asthmatics continue to be uncontrolled and at the risk for future exacerbations, which is something which is detrimental not only to the patient's health, but also the future risk of exacerbations and early death in patients with asthma. So the symptoms, which generally are basically the central point for asthma control, are related to symptoms which occur during the daytime, symptoms which occur during the nocturnal, that is during the sleep, and nighttime, and also the activity which is limited as per what the patient talks about. And of course, very importantly, is the SABA use. Anyone who uses more than two or more than two times per week of SABA is practically not a controlled asthma. But there are two caveats to it. If patients are using SABAs before exercise and goes to exercise 3 times a week, that's not an uncontrolled asthma. That is exercise-induced asthma requiring SABA. Similarly, those patients who are on AIR, that is the anti-inflammatory reliever therapy. So if they use it more than 2 times, then you need to call it asthma uncontrolled is also not correct. So it is only actually relevant when you use salbutamol alone. And it is talking about past 4 weeks of control. So you look for these symptoms in how the patients have been faring in the last 4 weeks. It must be done on every visit, and it requires direct questioning. And also that some tools are available to us, which are some simple one like Gina has given, but more categorical or numerical scores are there. And generally numerical scores like ACT and ACQs are used in practice. This is one ACT control, and 19 and below are all numbers considered as asthma being uncontrolled. And anything which is 15 or below 15 is a very poorly controlled asthma. It's a 5-point test and again looks at the same things. But if you look at GINA 24 today, you will find that the past 4 weeks is not enough. In fact, you need to look at even a longer period of time and maybe extend it to the last 3 months rather than just 4 weeks, which is perhaps the change which has come in 2024. But more important than just asking about how are you today or you were in the last 4 weeks, it is very important to assess the patient about his future risk. And future risk is very important from the perspective that there are patients who are poor perceivers. They can have symptoms which are respiratory, but not because of the respiratory causes like asthma. The symptoms can be even controlled by sham treatments seen in various clinical trials, and symptoms can be overshadowed by anxiety and depression. So the symptom alone assessment is not good enough. Future risk of this patient is very important. And what are the future risk in asthma? Development of exacerbations in times to come, development of persistent airflow obstruction where FEV1 doesn't budge, doesn't become normal, and of course, medication related side effects. So future risk of exacerbations needs to be evaluated in each and every patient when we start the treatment for asthma. And we need to keep this in mind that we might keep them in a higher categories and treat them more aggressively if they are at future risk for exacerbation. So past exacerbation in last 1 year is the most important indicator of future risk of exacerbation. But equally important are poor adherence, inhaler technique, chronic sinusitis, and patients who continue to smoke and have asthma. But very important point that asthma, we do not talk about that we need spirometry for diagnosis. But a low FEV1 is a very strong predictor of future exacerbation. So if we find in spirometry that FEV1 is 60% or below, then that patient has got a red flag for a future risk for exacerbations and need to be treated more aggressively, even if his asthma control test tells us the numbers are like 2022. It doesn't matter because these patients need to be more aggressively treated from the future risk of more exacerbations, which are going to lead not only to more damage to the lungs, but also chances of increased morbidity as well as mortality. Now, other factors which are also risk for exacerbations are patients who use high SABAs and use low ICS, patients who are pregnant, have food allergies or multimorbidities, continuous exposure to allergen, pollution, or smoke, and of course, poor psychosocial support to the patient. And very importantly, type 2 inflammation. And if you look at GNOF 2024, you will find that type 2 inflammation has been highlighted a lot, that if you have an increased eosinophils, if you have a high FeNO levels, then again, this is a future risk for serious exacerbations in a patient who otherwise looks controlled in asthma. Any intubated or ICU admission in the last 1 year is enough reason to predict that this patient is not good and is may likely to have a serious exacerbation in future also. Another future risk is persistent airflow obstruction. Those patients after bronchodilator, FEV1 does not cross above 70%. 60% is where it becomes really serious. But we have lots of patients who do not cross even 70%. And these are the patients who have again a risk for the future asthma related permanent damage on the lung. Who are these patients? Those who show fast decline in lung function. That is why GINA recommends that you must do spirometry every year for these patients and try to identify those patients who have a faster decline in lung functions, because these patients are ultimately going to be respiratory cripples. Low birth weight, preterm babies, smoking and inhalational noxious injuries, chronic mucus hypersecretion, and patients who develop exacerbations and are not on inhaled corticosteroids are all factors which indicate that these patients are going to be at low lung functions, which is again a bad prognostic factor for the asthma assessments and the future control of asthma in these patients. Coming to the medication side effects, these are again the third factor, which is again going to indicate poor outcome for patients' asthma. And they are related to either incorrect technique like oral thrush or dysphonia, but very importantly, systemic features. And these are primarily those patients who are on higher dosages of inhaled corticosteroids or perhaps more potent inhaled corticosteroids. And these are easy bruisability, osteoporosis, fragility, cataracts, glaucoma, and adrenal suppression. But very importantly to remember, when we use the drugs which are going to inhibit P450, then they can increase the asthma therapy toxicities, particularly those patients who are on inhaled corticosteroids or LABAs. So in the short term, if you use the drugs like itraconazole, it increases the side effects of LABA, and it also increases the adrenal suppression because of interactions with the inhaled corticosteroids. So keep that in mind, that the drugs which we are giving to these patients, which are oral, can also have a significant effect on inhaled corticosteroids or LABA-related side effects. And then treatment issues. What is the GINA step? So as I told you in track 1 now, the GINA step 1 and 2 is 1. So at least it makes it a little simpler for us to look at mild, moderate, more moderately severe, and then finally the severe asthma. The adherence and technique is very important to check, and also whether the patient is being given asthma action plan or not. And very importantly, what are the attitudes and goals? And if you see that, although the Gina talks about education this time, but also talks about that attitudes and goals needs to be addressed, because they are ultimately going to be responsible for treatment adherence and compliance. The another factor which needs to be assessed is the morbidities, and rarely the asthma patients come with a single asthma, and they have many other comorbidities. And in fact, almost 99% of severe asthma has at least one comorbidity. And this is our data, which was published, which showed that a lot of them, actually 76%, have allergic rhinitis, And almost 35% of patients hypertension and diabetes coming up, which is related to the side effects of the disease. So there are pulmonary like rhinitis, rhinosinusitis, but equally important are extrapulmonary obesity, GERD, obstructive sleep apnea, and anxiety and depression in these patients. So lung functions in the assessment, where do they fare? Now you look at it that the lung functions are not strongly correlating with asthma control. So even if there are people who have poor lung functions, still they may be completely asymptomatic. But you need to do lung functions at the time of diagnosis or starting the treatment, after 3 to 6 months of starting inhaled corticosteroids, and then yearly, particularly to identify those patients who are at risk of rapid decline in lung functions with future of persistent airflow obstruction. And the important thing is that after the first test, you do not need to hold the medications prior to the the lung functions, which needs to be repeated periodically, like year-wise or maybe at 3 months to 6 months. And you need to do both pre as well as post. And this is personally very important because we need to mark the patient's best values. And how to interpret a PFT on a patient who are already on treatment for asthma, and we then tell them not to hold the treatment. So if they show at that point of time that there is a low FEV1, which is less than 60%, they are at risk for future exacerbations and a rapid lung function decline. If they come back with a normal FEV1, we need to really look at it whether they have symptoms or not. And what are those symptoms? Shortness of breath, look for cardiac causes and rule out deconditioning. If they have cough, then comorbidities like PNDS and GERD. But if you get reversibility, still a patient is on treatment and demonstrate reversibility on a lung function without holding the drugs, then it shows that either there is a compliance issue or this patient has got an uncontrolled asthma. How much improvement or deterioration is required to label it that it is significant? So 10% change in FEV1 is the threshold for betterment or worsening in patients on monitoring, which, as I said, that you need it initially at 3 to 6 months and then at 1 year. Coming lastly to the asthma severity. Now that only talk about two things, severe asthma and non-severe asthma. Severe asthma is step 5 asthma, which is a retrospective diagnosis of a patient of asthma who's uncontrolled despite using high dose ICS and LABA. But now also they are talking about medium dose ICS LABA plus LABA. Or the patient who is on ICS LABA high dose, but is controlled. And as soon as you want to decrease the ICS dose to medium, which is recommended in now in 2024, and the patient gets destabilized. That patient is also severe asthma and will require phenotypic and endotypic assessments to look for the targeted therapies. But very importantly, every severe asthma patients must go through 5 steps to confirm the diagnosis, whether it is asthma or not, because 50% of the patients will have actually difficult asthma, and then lots of them will not even have asthma. Almost 1/3 do not have asthma, but non-adherence, incorrect inhaler technique, ongoing exposures to triggers, and comorbidities are some of the very important aspects where the patient is labeled as difficult asthma because they are all controllable by appropriate diagnosis and appropriate treatments. So to highlight the key points of my lecture is that every patient of asthma, after the diagnosis is made, we need to have assessments and follow up as well as monitoring well planned for these patients to be kept in mind every time they visit. Lung functions have definitely fared much more in the practice at the moment, and the newer guidelines are now talking more about eosinophils and pheno in this group of patients to identify those patients who are going to be at future risk for exacerbations or persistent airflow obstruction, both being the bad factors for the asthma patients. Patient education is the most important aspect, but patients' perspectives, attitudes, and goals have to be equally incorporated when we talk about assessments of asthma, because that will help us to decide what is the kind of treatment. The GINA has very clearly in 24 accepted that they have given a broad guidelines to treat the patients at large. But when it comes to an individual patient, the most important thing is understanding your patient's needs, their attitudes, their goals, their preferences, and include all that when you write the treatment for asthma. With that, I would like to thank you all with a couple of take-home messages that now the asthma treatment is not only the symptom control, but future risk reductions, which is in the term of exacerbations, fixed airflow obstruction, or medication-related side effects. and very importantly, incorporate expectations and attitudes of the patient. Don't forget the multimorbidities which happens with asthma patients. And spirometry has now shown to have a pluripotent role in asthma, not only diagnosis but management also. And then severity assessment is always retrospective, and even mild asthma is now being called as a retrospective diagnosis, not the day one diagnosis. So there are a couple of things which are coming up that these labels should be used after you have known the patient for some time, on treatment, off treatment, where you can use these kind of terminologies. Education and asthma action plans need to be there and discussed with each and every asthmatics, which is still missing largely from our practice. Thank you, everyone. And thank you for patiently listening to me and allowing me to be online. Thank you. Thank you, everyone.
Thank you, sir, for enlightening us in a very precise and a very simplified manner what GINA 2024 has incorporated as far as asthma is concerned. And you very rightly said that we should not have any short-term objective. We should look for long-term objective, future risk of the patient also, because that is where most of these patients and most of the busy practitioners, they also fail miserably. And any questions or any doubt? Because Deepak Talwar, yes, Darshan has a question, sir. Mike.
I think somebody just repeat the question for me.
No, sir, he'll just come in front of you.
Okay. Okay. It's a pleasure to see Darshan and meet him. I met him at Dr.
It
S.N.
would have
Gupta's.
been, sir, it would have been, had you been here, sir, it would have been better for us.
Sir, good morning. Am I audible, sir?
Yes, you are very much audible, Darshan.
I am one of your ardent fans, sir. So, sir, just a simple query that as you told that lung functions are like not correlating well with the control of asthma. So, where do you see the place of impulse oscillometry in the control of asthma and diagnosis of asthma, sir?
Darshan, you always put me into a very difficult, tight spot. At the moment, I don't even expect that the impulse oscillometry will be doing anything as far as the monitoring of asthma is concerned. But thankfully, and helping us all, GINA 24 has actually incorporated cuff variant asthma with preserved spirometry, where they have asked actually to do a bronchoprovocation test rather than doing an oscillometry. So GINA has not reached at oscillometry, but small airway dysfunction with preserved spirometry, patient having symptoms, particularly cough, is the one which can be diagnosed by an impulse oscillometry. And that's where we actually can monitor them also. But by and large, I would again emphasize the same thing, that impulse oscillometry misses the target on the large airway obstruction. It picks up very well small airway obstruction, but you will find impulse oscillometry perfectly normal. That is, R20 is normal, and patient has got FEV1 over FVC ratio of something like 50%, FEV1 something like 60%, and still the R20 is normal. So, like, if we do only oscillometry, I don't think so it will give us the diagnosis. And very importantly, even though in the monitoring, it will miss that how the large airway and FEV1 is faring if we don't include spirometry into practice.
Thank you, sir.
Thank you, Darshan. Thanks a lot.
Any more questions? Sir, Dr. S.N. Gupta, sir.
Thank you, Dr. Deepak Talwar. Very happy to see you in the morning session, and I was a little bit late. I think as you always give a fantastic lecture, so today it was for the return of the asthma. See, what I want to just convey to my junior colleagues is that when we are managing the patient of bronchial asthma, I think we should always try to concentrate on the use of the inhaler therapy, because ultimately the result is based on the proper technique of the taking of the devices. So, and this is what have been taught by our seniors, Dr. Rajan Prasad and others, that whenever the patients comes to your OPD, in the follow-up event, we should try to see the technique. We should request the patient that you show the technique. And every time what we see in our clinical practice, that the patient commits some of the mistakes. Sometimes he takes it in the reverse way, sometimes. So I think that is the one thing which we should always keep in mind. And this is the message to our junior colleagues. As far as the assessment is concerned, I just want to add one thing, that see, all the pulmonologists who are going to start their practice, they should, first they should acquire a spirometer. And slowly they should try to acquire the pen and what the impedance oscillometry equipment if they want for the betterment of the assessment of the disease, as well as that also emphasizes the changes, the management part also. Yes, you have rightly said in the last that it does not detect, when the R20 is the normal, but you find the FE1, FEC ratios. So these are the things which ultimately leads to the upgradation of the management in the field of the bronchial asthma. Thank you so much.
Great comments. Thank you. Brilliant.
सर बस एक लास्ट क्वेश्चन आपसे, क्योंकि कोई और तो सर पूछ नहीं रहा है. सर, do you prefer to go for a glycopyrium reversibility test in those patients whom you would like to keep on a triple therapy, sir? Add on bronchodilator effect, just to see that? Because I have read few papers where these people are trying to say, because the guidelines always talk about the salbutamol reversibility test or other, but the glycopyrium say if we are using anticholinergics. Have you tried to see the add-on benefit of, say, doing the bronchodilator reversibility test?
So, Rajiv, actually, we are not using. Simple answer is that we are not using glycopyrium reversibility, right? But yes, if we do with salbutamol and we don't find like a good one, next time whenever the test will be done, it will be done with these ipratropium and salbutamol for that patient. Uh, there is no guidelines for that at all. We still go on with salbutamol. But the
अभी
question
नहीं.
is, it is a treatable trait. Bronchodilator is a treatable trait for bronchoconstriction. So if the patient responds to salbutamol or ipratropium or both of them or one of them, how does it matter actually, because you need to improve the patient's, the bronchoconstriction. So I personally, because now we are moving more towards the precise medicine, I think it is always worthwhile to look for it that can you do better. Now I think the Gina has spoken about Lama, a little lengthier one. I was trying to read early in the morning, but what they are saying about is that those patients who are more likely to respond to Lama, you should add first. And the smoker group is considered as the one in which they have mentioned that if the patient has been ex-smoker or patient is a current smoker asthmatic, then an anticholinergic, even with a medium dose or a low dose inhaled corticosteroid would be a good option for these patients. So I think they are going for a little triple therapy where they are trying to bring in Lama a little earlier, but they have only identified one subgroup, which is the smoker group, but they haven't mentioned about reversibility part for it. But I don't think so that we need to be determined by what Gina tells us. Our mind tells us if it is working, it is working. We should use it. We have used Aerocort for so many years and we are happy about it. We will be happy about using glycopyrium or any, for that matter, any anticholinergic, which if it brings better asthma control without increasing the dosages of inhaled corticosteroids, without giving oral corticosteroids to the patient, well and good. Why not? We don't have biologicals so cheap like them to give it for every patient.
Thank you, sir.
So thank you, Dr. Deepak, for a nice lecture. And I think this is a very precise manner, but a very good messages for the assessment and monitoring of the asthma. Thank you very much once again.
Thank you, Dr. K.V. Gupta. Thank you, everyone. Thank you, everyone. Thank you very much.
Thank you, Deepak Sattalwar sir, for that insightful presentation. And I now request Professor Ved Prakash sir to kindly come onto stage and felicitate our chairpersons. Professor K.B. Gupta sir. Dr. S. N. Gupta, sir. Professor Rajiv Garg, sir. जी सर.
Moving ahead towards our next session on asthma burden in India, may I request the chairpersons to please grace the stage. Dr. Suryakant Sir, past President TECAI and Head of Department of Respiratory Medicine, KGMU. Dr. R.A.S. Kushwaha Sir, Professor, Department of Respiratory Medicine, KGMU. Dr. Ashok Yadav Sir, ex-senior consultant pulmonologist, Balrampur Hospital. Dr. Rishabh Kakkar Sir, Assistant Professor, Department of Respiratory Medicine, Era Medical College.
So very good morning and congratulations to Dr. Ved Prakash and his team. Today is World Asthma Day and we celebrate the World Asthma Day on every first Tuesday of May every year. And today's World Asthma theme is that asthma education empowers the patient. So probably that is the reason why we are assembled here for disseminating the asthma education. And who is the better person for asthma education in this country than Dr. Viren Singh? Professor Viren Singh is a teacher and expert, I would say, mainly educator. He has so many innovations and strategies for teaching and for the medical education, especially in asthma. Currently, he is the director of Rajasthan Hospital and Asthma Bhavan, Jaipur. He has been professor and head of medicine department at SMS Medical College and also the medical superintendent of SMS Medical College, Jaipur. And he has been the president of Indian Chest Society. And he is the eminent faculty and researcher in the pulmonary medicine and has been awarded several awards, including the prestigious Dr. B.C. Roy National Award. So Dr. Viren Singh is known for his communication skills, academic skills, researcher skills, innovative skills, and moreover, is a wonderful personality. Sir, welcome to Lucknow and welcome to this event.
Thank you very much for your kind words, Professor Suryakant. Here are the numbers. Whatever Professor Suryakant said, and can you decode these numbers? Okay, I give you a clue that Dr. Deepak Talwar has delivered a lecture and these are related to that.
Asthma mortality, dear friends.
Excellent. Excellent. So Professor Suryakant deserves a great applause. Friends, one of my friends asked, "अरे यार 2-3 साल में कहाँ थे?" I said that I enjoyed my life during government sector, and in last couple of years I was busy. ASTHMA Bhavan, probably many of you know, and then a 350 bedded hospital in Jaipur. I was busy in the private sector. So friends, I will be talking the asthma burden in India. And what is shocking thing is that 43% of global death are in India. What are the causal factors? I'll discuss 5 aspects: undiagnosed asthma, untreated asthma, potentially harmful treatment, air pollution, treatment barriers. Then a bit about whether asthma prevalence is increasing or decreasing, and then can we reduce asthma death? Here you can see that these are the data. Just to simplify for your convenience, I put it in percentage. The Indian population is 18% of world, but asthma patients are 13%. So 13% of global burden of asthma are in India. But Delhi is just double, 27%, and death 43% in 2019 and 46% in 2021. Truly said by Dr. Suryakant that patient education is very important. And then right treatment is very important, as said by Dr. Deepak Talwar. The question which is mind-boggling is why every second person dying due to asthma is Indian. And this is right day because this is World Asthma Day. First and foremost causal factor is undiagnosed asthma. You will be surprised to know that for every one diagnosed patient, there are 3 undiagnosed patients in the society. And based on what? Based on Global Asthma Network study, which was carried in 1718, and Asthma Bhavan was the national coordinating center, and these were 9 centers. 1,27,309 subjects were enrolled, who were randomly selected, schools and their parents. The terminology was presence of wheeze in 12 months. Severe asthma was more than 4 attacks of wheeze or 1 per night awakening disturbance of sleep, wheeze affecting speech in 12 months. Doctor diagnosed asthma. Has this child ever had asthma? Was this child's asthma was confirmed by a doctor? Using these terminology, when current wheezers, it was found that in 6 to 7 year group, only 18% were diagnosed by a doctor. 25% and 23% in 13-14 and in adult groups. So almost making it that every diagnosed asthma patient in the society, we have 3 patients who are still wait for a diagnosis. Then now we have 2 groups. So one diagnosed asthma patient and other group is undiagnosed patient. And what type of treatment they are taking in real world scenario. Diagnosed asthma patient, it was found out that 30% were taking ICS in 6 to 7, 35% 13-14, 26% in adults group. So almost 1 in 3 to 4 were taking treatment, meaning by almost 70 to 75% were not taking ICS, even those who are diagnosed. And the other category who are undiagnosed. In undiagnosed situation is miserable. Almost 98% were not taking ICS. And what about regular and as needed therapy? Regular therapy was taken only by 2%. And that was true despite of the fact that almost 50% of this group were having severe asthma. And in severe asthma, less than 2.5% took regular ICS. Almost 97-98% were not taking regular ICS. As needed also, it was miserably low. In 6 to 7 and adults, it was 6%, while it was 13% in adolescents, 13 to 14 groups. And what type of treatment they were taking? Was it? We divided treatment into 4 categories. Either nebulizer SABA, which was most commonly used. Then beta agonist inhaled. Third most common were oral medication. And fourth in the ranking of use was ICS or ICS plus LABA. In this scenario, these 4 groups were used by Global Asthma Network study, and if we categorize them, then we can say that ABC, so these 3 out of the 4 categories which were most commonly used may harm without ICS. And ICS LABA daily, it is only taken by less than 10%. Friends, all over the world, the countries who are showing increased intake of ICS, they have shown decreased mortality. So increase use, decrease mortality. That is the law of thumb. That must be used. Unfortunately, we don't have that, and probably that is a major cause of high mortality, very high mortality in our country. Then the air pollution. In air pollution, if we talk, these are 2022 data, PM 2.5. In first 10 cities of the world, most polluted ranking, 6 are Indians. And this trend persists down also. As mentioned in the Lancet Planetary, the 89.9 microgram per cubic meter is the annual mean exposure of 0.2.5 in India. Means almost everyone is taking unhealthy air, forced to inhale an unhealthy air. And what is the safe limit? WHO prescribed 10 microgram. America it is 12. Europe it is 25, India it is 40 microgram. Does it mean that Indian lungs are stronger? I don't know. I don't know on basis of what they have put these. And it has been projected by iForest analysis that PM 2.5 2022 5.2 metric ton is generated all over India, and 48% is biomass burning in kitchens. The rest in other things. In biomass burning, one thing is magnitude, other is that it is inefficient burning. Inefficient burning leads to more smoke and more harm. Then there are treatment barriers. Treatment barriers. Long back we carried out a study and asking patients of asthma can your asthma be cured forever? Only 15% said that it can't be cured, it can be controlled. But 85% were hopeful that it is controllable, it is curable. Why it is so? From where the notion of cure comes? Notion of cure comes from alternative medicine. Almost 1 lakh of people gathered in the month of June to cure asthma by fish therapy. And then, when a person takes treatment, a universal question of every patient of asthma is, Doksa, within how much time you will cure my asthma? And if the treating doctor is academician like Dr. Bera, he will say no and never. Believe me, while he is going out, yaar doctor sahab to gadbad aa gaye. If he comes to a clinician like me, I'll evade direct reply and say, how old are you? Then he'll say, doctor gera hai yaar iske paas hai. He will keep on coming 2-3 times to me, ultimately realizes that he doesn't have a magic. So he lends to this gentleman. And this gentleman, when he asks to the same question, he will say, not only you, even your progeny will never suffer from asthma. And he will name 5 or 7 persons of the city, prominent persons, that I have cured asthma in them. Ultimately, so the notion of cure comes from that place. In the same study we asked, when you stop medicine, 91% said that when it is not symptomatic or when they are able to tolerate symptom, they stop medicine. But only 9% said that as per advice of a doctor, we stop medicine. Even this is a case report published in New England Journal of an Indian. Then the lady said that I thought asthma is a stigma. So instead of saying asthma, I told that I am suffering from typhoid. Then inhaler is a strong medicine, so I don't take. Then treatment cost and notion of cure. Yet another barrier is wrong terminology. In this study we found out that when we interacted with almost 547 asthmatic patients and asked what is name of your disease, only 23% said it is asthma. Rest of them said something else. It is SARS, cough, dama, etc. But friends, if they will say cough, then they are not going to take treatment. When they will say some other name, they are not going to take treatment. So most important thing is speak asthma to defeat asthma. My question to you is whether asthma is increasing or decreasing. Those who say increasing, raise your hands. Those who say decreasing, raise your hands. None. So, Global Asthma Network studies, only GAN study has been carried out in the last 20 years, 3 times, in 1991, 2003 and 2018. So, it was the uniform methodology, and here you can see the green line, it was 6%, 5.8% and 3%. So it has decreased, and same is in the 6 to 7 year group. I don't have any explanation. Despite of a popular notion that asthma is increasing, in studies it has been shown that it is decreasing. We need further studies to find out the exact mechanism. Friends, can we reduce, coming back to our original question, can we reduce asthma mortality? Yes, everyone sitting here can contribute in reduction of mortality. How? One, at the patient level, if we educate them. We don't have a word, terminology in Hindi. But if we just communicate wheeze, I communicate to my patient कि भाई wheeze है, wheeze बोलो, तो बोले हाँ wheeze बोल लिया. तो मैंने कहा ये फेफड़े की रोने की आवाज है. तो फेफड़े की रोने की आवाज है means that is wheeze. So at least those 75% of the patient who remain undiagnosed can be diagnosed if we educate them in this way. Second thing, at doctor level, what to do? Once we diagnose asthma, we should speak asthma to defeat asthma. Dr. Suryakant is doing lot of public education work, and so if speak asthma, defeat asthma. But still problems comes. 10-year child come to Dr. Ved and वो देख लिया कि डायग्नोज तो एस्थमा हो गया, बट देखा कि माँ का चेहरा बिल्कुल मुरझाया हुआ है कि अभी आंसू आ जाएगा, तो ये करेज नहीं कर पाते कि अरे मैं कैसे कह दूं एस्थमा है. तो हाँ हाँ एस्थमा जैसा लग रहा है, एस्थमा कहते कहते मुंह से वर्ड निकले एस्थमा जैसा लग रहा है, अभी हो जाएगा ठीक. सो माय मैसेज इज दैट डरो नहीं, टेल द पेशेंट कि एस्थमा है. उस टाइम तो आंसू आएंगे, मदर के तो आएंगे ही आएंगे, फादर के भी आ सकते हैं, बट दैट विल बी रिवार्डिंग इन लॉन्ग टर्म बेसिस. सो फ्रेंड्स, in the last of my concluding my talk, first and foremost thing to reduce asthma death is suspect more, to diagnose 75% of undiagnosed hidden asthma. No wheeze, weeping sound of lungs. Need more useful treatment, ICS, regularly or as needed, as suggested by Zina. Use SABA, nebulizer and oral treatment as add-on therapy only. We should use as add-on therapy. Need of a study to find out the factors of declining prevalence. Stop asthma is curable notion, and mass level patient education program we are organizing regularly, and you can see it is Birla Auditorium, and almost 1500 asthmatic patients participated on this 28th January. So it was. So thank you very much, and I compliment and congratulate Dr. Ved for organizing wonderful conference and inviting me. Thank you.
So, sir has very well depicted this data that how big gap in the knowledge of the society, even in the doctors. जैसे सर ने अभी दिखाया कि केवल साबा लिखा जा रहा है, तो डॉक्टर लोग ही तो लिख रहे हैं और क्यों मरीज ले रहा है. तो डॉक्टर्स के बीच में भी अवेयरनेस की ज़रूरत है. जैसे इस बार का जो थीम है एस्थमा एजुकेशन एम्पावर्स, दमा शिक्षा सशक्तिकरण, कितना सही है, क्योंकि गैप बहुत है इसमें, नॉलेज गैप बहुत है. इवन लीडिंग डॉक्टर्स के भी मरीजों को जब आप देखेंगे तो उनमें जैसे इनहेलर की टेक्निक गड़बड़ है, कहीं वो गलत सलत ले रहा होता है, तो देयर आर सो मेनी रीजन्स. सो एस्थमा एजुकेशन मरीजों को स्ट्रांगली, जैसा अभी सर ने बताया कि एस्थमा की अगर डायग्नोसिस बन रही है तो स्ट्रांगली हमें मरीजों को बताना है, उससे छुपाना नहीं है. तो स्पीक एस्थमा, ट्रीट एस्थमा एंड डिफीट एस्थमा. तो सर का ये जो नारा है बहुत ही समसामयिक है, इसे हमें हमेशा अपने मरीजों को बताना है, ज़रूरी है. और मैं आप लोग अगर क्वेश्चन पूछना चाहें सर इन्वाइट करिए.
डॉक्टर सिंह साहब, आपने बहुत तथ्यात्मक तरीके से हिंदुस्तान में ख़ासतौर से अस्थमा की जो वस्तुस्थिति है उसके बारे में बताया, आपने दो बातें खास तौर से कही कि एक तो अस्थमा की प्रेवलेंस कम हो रही है, दूसरा आपने कहा कि 85% लोग ये मानते हैं कि अस्थमा क्योरेबल डिजीज है। ये दो महत्वपूर्ण बातें हैं। तो अगर ये प्रेवलेंस कम हो रही है अस्थमा की, तो क्या इसके पीछे कहीं पहले ओवर डायग्नोज स्थिति तो नहीं रही कि हमने ज़्यादा उनको डायग्नोज कर रखा था, या अब हमने अंडर डायग्नोज किया है? एक तो प्रश्न ये। दूसरा, अगर 85% लोग ये मानते हैं कि अस्थमा ठीक हो जाएगा, क्योर हो जाएगा, तो ये गंभीर स्थिति है हिंदुस्तान जैसे देश के लिए। इसको केवल चेस्ट फिजिशियन, जो क्वालिफाइड चेस्ट फिजिशियन हैं या फिजिशियन हैं, वो इससे निपटने में सहायक नहीं हो सकते। तो उसके क्या अल्टरनेटिव हो सकते हैं? ये दो बातें मैं आपके सामने रख रहा हूं।
बहुत सुंदर। देखिए, जो क्योरेबल का जो नोशन है, वो नोशन ऑल्टरनेटिव मेडिसिन के डॉक्टर से आता है, वन, और उसको सपोर्ट मिलता है बिकॉज एस्थमा, ऑलमोस्ट हाफ ऑफ चिल्ड्रन इन एस्थमा गोज इनटू रेमिशन. It may be 5 years, it may be 10 years, it may be 15 years, or it may be lifelong remission. So उससे वो चीज़ बलवती हो जाती है जो उनका नोशन है. इसके अंदर किया क्या जाए? इसके अंदर करने का ये कि मास पेशेंट एजुकेशन, 1-to-1 के अंदर कई बार काम नहीं करती ये चीज़, लेकिन 10 आदमी बैठे होंगे या 20 आदमी बैठे होंगे, देन वो एक कहेगा हाँ साहब मेरे बचपन में था, 15 साल ठीक रहा, अब फिर होने लग गया. तो उनको ये रहेगा कि एस्थमा इज ए जेनेटिक टेंडेंसी विच मैं उनको इस तरह समझाता हूँ कि भाई ये कुंभकर्णी नींद में से चला जाता है, सो जाती है, कुंभकर्णी नींद में आ जाती है, फिर वो कुंभकर्ण की नींद टूट जाती है, जग जाता है, तो फिर एस्थमा होने लगता है. तो आप अपनी जो एहतियात है वो बराबर बरतें. और फर्स्ट क्वेश्चन आपका, मतलब आपने इतना सुंदर बोला कि मैं तो भूल गया. पहला क्वेश्चन एक बार रिमाइंड.
दूसरा ये जो आपने कहा,
हाँ, ओवर डायग्नोसिस आप सही कह रहे हैं कि हो सकता है, बट प्रोबेबिलिटी इज वेरी लो बिकॉज इन दिस गैन स्टडी इट हैज बीन शोन दैट 75% रिमेन अनडायग्नोज्ड इवन टुडे. सो वो मुश्किल है. हालांकि ये एक बात और है कि कहीं ऐसा तो नहीं एस्थमा इज टेकिंग डिफरेंट टाइप ऑफ फिनोटाइप, भाई वो कहीं खांसी तो नहीं हो रही ज़्यादा, कहीं कोई और दूसरी तरीके की स्नीजिंग तो नहीं हो रही, राइनाइटिस तो नहीं हो रही, क्योंकि जो मिल्यू है, एनवायरनमेंट इज चेंजिंग. इतना पोल्यूशन नहीं था, पोल्यूशन बढ़ गया.
लेकिन इसमें ये बात जब 85% लोग मानते हैं कि हम ठीक हो जाएंगे, ऐसी हालत में हिंदुस्तान में ये कहना कि प्रिवलेंस घट जाएगी, केसेस घट जाएंगे, ये बड़ा विरोधाभासी
वो गैलीलियो वाली बात है.
और डॉक्टर साहब आपने कहा कि हमें पब्लिक अवेयरनेस करना चाहिए, लेकिन मैं समझता हूं कि अकेले ये संभव नहीं है आपके प्रयास से, जब तक लीगल फ्रेमवर्क में हम इसको नहीं लाएंगे और जो सरकारें हैं वो ये सुनिश्चित नहीं करेंगे कि कोई भी कुछ भी क्लेम ना कर दे. और मैं समझता हूं कि अभी पिछले दिनों माननीय सुप्रीम कोर्ट ने एक बड़ा इंस्टेंस सामने रखा है कि कोई भी कुछ भी क्लेम ना करे, कोई भी जो वास्तविक नहीं है उसको अपने स्वार्थों के निहित स्वार्थों के लिए उसको बढ़ावा ना दे. जब तक ये लीगल फ्रेमवर्क में काम नहीं होगा तो इस समस्या का हल नहीं होगा.
100% एग्रीड विद यू.
और आपकी जितनी भी एफर्ट हैं वो सब व्यर्थ हो जाएंगे.
बिल्कुल.
Thank you, sir. As usual, it was a delight to listen to you. I think not even a single person would be there who was not interested in listening to you.
Thank you.
It was a very engaging lecture. Now I would request the audience to, if they have any questions. Thank you so much, sir.
Thank you, sir. That was a wonderful presentation. Now I request Professor Ved Prakash, sir, to kindly come on stage and felicitate our guest speaker and chairpersons. I request Professor Digambar Behra, sir, to please come on stage and felicitate our guest speakers and chairperson. Professor Viren Singh, sir. Professor Suryakant, sir. Dr. Ashok Kumar, sir. Dr. R.A.S. Kushwaha, sir. Dr. Rishabh Kakkar, sir.
For our next session, our next topic, which is not very uncommon but relatively commonly misdiagnosed and undiagnosed, ABPA current diagnostic strategy and management. May I request the chairpersons to please come onto stage and take their seats. Professor P.C. Kathuria, sir, Senior Consultant, Department of Allergy and Asthma, BLK Super Speciality Hospital and National Allergy Center, New Delhi. Professor S.C. Chaudhary, sir, Professor, Department of Medicine, KGMU. Dr. Prasanta A.P., Assistant Professor, Department of Pulmonary Medicine, Sanjay Gandhi PGI. I would request the chair to kindly introduce our next speaker and please take over the session. Thank you.
So, good morning, everyone. Now we moved on to the last lecture of the first session by Dr. Ved Prakash. He is a professor and head Department of Pulmonary and Critical Care Medicine, KGMU, Lucknow. He is the organizing secretary of this Asthma Allergy Conclave. He has been awarded with Young Achiever Awards and UP Ratan Awards by the government of Uttar Pradesh. He has published more than 70 papers in various national and international journals. His main area of interest are lung cancer, critical care, and interventional pulmonology. He will be delivering on ABPA, current diagnostic strategy and management. I request Dr. Ved Prakash to deliver his lecture.
Thank you, chairpersons, for your kind words. So, ये कहाँ है? This is the pointer. Pointer. ये pointer. ये slide है. Okay. So, thank you, chairpersons. I would be talking about ABPA, diagnostic strategy and management. Teacher of teachers, Professor Rajendra Prasad, who taught us and the journey from TB department to TB and chest, then TB and chest to pulmonary medicine, and then respiratory medicine and pulmonary and critical care medicine. So I can say Sir has been in the dreams regarding the DM program at King George's Medical University at the time when I was doing MD. So this was the dream, and he is continuously guiding us. So tribute to our teacher and teachers, teacher of teachers, and our mentor. So we introduced like allergic bronchopulmonary mycosis are complex pulmonary disorders caused by immune reactions mounted against fungus, and most commonly it is Aspergillus fumigatus. And conventionally the term ABPA is used when the causative pathogen is Aspergillus fumigatus. So allergic bronchopulmonary mycosis is an ABPA-like syndrome caused by fungus other than Aspergillus fumigatus, and the earlier identification and treatment of ABPA is crucial to prevent the progression of bronchiectasis, and ABPA responds well to the treatment. So we can prevent the further complications of ABPA. So we see the prevalence of ABPA among the patient with having the history of asthma, that is persistent asthma, is estimated to 1 to 2%, although rates up to 28% have also been reported in some areas. And among patients with cystic fibrosis, the reported prevalence ranges from 2 to 9%. In cystic fibrosis patients, ABPA may present with worsening symptoms or lung function that is not responsive to usual antibiotic treatments. Characteristically, individuals with ABPA present with respiratory symptoms including poorly controlled asthma, wheeze, hemoptysis, productive cough, and as well as the systemic symptoms like fever, weight loss can suffer, and the recurrent exacerbations. So the transient and fleeting pulmonary opacities and bronchiectasis are the hallmark for the radiological presentation of ABPA. In certain cases, ABPA may develop into chronic pulmonary aspergillosis, and end-stage disease is bicorpulmonale and type 2 respiratory failure. So this is the revised International Society for Human and Animal Mycology and ABPA working group consensus criteria for diagnosing ABPA has been changed. Earlier, the predisposing conditions were asthma and cystic fibrosis, and now in 2024, the chronic obstructive lung diseases and bronchiectasis are also been included, or the other criteria are compatible clinico-radiological presentation, expectoration of mucus plugs, glove finger, and fleeting opacities on chest radiograph, and lung collapse and other features. So the essential components for diagnosis of ABPA is the Aspergillus fumigatus specific IgE, that is need to be positive, that is more than 0.35, and serum total IgE more than 500, and other criteria also has to be fulfilled, like 2 of any other, like positive IgE against Aspergillus fumigatus and blood eosinophil count more than 500 cells, and thin section chest CT consistent with ABPA, having bronchiectasis, mucus plugging, or high attenuation mucus, HAM, and or the fleeting opacities on chest radiograph consistent with ABPA. So these are the criteria, and there are some other important considerations. Serum total IgE, if the criteria met and the serum total IgE is less than 500 also, then that may also be acceptable if all other criteria are fulfilled. And there are some important considerations also. A positive type 1 skin test is acceptable with Aspergillus IgE if unavailable, and Aspergillus fumigatus specific IgG can be detected using lateral flow assay or enzyme immunoassay, and high attenuation mucus, that is HAM, is pathognomic of ABPA and confirms ABPA diagnosis even if all other criteria are not fulfilled. And elevated IgE levels against F1, F2, F4 supports of diagnosis of ABPA and could be used as another component for diagnosing ABPA. While investigating a patient with asthma, we first perform Aspergillus fumigatus specific IgE. If it is more than 0.35, the serum total IgE levels are assayed. If the serum total IgE is greater than 500, the other tests are performed, including a thin section CT of thorax and Aspergillus fumigatus specific IgG and peripheral blood eosinophil count. Patient of ABPA without bronchiectasis on CT chest are labeled as serological. So that is ABPA S, that is serological ABPA, while those with bronchiectasis and HAM are classified as ABPA B and ABPA HAM. And ABPA MP includes patients with non-hyperattenuating mucus plugs, patient with bronchiectasis and mucus plugging are labeled as ABPA MP. Other radiological findings frequently observed in ABPA include centilobular nodules with a tree inward appearance, atelectasis, mosaic attenuation, and consolidation. So these are the predisposing factors and criteria for diagnosing the different types of ABPA. The revised International Society for Human and Animal Mycology ABPA Working Group recommendations for clinical classification. A newly diagnosed ABPA-AM refers to patients meeting the diagnostic criteria for allergic bronchopulmonary aspergillosis or mycosis for the first time, and the exacerbation in diagnosed ABPA-AM patients occur when a patient with previously diagnosed ABPA-AM experiences a worsening of their condition. So this is the exacerbation can be characterized by sustained clinical worsening lasting over 14 days. Then radiological deterioration is also noted, and a significant increase in serum total IgA levels by at least 50% from the last recorded value during the clinical stability. And the asthma exacerbation refers to a worsening of respiratory symptoms lasting at least 48 hours in patients with asthma. Without concurrent immunological or radiological deterioration of ABPA-AM, infective bronchiectasis exacerbation reports a clinical deterioration lasting at least 48 hours in a patient with underlying bronchiectasis or respiratory infections without immunological or radiological deterioration of ABPA-AM. So this is another latest classification, and the revised International Society also have the recommendation for clinical classification like response, remission, treatment dependent ABPA, advanced ABPA. So response criteria, when the patient are considered to have responded to treatment if they experience symptomatic improvement of at least 50% on a like or visual analog, Likert or visual analog scale after 8 weeks. Additionally, major radiological improvement, that is more than 50% reduction in radiological opacities, or a decline in serum total IgE by at least 20% after 8 weeks is required. And for the remission criteria, the remission is defined as sustained more than 6 months clinico-radiological improvement achieved without the use of glucocorticoids. Additionally, there should be no significant rise in serum total IgE and more than 50% increase from the last recorded IgE values during the clinical stability. So this is the another criteria, and the treatment dependent ABPA criteria defined by 2 or more consecutive ABPA-AM exacerbations occurring within 3 months of discontinuing glucocorticoid therapy, alternatively worsening respiratory symptoms along with deteriorating imaging finding, or a 50% increase in serum total IgE levels within 4 weeks of tapering oral steroids on 2 separate occasions. So this is treatment dependent ABPA, and then advanced ABPA. Advanced ABPA is characterized by extensive bronchiectasis involving at least 10 segments. So 10 segments are involved, more than 10 segments. The lung attributed to ABPA-AM on chest imaging, presence of complications such as cor pulmonale, that is the right-sided heart failure secondary to lung diseases, or chronic type 2 respiratory failure, that is respiratory failure due to inadequate gaseous exchange in the lungs. So this is the recommendation for clinical classification, and this is the radiological classification of ABPA-M. That is, one is ABPA-S, that is serologic, ABPA without bronchiectasis, diagnosed based on serological markers such as elevated IgE levels and positive Aspergillus specific IgE or IgG, ABPA with bronchiectasis, that is ABPA-B, ABPA accompanied by bronchiectasis characterized by dilated and inflamed bronchial tubes. On imaging studies, ABPA with radiological evidence of bronchiectasis, ABPA that is with the confirmed bronchiectasis observed on radiological imaging. Then ABPA with mucus plugging, that is ABPA-MP. ABPA with evidence of mucus plugging in the airway, potentially leading to obstruction and respiratory symptoms. ABPA then with high attenuation mucus, that is HAM. ABPA-HAM, ABPA that is characterized by the presence of mucus with high attenuation on imaging studies, indicating the presence of fungal elements. ABPA with chronic pulmonary fibrosis, that is CPF. In this CPF, ABPA associated with chronic changes in the lungs and pleura, including fibrosis, fibrocavitary lesions, fungal ball formation and pleural thickening. So these are the radiological criteria. Having this is the serological. This is ABPA-S having only serology. This is having the bronchiectasis, having ABPA-B, and this is ABPA mucus plugging. So we can see the mucus plugging, and this is HAM. So we can very well see the density of muscles, and this is more dense than the muscle. So this is the HAM. And ABPA CPF and ABPA CPF. So these are the radiological types, and we come on the treatment of ABPA with a level of evidence based on key studies derived from well-controlled randomized controlled trials, RCTs or meta-analysis of well-controlled conducted studies, level of evidence that is level 1 evidence, having the oral glucocorticoids are the most rapid acting treatment for acute ABPA. And the level 2 evidence, 2 is obtained from prospective observational studies or RCTs with a small sample size or high risk of bias. So this is the level 2, having the oral itraconazole or voriconazole have similar efficacy as systemic glucocorticoids in acute ABPA with fewer adverse events. And the oral itraconazole have steroid sparing action in treatment dependent ABPA. So these are the level of evidences regarding the treatment. And the level 2 also have the high dose inhaled steroid do not achieve symptom control or reduce ABPA exacerbations when used as a primary therapy for acute ABPA. Omalizumab reduce asthma exacerbations and has steroid sparing action in treatment dependent ABPA. So these are all level 2 evidences. So identify and exclude any potential environmental source responsible for ABPA. So this should be the goal of treatment, control of asthma and acute stage of ABPA, mitigate the onset or progression of bronchiectasis, a marker of end stage lung disease and chronic pulmonary aspergillosis, and with minimal or no adverse reactions related to treatment. So we have to identify and exclude any potential environmental source responsible for ABPA. And this is the chart of common drugs available for ABPA, that is steroids, azoles, and new treatment options like anti-IgE and anti-IL-5 antibodies. We have this mepolizumab, regilimumab, and bevacizumab. So these are the newer treatment options for ABPA treatment. And these are the other modalities like nebulized amphotericin B, inhaled corticosteroids, and newer modalities we have the biologicals like omalizumab, mepolizumab, benralizumab, and tezepelumab. So these are the options. And systemic glucocorticoids. Any of these two regimens have low dose steroid can be used for acute ABPA proposed in latest ISAM ABPA treatment guidelines with the dose of prednisolone 0.5 mg per kg for 2 weeks followed by 0.5 mg per kg for taper by 5 mg every 2 weeks and discontinue over 3 to 5 months. So alternate day for 8 weeks then can be used, or 0.5, 0.25 and 0.125 mg per kg per day for 4 weeks each, then taper by 5 mg every 2 weeks till discontinuation. So this is the dosing of steroids. And oral antifungal triazoles, especially itraconazole, have similar effect as glucocorticoids, but a slower trajectory to improvement and a better safety profile than corticosteroids. So these are the antifungal elements. Itraconazole 400 mg per day in 2 divided doses for 4 months, then maximum dose of 600 mg per day. It should be administered with meals to improve absorption. Then therapeutic drug monitoring should be performed through, if we are giving itraconazole, there should be the monitoring of drug levels that should be more than 0.5 mg per liter, and oral itraconazole is recommended as the initial therapy when systemic steroids are contraindicated. So these are the options, and this is the stage-wise management of patient with ABPA-AM. That is the management of acute allergic bronchopulmonary aspergillosis, primarily involve systemic corticosteroids with dosing protocols, detecting treatment, efficacy and safety. RCT comprising low dose prednisolone of 0.5 mg per kg per day versus high dose prednisolone 0.75 and 0.5 mg per kg per day regimen showed similar rates of ABPA exacerbation with the lower dose associated with fewer adverse events. Oral antifungal triazoles, notably itraconazole, offers a comparable efficacy to glucocorticoids but with a slower response trajectory and a superior safety profile. Biologic agents are not recommended as first-line therapy for ABPA, and adjunctive vitamin D supplementation has shown no benefit in management. And treatment decisions should be tailored to individual patient need with close oral corticosteroid dose, then sputum eosinophil count and ABPA exacerbations. A significant limitation was that neither study reported outcomes beyond 8 months regarding ABPA exacerbation. So long-term itraconazole, nebulized M4B or biologicals agents are recommended options for managing treatment-dependent ABPA. So this is the stage-wise management strategy for the patient of ABPA-M, with the remission may be achieved on antifungal azoles or biological agents or spontaneous after therapy. So this is the, and environmental control is also very important aspect of ABPA management. Being clinician dealing with drugs and inhalers, we often overlook these things which are very important, like minimizing activity that could result in the inhalation of large number of Aspergillus candida, common mold found in various environmental including soil, decaying vegetables, vegetation, and indoor environment, and the surgical mask or the more effective N95 respirators may minimize the spores. So this can be used with the regular cleaning and maintenance of heating, ventilation, and air conditioning systems. So this is the very much common cause and often overlooked, and the systems may prevent mold growth. So we should also explore in these places, and ensuring proper ventilation in bathrooms, kitchens, and other areas prone to moisture accumulating may prevent mold growth. So these are the some environmental control needed to be done. So thank you. Thank you for patient listening.
Full explanation on ABPA from the update classification, radiological, and the update treatment. Any question from the floor? It is immunological reaction. This is the fumigated allergen has got 45 components, and some of these components they only induce hypersensitivity reaction, and some of the induce not only the type 1 and type 2 reaction. Any questions?
Excellent presentation, sir, for explaining in great detail. Thing is, ABPA, especially in tertiary care centers, among adult patients, we have to actively look for ABPA, and in children who is having severe uncontrolled asthma, we have to look for ABPA. And rest everything, sir, has explained in great detail. Thanks.
Thank you once again.
Thank you, sir, for that very detailed and exhaustive presentation. May I now request, I welcome Professor Rajendra Prasad, sir. May I now request Professor Rajendra Prasad, sir, to please come on to stage and felicitate our speaker and chairperson. I also request Professor D. Behra, sir, to please come on to stage. Our speaker, Professor Ved Prakash, sir. Professor P.C. Kathuria, sir. Professor S.C. Chaudhary, sir. Dr. Prashanta.
This brings down the curtain for our first session. In our next session, we'll be learning about Introduction to Allergy and Immunotherapy. The first talk we have is Allergic Diseases in India, and for that may I request the chairpersons to please grace the stage. Professor V.K. Jain Sir, Department of Respiratory Medicine, MG Medical College, Jaipur. Dr. Rajesh Sharma Sir, Assistant Professor, Department of Respiratory Medicine, ERA Medical College. Dr. Darshan Bajaj Sir, Additional Professor, Department of Respiratory Medicine, KGMU. I now request the chair to kindly introduce our speaker and take over the session.
So we thank you very much for inviting us as the chairpersons for this second scientific session on introduction of allergy and immunotherapy. The first speaker is none very stalwart in the field of pulmonary medicine, Professor Padma Shri Dr. D. Behra. I invite him to on dais to kindly come over, sir, for your talk. The talk is very important, the allergic diseases in India and overview. It is my pleasure to introduce Dr. Behra. He is Padma Shri. He is also the Emeritus Professor, ex-professor and HOD of Pulmonary Medicine Department, PGI Chandigarh, Director Pulmonary Medicine, Fortis Healthcare, Mohali, and he is elect President of National Academy of Medical Sciences. He is also the ex-Director of NITRD in New Delhi, and I think he is having more than 4 decades experience, not only the clinical practice, but also as a teacher. And I know him when we both were in the convocation aims in 85 or 86, when we awarded the fellowship, DNB degree in the convocation, professor. That time I know we had an introduction very well, Dr. Behra. Since then we are colleagues also. So Dr. Behra, kindly please talk for your talk. Thank you.
So thank you, sir, for the kind words and a very, I think it is already afternoon, I don't know. Yes, not yet afternoon, so very good morning to everybody. So during the next few minutes, I will just give you a broad overview about the epidemiology of allergic diseases in India. Out of all these allergic diseases, of course, bronchial asthma is the possibly more common, and people possibly wrongly think that that is the only allergic disease and that is most important, and all our attention, teaching and everything is focused on that. We forget about the other allergic diseases. So anyway, and then Professor Virender Singh has given an outstanding and excellent broad overview about bronchial asthma. So what I'll do, I'll just skip about the issue of bronchial asthma because that is already being covered. So I'll go into the other allergic diseases as we see in India, and vis-a-vis what is happening in other countries, what is the global scenario. I'll try to cover some of those aspects. The allergic diseases, particularly asthma and atopic dermatitis and other types of allergies, they are now recognized as major public health problems, and they have greatly impacted the low and middle income countries.
as well as the high income country. That means all types of countries, whether it is low, high or middle, they have got this is an important public health issue. And although they are regarded as frequent in high income countries and the affluent countries where they report higher prevalence rates, these things are coming up in the middle and lower income countries also. Say for example, if you see about UK, so allergy is widespread in the United Kingdom and also worldwide in other countries. And then the number of people affected and experiencing severe allergic symptoms continues to increase, particularly in the developed world. For example, in the United Kingdom, the cases of food allergies have doubled in the last decade, and the number of hospitalizations caused by severe allergic reactions, they have increased by 7-fold. You know, this is just to give you statistics. In 2014-15, approximately 80,000 those allergy patients they attended in England, and this was an increase of almost 9,000 from the year before. On an individual level, the lower socioeconomic status has been associated also with the higher disease burden, both in the increase and severity and the poorer control of asthma and other diseases. So there is a racial and ethnic disparity, they also exist, that we will see in the subsequent slides. The health inequalities regarding these diseases have been further accentuated recently as novel and targeted treatment options, as you will be hearing. Such biological, they have been gaining popularity, but most of these countries are not able to avail those facilities because of cost factors. So in this regard, there are numerous reports have called attention to the disparities in access and efficacy of the newer emerging options. So this is just although it is a very busy slide, so these are the common allergic diseases. We see that is allergic rhinitis, bronchial asthma, food allergy, skin allergy, drug allergy, insect allergy and anaphylaxis. And I will go one by one in detail except bronchial asthma. You know, the question is, before that, let us see why the allergy is different in different parts of the world. It is there are many theories or many speculations, or there are of course scientific. So one of the common one is the hygiene hypothesis. So the hygiene hypothesis that says that children in families with the older siblings, they are less likely to develop allergy. These are epidemiological observations. So why it is so? Because an increase in the incidence of infection in the early childhood, which is transmitted to them from the older siblings. So they are exposed to more infections during childhood. So this hygiene hypothesis has since been, it is now renamed as the old French mechanism. So the likelihood of developing allergy is related. Now it is told that it depends upon the individual microbiome, that is the population of microbes living in and on the human body. Exposure in the early life to a wide range of microbes that have been evolved alongside the humans for millions of years helps to develop a properly regulated immune system that does not overreact to harmless allergens. So there is a change in the human lifestyle, like less breastfeeding, smaller family size, and increased antibiotic use, etc. So they have changed our environmental system or the microbiome, as I was telling you. So they have affected the exposure to a diverse array of microbes, and is the most compelling theory why allergies are increasing in the developed world. There are several mechanisms through which are responsible for inducing the protection from various immunological disorders, including allergy. So that means what happens, there is a skewing towards the immune profile of T helper 2 cells that we call as the Th2 cells over the T helper 1 cells or Th1 cells. So the Th1 cells, they produce cytokines predominantly for fighting off bacterial and viral infections, whereas Th2 cells, they produce cytokines that fight off parasitic infections and contribute to IgE production and allergic responses. So in a more hygienic environment, so there is less contact with infectious agent, so the immune profile is skewed towards the latter, so due to the lack of need to fight against as many invading microbes. Again, remember, this was the hypothesis that was given and that is still persisting, but again this is not again accepted by everybody, because you see, as I told you in my earlier slide, that they are also now becoming more common in the less or the middle income or less developed countries also. But then again, those who still believe in hygiene hypothesis, they said yes, the so-called less or the middle income countries, they are also becoming little more hygienic, the environment is changing. So that is how is the issue, but this is the most commonly believed hypothesis why allergic diseases are increasing. So this is again how the development of allergic diseases, starting from the infancy, it starts with infancy, then there is what we call as the atopic march that goes on to the adulthood. So in the early infancy, actually atopic dermatitis and food allergies are more common in the early childhood. It starts with infancy and goes into early childhood. Then as the atopy marches forward, then in the childhood we will have allergic asthma, allergic rhinitis. So now there is a fifth entity that is added, that is eosinophilic esophagitis, that is allergic form of esophagitis known as eosinophilic esophagitis. And these are some of the explanations given, like say for example in the early childhood there is a damage to the skin barrier through these cytokines like IL-33, IL-25, like filaggranine, etc. Then the microbiome alteration as the age advances, then interference of the predicted genes, and social dysfunction of cells and molecules, and various epigenetic factors, that means as environmental the interaction takes place with the individual. So these are the temporal pattern and the possible mechanism of this atopic march. Then as you can see, the same thing is shown here, that in the infancy how the skin irritation such as hives or eczema, then as one grows up, then the different types of manifestations possibly go on. So this is again the same thing which I was telling you in different colors. You see the green one, that is atopic dermatitis, that occurs in the the early in the sorry. And then at different ages you can see that there is some problem with my pointer. So that is what is the allergic mark. Now coming to the specific discussion about the topic, which is the report about the global burden of disease study that was published last year. You can see on the left hand side about the asthma, and the right hand side is the atopic dermatitis. You see in the world, this is a comparison between 1990 and 2019. So almost about 30 years difference. You can see the global cases of asthma, that was about 227 million in 2019, it was 262 million. Again we have to realize that the population is also increasing, the number is also increasing. So when it is converted into the age standardized rate, that means cases for 100,000 population, again you can see there is a decrease in the prevalence rate, that is from 8,330 per 100,000 population to about 3,460. So therefore, there is a decrease in the prevalence, that was Professor Verinder also shown in his too, has shown that there is a decrease in our own country also, the prevalence rate. But again remember, the number will be high because the population number is also increasing over the year. And then of course again remember, as I will again remind you, so these are all based on the reported cases. So if you add to that about which are the missing cases, of course the number will be anything much more than this, but these are the reported cases. So based on that, we can. of atopic dermatitis, again also the number has increased over these 30 years. But again, by and large, the prevalence rate remains by and large the same, from 2379 to about 2377. Not much of a decrease, significant decrease. So in 2019, about 262 million cases of asthma and about 171 million cases of atopic dermatitis were reported globally. So this is just to tell about the recent study, that is the regional and national burden of asthma based on the reported cases. You see, in India we have got between diseases. We are some countries, we are very high prevalent countries like Australia. We can see some of the European countries, they have very high burden for 100,000 population. So India is various parts of India between 2,000 to 4,000 cases for 100,000 population. And if you see the mortality rate, which is again about 20 to less than 30, is the mortality rate for 100,000 population in 2019. So this is now coming to the atopic dermatitis. China has the highest number. The incidence rate about 5 million cases of atopic dermatitis, and the prevalence is much more, that is about 35 million. And then India has the second highest number of atopic dermatitis cases, about 3.7 million cases in 2009, and the total it is estimated about 25.9 million cases of atopic dermatitis. And of course, from other countries like the high income Asia Pacific region, and then followed by other countries as you can see, and there it is less in the African countries in various parts, whether it is central, eastern, or southern sub-Saharan Africa. This is the disability adjusted life year loss, or what we call the values, again due to atopic dermatitis. So obviously there is an increase in the values because of atopic dermatitis. So this is again a very nice review by Mohet et al. That has again come last year. You see, this is the comparison between the the 2019 study and then the GAN study, that is the Global Asthma Network study, which Professor Veerander showed. You can see this is the figures given in the blue dot, and then there are the red dots. As you can see, there are different cities of this country. You can see there is some variation. In some areas like Chandigarh is less, but the other countries, for example, you go to the south, then there are different parts, there are different as regards the asthma, allergic rhinitis, and atopic dermatitis. Between the ages 6 to 7 years, in the both types of studies, there is some difference between the two studies and the different parts of the country. That is what I am trying to tell you. Similarly, this is again between the ages 13 to 14 years, both in comparison between the IDAC and then the Global Asthma Network study. All the three diseases they actually differ in different parts of the country, different parts of the country. Then again, if you see the allergen, you see again the distribution of house dust mites and the pollen allergens that is shown. In some areas they are much more, in some areas they are less. If you see, say for example, pollen allergen, you can see in the northwestern part of the country, where Chandigarh, Delhi, other parts, they are more in comparison to southern parts, and so on. This is again the various risk factors that are again worked out. The more common is the siblings, if there is a intake of paracetamol, then indoor air pollution, then the indoor air pollution, the heating and cooking, then the use of antibiotics, underweight, and then for the allergic rhinitis, it is again the maternal smoking, then the paracetamol intake, then the indoor air pollution, then the underweight, and the obesity. And like this, the various risk factors have been worked out. Again, the same thing has been shown out of all these risk factors. So, indoor, characteristics like whether there are the moisture, mold, etc. Then again for allergic rhinitis, it is a smoking exposure to mosquito coil, indoor characteristics, etc. They are the more common factors for all these three types of allergy. And again, I think it is again good thing to note that the allergen biology in different parts of India has been worked out. I am not going into the details because they are very difficult to name also. In both the fungal spores, the pollen allergens, etc. They have been worked out very clearly. Now coming to allergic rhinitis in India, the prevalence of is rising in India in the last 2 decades. Greater in the older children, that is 13 to 14-year children, and the relatively smaller increase in the 7 years. As you can see, the study in both the ISAC 1, phase 1 study and the ISAC phase 3 study, you can see it is more in case of 13 to 14 years, which is 12.5% and around 12% and around 18 to 23% the older age. So this is again, these are the common aeroallergens of relevance to the allergic rhinitis and asthma in India. As you can see, the common ones are the house dust mite, cockroach, pollen, and the mold spores. And then these are the common the names of the house dust mite, which is the commonest one. I think you know that is dermatophagosis, seronismus. About 75% of this species is the house dust mite. Then in the western, northern and southern India, there is a lower rate of sensitization. And again, the major offender is the dermatophagosis, seronismus. And then in northern India is the house fly, antigen, rice grain dust, cockroach, house fly, etc. So then there are different species that have been identified. So for example, for the cockroach species, it is the Blactella germanica, and so on. Then another interesting observation is we know that allergic rhinitis, we have got two types, whether they are blockers and then the sneezers and the runners. Right? The blockers, there is mainly preventing with nose clogs, so the higher rates of sensitization to dust mites and fungi. Whereas those who are running nose, will be higher rates of pollen sensitization. And then amongst the aspergillus, the aspergillus flavus will be having the highest rate of sensitization, and that is called allergic rhinitis. And again, so the allergic diseases such as allergic rhinitis and asthma, they are increased in India over the past decade. So approximately 22% of adolescents currently suffer from allergic rhinitis in India. Although there is a lack of proper epidemiological studies and various risk factors, they are speculated or environmental exposure, genetic factors, then dumpsters in your residence, movement of vehicles in your home, exposure to artificial light at night, and then of course the diagnosis and management of AR in India are often suboptimal. There is lack of specialized training in allergy and immunology, lack of diagnostic facilities, and then of course the cost of medication, that is another impediment for proper management of these allergies. Then coming to the pollen allergen, we have got two pollen seasons. The tree pollen is between February to April, and the grass pollen between September and December. The allergenically important pollens are, these are difficult names, but they have the common names in their regions. So many of them are seasonal, some of them are also perennial. And the fungal spores, again, we have got different fungal spores. So the good thing is that they have been worked out already. And coming to the atopic dermatitis, the prevalence in India is perhaps lower. There is no significant increase in prevalence in India. The ISAC 1 study, which is a 12-month period prevalence, is between 2.4 to 6%. I think the phase 3 study, the prevalence rate was lower, that was less than 5%. The hospital-based study shows about 0.42 to 0.55%. There is a racial difference in prevalence as reported in other parts of the world also. Now, coming to drug allergy, India, the cutaneous adverse drug reactions occur in about 2 to 5% of cases. Mainly reports are from the outpatient department. The common offending drugs include antimicrobials, that is the most common one. About one third is because of antimicrobial, and then another one third is about anticonvulsant, and then anti-inflammatory drugs about another fifth of cases. And then the other less frequent drugs can be antipsychotics, antidepressant, antihypertensive, etc. Then about the anaphylaxis, obviously we don't have the proper data. It is lacking in our country. A recent single center study in South India reported that knowledge of anaphylaxis and its management was suboptimal amongst junior doctors, medical and nursing students. The true estimates of these students are not available, as I told you. Then a systematic review on the drug-induced anaphylaxis in India from the published studies that between 1990 and 2030 reported that reactions are occurring in the perioperative system, which is the more common, in the wards or the indoors, it is about 20%, and at the home it is about 11%. And as I have told you, the main culprits are the antimicrobial and all the anticonvulsant and non-steroidal anti-inflammatory drugs. The opioids were again one of the most commonly used agents. Then the food allergy, coming to food allergy, when you discuss about in the global context, it is a growing public health concern. It is referred to as the second wave of the allergy epidemic following asthma. They are very common, affecting up to 10% of infants in some countries. The prevalence is increasing in the last few decades. The preferentially it affects the industrialized regions. So now also growing evidence in the less privileged countries also. The problem because of diagnosing food allergy is because ideally the prevalence is to be confirmed by gold standard of a food challenge, which is resource intensive, that limits the availability of quality data. So in a survey of 83 World Allergy Organization member countries, 6 non-member countries, over half of them have no data on food allergy prevalence. And another quarter has data based on only patient and parent reports without any authentic or the proper, food challenge studies. And only 10% have food allergy prevalence studies, which are actually one can say authentic. For example, in USA, it is a growing problem, as I told you, about 8% of the children, 11% of adults have a convincing history of food allergy. That means the symptoms are consistent with an IG-mediated reaction to a specific allergy. The hospital admission data that shows a clear increase in pain, food avoidance, and use of rescue treatment if accidental exposure occurs are the only advice options are provided, because omalizumab is one of the drugs that is now recommended apart from avoidance of food. But again, that is not available. This is just to give you what are the different food items. This is the data of the USA. That any food allergy, as I have told you, all ages is around 11%, and then the peanut allergy is the most common, followed by there are many other food items that have food allergy. Now coming to out of those food allergies in adults, the severe food allergy reaction occur more than half of the cases, and allergy to multiple foods in about 45% of cases, and those who develop food allergy as an adult in about 48% of cases. Then the epinephrine prescription is about 1/5 of the cases they require epinephrine, and at least one food allergy related lifetime emergency department visit is another 38% of cases. So again, they have got various impacts on the various issues, school related, work related, social. They have got many other implications, particularly if somebody is having food allergy. So this is just a busy slide that shows the food allergy studies in India. So many investigators have reported the existence of food allergy. So as much as the 20 4, 20 foods, 46 foods, and sometimes only one food. Like this, you can see the number of foods they can cause food allergy, and different authors have reported from different parts of the country. But I think one of the very important ones that is what we call the European study, that was where the India and the China were also part of the study. So that's exactly what it says, that the food allergy sensitization is about 19%, but clinically relevant is about 0.14%. Similarly, peanut allergy about 6.3%. If you do the sensitization study, but clinically relevant is about 0.03%. So despite high sensitization rate, the prevalence of clinically relevant food allergy was extremely low. So the health node study from Australia showed that odds of peanut allergy was 3-fold greater among children born to parents born in Israel. So this is I was talking about that European study that we call as the Europe prevalence study. This is in an adult population conducted in 2 centers in Karnataka state, that they show that a high sensitization rate of around 26.5%. However, the rates of probable food allergy, which are clinically significant, they were low at about 1.2%. So, the higher than that observed among adults in Europe, except for those foods that cross-react with the birth pollen. So, most of the sensitization in subjects who are total IG above the median IG level. So, as I was telling you, the high level of cross-reactivity occurs in different pollens and food and among food. The prevalence of probable food allergy, which are self-reported, that is around 1.2%. So mainly they are accounted for by cow milk and apple. So different food items. So now, ladies and gentlemen, this is just the summary of various types of the allergies that have been reported from India. The asthma, you have already heard, between 6 to 7 years and 13 to 14 years. The eczema, food allergy, and allergic rhinoconjunctivitis, the different extremes, which I summarize that. And then the good thing is that we have got now what we call the pollen atlas and the allergic data that is available from different parts of the country. Again, these are those who are interested, they can go through that, the fungi, pollen, and the different parts of the country. Another interesting thing is that they differ at the different parts of the country. So some of the genetic studies are also available from this country, different genes. That is the Adam, the gene that is one of the that is most frequently studied. And of course, there are many other genes that are being studied in different types of allergies. So the last slide that shows, what is the problem with the India and about allergy disease. A lot of barriers for the delivering of high quality allergy healthcare in India. It starts out with our economic and regulatory factors, like there is obviously the poor economic status for many people. It is because of unavailability and access to essential medicines, which are which could be free or at subsidized prices. Then socioeconomic group like inhaler, adrenaline, auto-injector, biologics, they are very costly. Then lack of access to good quality of allergy, the non-availability of standardized allergen, specific immunotherapy, non-availability of standard allergen. My senior colleagues, they are going to speak about all these issues. There will be limited access and expensive. Then about the immunodiagnostic test, non-availability of penicillin, allergy skin testing kits, lack of healthcare insurance, lack of area-specific metrology. So all those types of things are there. Lack of legislation. I think the chairman in the previous section, he talked about lack of legislation. That anybody can tell anything. I will cure asthma and all that. Dr. Virendra Singh has already talked. Then lack of infrastructure for drug allergy recording and healthcare system. Then poor reporting of adverse drug reaction. Then education and training. Again, there is a lack of specialists in allergy and immunology. And actually partly we are to blame, we senior people, we mainly focus on asthma. We don't, to be very frank, not give much importance about allergy, except very few people who are committed, because what I am trying to say in general, sorry sir, I don't mean to, not obviously you people are not included in that, but most of 99% of said I am very happy with no hesitation in telling that. And then the other thing about various adverse environmental factors like the pollution, and then the clinical practice and research, then the guidelines which we talk, we are all talking of Jina, gold and all that. But in our country, there is the guideline for asthma, and then the up till late, very late, we did not have a proper guideline. So I think now we have got Indian guidelines for diagnosis of respiratory allergy. I think that is available. So in conclusion, I can feel that earliest published work from India was on respiratory allergy to most in 1961. Then 6 decades have elapsed, but advancement in allergy and immunology has been relatively moderate. Then Bark-Ford studies are lacking coexistence of asthma and other allergic diseases. They are very, very common, so they should not be ignored. Evaluation of ethnicity and genetics, cultural and religious influences, socioeconomic factors, and their impact, biodiversity and environmental changes, climate changes, etc. And asthma and allergy need to be looked into. Allergen distribution in India are 2 decades old, but good thing is that they are at least available. Then data on food allergy, then influence of dietary intake on the gut microbiota is not, it is available, but they are not authentic data. Then the breastfeeding practices are changing in the country. Then data on drug allergy, stinging insect allergy and anaphylaxis are very scarce. Then disease management guidelines, of course, as I told you, they are just recently available. And then, but only thing, the awareness amongst the respiratory physicians, very important. And then again, you see, the other specialties also, we should be combined together. If it is the dermatologist, the ENT specialist, so they are, and then for the food allergy, the gastroenterologist, so all these people should be together, including the immunologist. So there should be a national allergy of registry of allergic diseases. And I think as Dr. Kakuri and Dr. Jain already insist that we should have got a, the structured program of allergic diseases. May it be either if you want to teach it in the curriculum of respiratory medicine, that is okay, but they should be very much structured. Or if you want a diploma or whatever you can call it, that should be. If you want to to tackle allergic diseases. So I will stop here, ladies and gentlemen. Again, I thank you for your kind attention and I
Thank you, Dr. Behra, for an excellent presentation. Not only he told the overall spectrum of allergic disease problems, but also he has guided us that how we can incorporate this specialty of the allergic diseases in our pulmonary medicine. He has also covered the many other aspects also. If there is any question, I think he has already covered. If there is any specific questions, 1 or 2 may allowed. So if there is no question, presently out of 3, at least 1 person is definitely having one type or other type of allergic disease. By 2040, probably out of 2, 1 will be the allergic. Most of the allergic diseases are increasing except the asthma. So thank you very much for a wonderful, excellent lecture, Dr. Behra ji, and thank you very much.
Thank you, sir. That was an incredible session. I now request Professor Ved Prakash, sir, and Professor Rajendra Prasad, sir, to come on the stage and felicitate our guest speaker and chairperson. So, please felicitate our guest speaker, Professor Digambar Behra, sir. Professor V.K. Jain, sir. Dr. Rachit Sharma, sir. Dr. Darshan Bajaj, sir.
It is a well-known fact that everything under the sun, including the sun, is an allergen. And that makes it all the more hard to diagnose a patient's allergy to a specific allergen. For our next session, diagnostic approach to an allergic patient, may I now request the chairpersons to please come onto stage and take their seats. Dr. Ram Narayan Rawat, sir, Senior Consultant Pulmonologist, Balrampur Hospital. Dr. Ajay Kumar Verma, sir, Additional Professor, Department of Respiratory Medicine, KGMU. Dr. Atul Tiwari, Assistant Professor, Department of PCCM, KGMU. Welcome, chairpersons. I request you to kindly introduce our next speaker, our very own, our very beloved Professor Rajan Prasad, sir, and open the session. Thank you.
So it is my pleasure to invite our teacher, rather teacher of teachers, Professor Rajendra Prasad sir, who needs no introduction, and it's always pleasure to listen you, sir. So to deliver next talk, diagnostic approach to an allergic patient, clinical, I hand over dais to Professor Rajendra Prasad sir. Over to you, sir.
Thank you, Ajay and other chairpersons. And at the outset, I must thank the organizer, although I am one of them, to allow me also to take a lecture, a short lecture on what is the approach to the diagnosis, especially the clinical issues. Other issues will be dealt by somebody else. So I will be just confining myself to the clinical. And when I say these things, my talk has been made very simple by Professor Behra. He has already dealt all the things about allergy, and So, so my objective would be for about, यार कौन सा लगाया हुआ है? My objective would be for about 20 minutes, time about 20 minutes. And so what is the relevance of history and clinical examination in diagnosis of allergy, particularly respiratory allergy? And you know, power and ease of new technologies might cause us to imagine that history taking and physical examination will become obsolete. This slide I delivered a lecture way back in 2010 in Mumbai when they have organized what will happen in 2020. So that was a lecture and I used this slide that we have so much of technology advancement today, even artificial intelligence has added to it. But still I believe we are little older clinicians, probably I can't see anybody senior than me except two persons. I have already said Dr. V.K. Jain and one other is Dr. Mujammil Khan Sahab. Otherwise, and Kathuria is my class fellow, unfortunately. So what I'm trying to see that still it holds true that, but what is very unfortunate, people are forgetting history. That's my presumption. When I see patients and I see how they are diagnosing, so I find that probably people are forgetting the art and science of history taking. Then clinician and their patient will value history. You know, always, मरीज क्या कहता है? साहब, डॉक्टर साहब ने कुछ पूछा ही नहीं. It means patients value it. मेरे बारे में थोड़ा मशहूर है कि डॉक्टर बहुत गौर से सुनते हैं और कुछ नहीं बताओ तो फिर वो करते हैं और पूछते हैं. तो that is even patient value it. ये मैं नहीं कह रहा हूँ, ये मरीज भी चाहता है. हमारे पीजी लोग बहुत लोग बैठे हुए हैं, मैं बहुत कभी कभी डांटता भी था, भाई हिस्ट्री हाउ कायदे से ऐसे नहीं काम चलेगा. So that you have imagined that, and एक है ये शायद बोलेगा नहीं, लेकिन यही कह रहा मरीज डॉक्टर साहब ने कुछ साफ सुना नहीं. So, and you know, there are enough grounds. Today we are talking of evidence-based medicine. So I have focused you on 2-3 references that says that 88% of the diagnosis in primary care were established at the end of brief but good history. That is evidence-based even. Can you imagine that 88% of the diagnosis, what you need to diagnose or to treat, which comes from good history. So you can understand the importance of history. Even this lecture now, I have also become YouTuber. What people call, what PG students call me, sir, aap YouTuber ho gaye ho aajkal. So even this lecture is there on the YouTube. Some would be interested, can see that. I would start with one of the study where Rajiv Garg and many people were co-authors. A study of prescription habit of how much allergy is required by the medical practitioner. That this study probably has shown this. It is a little old study, but what it shows that everybody write for allergy testing, whether he is a postgraduate, whether he is a graduate, whether he is a non-allopath. सबके पर्चों पर दिखता है एलर्जी की टेस्ट, एलर्जी की डायग्नोसिस. And there are many, lot of allergic diseases you have just heard. I will not repeat them. But unfortunately, this study was done while I was in KGMC in our allergy clinic, and then we found that those patients who are referred to us for allergy workup, hardly about 65% they really were allergic. 1/3 were non-allergic. अब उसमें मैं नाम नहीं लूँगा, मतलब क्या क्या डिजीज़ नहीं, मतलब स्केबीज में भी, माइकल स्टेनोसिस में भी, जहाँ कुछ भी कुछ थोड़ी बहुत प्रॉब्लम स्किन की हो गई, सांस की हो गई, सब आदमी, तो दैट इज वेरी पॉपुलर साइंस व्हाट आई एम ट्राइंग टू से. And I'll just, and allergy testing was required at least in 2/3 of them. You this morning, I think you were listening what is allergy. I think Vikas Agarwal, you must have heard in the morning. He delivered a beautiful lecture. I have heard his lecture in PGI itself during one of the ALLERGOCon in PGI. And so allergy, you know, I used to say misuse of term allergy led to a variety of unexplained phenomena being labeled as allergic disease. Most of the doctors tend to attribute allergy when they do not understand or cannot diagnose or treat properly. Among educated laymen, it's a fashion to suffer from allergy. मरीज आता कहते हुए क्या तकलीफ है, तो कहता साहब एलर्जी हो गई. So it's a fashion. So, but anyhow, the term was coined first time in 1906, and then there is the gel and Coombs classification was very popular, and recently, you know, in 2023, all the definitions have been somehow changed, because a lot of new things have come from 2006 from 6 to 2023, and newer terms remain the same, but there's a little modification in it. There's like allergy is an unexpected, abnormal, exaggerated reaction to an exogenous stimulus involving the immune system. There is another word, atopy, is used, which is very common. We say commonly person is atopy. What is atopy? In that 23 guideline, although it was defined long back, term derived from atopos, and it still say that individuals who are prone to get allergic disorders, they are also known as atopic. And there are, I think you must have heard, Dr. Vikas, hypersensitivity reaction. There were typically, you know, there are 4 types of hypersensitivity reaction, but now there are 9 types of allergic reaction have been described. You must have heard in the morning, I will not repeat it. Atopy, I said, is the genetic susceptibility to develop IG-mediated disease. You have heard by Professor Vera various types of allergic disorders, but since upper 2-3 like bronchial asthma, allergic rhinitis, conjunctivitis, they are grouped together and they are also called as a nasobronchial allergy. Otherwise, every system can be involved in allergy. You have heard him that a lot of allergens, it may be pollen, fungus, dust mite, food, fruits, insects, all things can cause allergy. I think Dr. Behra has elaborated beautifully. In one of these studies, which we published in, I think, 2013-14, it was a KGMC work, and there is a common allergen. What we see in our day-to-day allergy clinics are insects, mites, pollen, and animal dander. Sometimes food, sometimes fungi. So these are the common allergens which in most of the studies in India, including ours, have shown they are the common. Another thing I always tell to my students, if you want to become a good allergist, you have to be botanist. Means you have to know the pollen calendar. And in our time, we used to mug up the pollen calendar, because there is nothing like pollen calendar when we were students. But now, good thing that we have a pollen calendar. Dr. Behra has shown you in Word Atlas, and everything is there now. At least it is very easy. But what is a pollen calendar? I just try to give you some information. Pollen calendar means, you know, this is a photo of one of the pollen calendars published in India. That suppose here is a एजा डायरेक्टा. एजा डायरेक्टा को आपको समझना पड़ेगा है क्या चीज़ है. ये नीम का पेड़ है, तो नीम के पेड़ में जो फूल निकलते हैं वही तो पॉलन होगा. अब देखिए इसका क्या कह रहा, मार्च अप्रैल के महीने में इसका फ्लावर होता। अगर आप कभी नीम का पेड़ देखें, आजकल है नीम के पेड़ों के फूल, तो आपको दैट इज पॉलिनेशन when that particular tree pollinate, the tree pollinate, that is the pollination. But now good point is that they have been mentioned in the, I didn't know this tree, मेरे ख्याल से बहुत लोग पहचानते होंगे। हमारे ओपीडी में जब केजीएमसी में थे, अभी भी होगा मेरे ख्याल से, कि वो नीम का पेड़ था, वो फूल मार्च अप्रैल के महीने में हमारा पीडी उसको उसी के ऊपर मतलब चल के आता था, और वो एलर्जी क्लिनिक बगल में थी जाता था, और वो एलर्जन लगाता था, उसमें एज अ डायरेक्टर दिखाई दिस वन ऑफ द कॉमन एलर्जन। मैं पूछता था भाई ये जो नीम का पेड़ इसका क्या नाम है, nobody was knowing that, but that was the first lesson I used to give my PGs. You should know it. This is neem, this is known as, this is the botanical name, and you see they are flowering, so it becomes a pollen calendar. So it is not very difficult. As I always say, that in India, if you want to be allergist, you have to know fauna and flora around you. That is very important. So that is neem, you know, April is the photograph was taken in the April, and that is flowers. That is the pollen. Another resinus is another common, that again pollination month of February. Now this is just an introduction. How to diagnose allergy? To diagnose allergy, what you require is a history, what you require is a history test, what you require is a lab test, and what you require is a provocation. My job is, I'll just confine in next 10 minutes, is about the history portion. I have another YouTube lecture. Many of my PG students demanded from me कि सर जो आप लोग हिस्ट्री पढ़ाते थे पहले, वो तो आप ऐसा कर जरा कम पढ़ाई होती है, लेकिन कम होती है, why not you put on the YouTube? मैंने कहा ठीक है भाई, I was teaching in ERA and I made it, and more than 50,000-60,000 people have already seen that. So that's how I said I become YouTuber. So history, you know, nobody, I have shown you the evidence there, nobody can deny the adequate and careful history. History in allergic diseases is mainly, you know, when patient comes to allergic diseases, I will insert in your room, it's clear that what, you ask one or two questions, it will be clear that what disease, rhinitis, asthma, history, what will be these subjects from. But when we take history in detail, what it tells, it is directed mainly towards establishing the underlying causes, means what Dr. Behra has talked, various allergens, pollen, fungus, so that from history we look, and that is possible. So it becomes a very specialized history, and I used to tell my students, if it is a specialized history, it consumes time. वो 2 मिनट की हिस्ट्री से काम नहीं चलेगा. Every allergy clinic, everywhere in this country has a special case sheet for allergy patients. So that was devised because we have to take history in detail. And whether when you take history, even I take history today, when I take history, my job, I wanted to find out whether my patient has allergic disease. Patient may have asthma but may not be allergic, may have rhinitis but may not be allergic. So how I find out? So that the first job of history is patient has an allergic disease and it discovers underlying causes. How you suspect allergy in the patient who is suffering from diseases I have already explained? Answer, allergic disease is usually from childhood. Usually the family history is positive. Means family suffers from atopic disease. Combination of, there is usually combination of symptoms. You know that asthma is also always associated with rhinitis or sometimes with eczema. There could be a seasonal variation. I have already deliberated as pollen calendar, and there could be a geographical variation. When I say geographical variation, it differs from 500, 600. Lucknow is different, Delhi is not different than Lucknow, but Lucknow is different, Srinagar is different, Bangalore is different. That is what is known as geographical. Many patients they come to us and tell कि सर जब मैं लखनऊ में रहता हूँ तो ठीक रहता हूँ, बैंगलोर में जाता हूँ तो मेरे को ठीक नहीं. That is what is the geography. So all these points you have to take details in the history. And naturally, if complaints would be relation to nose, ear, eye, chest, skin, GI, these are the common organs. And as you take any other history, in allergic history, you have to take the present illness, you have to take chief complaints, what are the chief complaints, and is there anything, when the symptoms occur, if there is a seasonal variation, if the perennial, if there, throughout the year there, it could be house dust, animal dander, mold, cockroaches, so many things you have to think of. It may be irregular, it may be perennial, well seasonal, all sorts of combination is possible. Time of the day and location sometimes is very important when these symptoms aggravate. There may be something where person is working over there, and then precipitating factors, what really precipitates your symptom, and thorough environmental history is also very important, which you cannot get any idea from any test, and then assessment of impact of illness is also very important, number of the last days, social adjustment, all the things you have to take together. Past history, हमारे जो यूजी और पीजी की आजकल की जो ट्रेनिंग है, एक सेंटेंस मैं सुनता हूँ कि सर हमारे जमाने में था, सर पास्ट हिस्ट्री इज नॉट सिग्निफिकेंट. ये एक बड़ा कॉमन वर्ड होता है. देन आई इमीडिएटली आस्क व्हाट पास्ट हिस्ट्री यू आस्क बिफोर यू आर सेइंग दैट. I know that in majority of the patient it may not be significant. That's why this dialogue has come in the medical science. But if you take so the past history of during infancy, I said somebody suffered from eczema during infancy or other diseases, vaccination, any ENT operation. अरे rhinitis होगी तो कभी-कभी ENT का operation. Any previous history of drug, what drugs he has taken, how he has responded to those drugs. And if there is adverse drugs, all those things you have to take in detail. Family history, I have already said that family history is possible, positive in many individuals. That in one of the studies it says that if 30%, if only one parent or sibling is atopic, the chances of 30%. If both, then 50%. If neither parents is atopic, still allergy can happen. So family history, it should be there. But it is not possible that every patient has family history. Then personal history is very important. What is his job? What was his past occupation? Job at onset, hobbies. लोग job जब पूछते ना तो current तो पूछ लेते हैं और पिछला का सब भूल जाते हैं. So everything you have to know what has been the total exposure, his diet, his hobbies, home conditions, passive smoking and active, everything you have. That's why I said it is a very specialized history. Special case sheets are prepared for this and it consumes time. So after you have finished history, you are very pretty well idea that what this person is, what disease he is suffering, and what are the factors which may be responsible in this particular patient. Based on that, you may think of, you do a physical examination depending on the area. You know that mainly physical examination. We always tell, suppose patient gives history of breathlessness and currently suppose you find there is no finding. Yes, it is possible. If the patient are in remission stage, you may not get any finding. So that thing you have to discuss. And then I have another 2 minutes. So approach to physical examination, and even the Indian guideline for diagnosis of respiratory allergy, which I think Dr. Behra and I was part of that, and that also says that is evidence-based. It says that it is very important, and there is a strong. Sorry, ये सब भाग रहा है. So this slide shows that what is the importance of clinical history. One of the ERP guidelines says that Though the certainty of evidence is low, but the strength of recommendation is very strong. So you can understand there is a good place of history taking in diagnosing. So I have come to end of my presentation. My take home message is I always give an adequate clinical history and physical examination is very important for diagnosis of respiratory disorder. And as I said that all lectures what I teach is on YouTube. Recently, many of you know that I have brought a book on X-ray and my YouTube lecture is also on the how to interpret chest X-ray. Many of my postgraduates demanded from me, sir, आप डाल दीजिए नहीं आपके संग एक्सरे सब निकल जाएंगे. So I put on YouTube, मेरे ख्याल से 3.5 लाख लोग इस YouTube को देखते हैं. Some of you maybe benefit and then we have book on allergy, manual of chest X-ray I already told. So I would like to end my presentation, especially for the younger people, that anyone who needs learning, अगर आपको ऐसे बना रहना है काम नहीं करना यहाँ आके अपनी स्लाइड खोली और उसमें कुछ थोड़ा बहुत थोड़ा बहुत नया दिमाग में था Thank you very much.
Although I am too junior to moderate a session which is taken by such a stalwart of pulmonary medicine, but I would like to thank Dr. Sachin and Dr. Arif who have given me opportunity to moderate this session. I would like to thank Dr. Sir. It is always delightful to listen the basics of the history taking from such a senior professor, and we have learned a lot from this nice lecture. Any question from the audience?
मुजम्मिल साहब आप उठा रहे हैं कहीं माइक दे दो भाई डॉक्टर is very senior. I took his name when I was doing PCCM. He was senior than us and
हेलो, मैंने आपको कई बार सुना है और शुरू से जब मैं यहाँ पर था तब आप मेरे सामने आए थे, लेकिन दो बातें मैं ये जानता हूँ आपके बारे में कि वक्त के सांचे में कुछ लोग थे जो वक्त के सांचे में ढल गए, वक्त के साथ चले गए. कुछ लोग थे जो वक्त के सांचे में ढल गए और कुछ लोग हैं डॉक्टर राजेंद्र प्रसाद जैसे जो वक्त के सांचे में ढल गए और मौजूदा को मुमताज़ बना देते हैं, प्रेजेंट को आला, मौजूदा को मुमताज़ बना देते हैं, मुमताज़ को राज बना देते हैं. कुछ ऐसे फनकार भी हैं डॉक्टर प्रसाद जैसे जो सन्नाटों को आवाज़ बना देते हैं और ख्वाहिशों ही से नहीं गिरते हैं फूल झोली में. वक्त की शाख को हिलाना होगा, कुछ नहीं होगा अंधेरों को बुरा कहने से, अपने हिस्से का दिया खुद ही जलाना होगा. और वक्त बर्बाद करने वालों को वक्त बर्बाद करके छोड़ेगा, वक्त बर्बाद करने वालों को वक्त बर्बाद करके छोड़ेगा, उसे हालात ही नहीं छोड़ेंगे जो खुद को हालात पे छोड़ेगा. ये आपके लिए चार थे और आपकी बायोग्राफी में मैंने ये दिए हुए हैं और बहुत पसंद किए गए और आपके उसके मुताबिक पूरे सही उतरते हैं कि आपने आज ज़िंदगी में जो हासिल किया है जो चीज़ वो आपकी मेहनत कर रही है. थैंक यू वेरी मच.
Thank you, sir. Thank you for your nice words. I have already told you that he was my senior and he was an artist. मैं एक बात और बता दूं, मेरी एक बायोपिक है, उसमें डॉक्टर साहब का भी इंटरव्यू उस बायोपिक में कहा था. डॉक्टर साहब को याद होगा, उन्होंने कहा भाई कुछ अपने सीनियर लोगों का नाम दीजिए, मैं चाहता हूँ आपके बारे में कुछ. उन्होंने बायोपिक में भी कुछ डाला, ऐसा वो बढ़िया सा उन्होंने डाला था और मुझे याद तो नहीं है, लेकिन ये कि he is such a senior, but he one thing about him that he is an artist. शुरू से रहे हैं डॉक्टर. Yes sir.
So may I raise a small concern? We were discussing about the art of history taking, in particular with the respiratory allergies, or maybe in general with the allergies in general. I want to understand from your vast experience as to, is there any need of assessing the emotional well-being of the patients who have some allergy, And what little I have understood that in couple of patients, the symptoms are exacerbated when there is emotional turmoil or distortion. Can you throw some light upon it, please?
I think you raised a very important question. That emotional issues, psychological issues are very important in allergic disorder. Maybe respiratory, maybe other allergic disorder. I will narrate a small story because you have raised this question. This was done in KGMC itself. What I was told, it was not done in front of me, but it was what I was told. In Department of Medicine, during our N.N. Gupta's very senior teachers, so what they did, because N.N. Gupta's, respected N.N. Gupta's interest was respiratory. So what he did, he took hold of few patients who were suffering from asthma and who were saying, my asthma used to increase during rainy season. And then another patient they catch hold, they say my asthma used to increase when I drink milk, something like that. So what they did, it was not done in front, but I was told very beautifully that what they did in the one room of medicine department, medicine वाला कोई भी अभी था, तो चौधरी साहब थे, उन्होंने एक कमरा बनाया, अब तो नहीं है, जिसमें if a patient, such patient entered in that room, he felt that because of sound, light and everything, although those are very olden days, it was a very difficult job, but if patient enters in that room, he felt that it is raining. And they had precipitated their asthma attack. Same thing was true with the milk. When some of those patients were given the barium sulfate, which mimics like a milk, and some of them, they developed asthma symptoms. So what I am trying to say, the evolved term known as psychoallergy. And we also see in our day-to-day clinical practice, many of the patients have a psychological background. So you have to assess. For any disease it is true, but for allergic diseases it is very true. And many of the patients I see that they are in fact not suffering from asthma, but there are some psychological issues with them. And when you treat that, although I am not competent to treat the psychological issues, but the concern for people, they really, when they assess and they recognize. So I think, sir, you have raised a very relevant and very important question. Because of lack of time,
One small corollary, sir. As on date,
in fact, Dr. Harshvardhan, I'll just like to add upon this point, emotional stress related. Actually, it is very much scientifically confirmed that all asthmatics do have exacerbation of their symptoms during emotional, psychological stress period, and it is mediated by increase in cortisol in that, which leads to TH1 and TH2 imbalance. Expression of, there is a disturbance in expression of cortisol and beta-2 adrenergic receptors, which is the cornerstone of therapy of bronchial asthma. So while on therapy also, whenever there is exam for children, when they are undergoing examinations or something, or any person who is going stress at workplace or anything, asthma does worsen, and it has got scientific background, or there are definite mechanisms for that.
Sir, may I have two correlates, please?
One more thing I should like to add what Alok said. This is with asthma patient, they aggravate. But I have seen patients, they have no asthma. And they have mainly the psychological issues. And they pretend that they have asthma. They say that I have severe breathlessness, what not. If you take history and you do examine, so yes.
So in the state context, sir, I have two sub-concerns. As on date, do we have a scale to measure the emotional well-being as on date? Number two, do we have any module for psychometric intervention in such cases?
I think I'm not the right person to answer it, but we have conducted many theses with the Department of Psychiatry, especially COPD, asthma, ILD, all the patients. What is the psychological issues with them? And they have really certain parameters, they have certain equipment, they have certain questionnaires by which you can measure it very effectively.
Thank you, sir.
Sir, with due regard, sir, I want to add something. सर ये जो हिस्ट्री टेकिंग में जब पेशेंट्स की जो हम वो देखा गया है डे टू डे प्रैक्टिस में कि जो जिन बच्चों को अर्ली विनिंग कराई दी जाती है और उनको टॉप मिल्क पे रखा जाता है, दे आर मोर प्रोन टू एलर्जिक इन्फेस्टेशन इन फ्यूचर। और जो जिनको की विनिंग देर से होती है और बच्चा फीड करता है 1.5 साल 2 साल, तो उसकी एक तो इमोशनल बॉन्डिंग्स भी ज़्यादा होती है मदर के साथ, प्लस वो उसके अंदर ये देखा गया कि ये चीज़ें उसके अंदर एलर्जिक जो इन्फेस्टेशन होते हैं वो सर कम देखने में मिलते हैं। ऐसा सर क्लिनिकल प्रैक्टिस मैंने फील किया है।
You are very right. It's a separate chapter. Yeah, I think how the weaning and how this breast milk feeding and not breast milk feeding, how it affects asthma. There's a good literature about it. Yeah. And you are very right. It may happen.
Thanks.
Any other question from the audience? So we are closing the session.
मैं नहीं समझता था कि हिस्ट्री पे इतने क्वेश्चन, एक बहुत खुशी की बात है क्योंकि एज ए टीचर मेरे को जब आदमी सवाल नहीं पूछता तो मैं बड़ा दुखी हो जाता हूँ समझ गए? तो कि शायद हमने आप कुछ एक्साइट नहीं किया लोगों को कि सवाल पूछें। सो आई एम वेरी हैप्पी दैट पीपल हैव ऑल रेज्ड एंड हैज लॉट ऑफ इश्यूज विद हिस्ट्री टेकिंग। मैं एक बात और बताऊं, जिंदगी भर लर्निंग प्रोसेस है। हो सकता हमारा पीजी जिस चीज को 1 घंटे में ना पूछ पावे, हो सकता हम 50 साल के बाद अब उसको 5 मिनट में पूछ, बिकॉज दैट एक्सपीरियंस मेक्स यू थिंक। हमें पता है पीजी लोग आते हैं रोज रिव्यू कराते हैं और बहुत सी चीजें वो छोड़ते हैं, हम कहते हैं क्यों छोड़ दिया भाई तुमने इसको। सो दैट इज नॉट देयर फॉल्ट, दैट इज द लैक ऑफ एक्सपीरियंस। बट एक्सपीरियंस विल ओनली कम, आई टेल देम। आज से ही आप एक्सपीरियंस लेना चाहते हो तो आएगी, और अगर नहीं लेना चाहते हो, जैसे मेरा पीजी क्या करता सर मैं बताऊं, वो सीधे सीटी दिखाता है आजकल। मैंने कहीं बोला नहीं, फिर मैं रह नहीं पा रहा हूँ, सीधे मुझे सीटी दिखाता है और मेरी उसकी इतनी डांट पड़ती। हमने कहा भाई मैं इतना बड़ा डॉक्टर अभी नहीं हुआ हूँ कि सीटी देख के मैं बताऊँ तुझे, तो मुझे पहले हिस्ट्री बता, मुझे फिजिकल एग्जामिनेशन में बता तेरी डायग्नोसिस क्या है, फिर एक्सरे दिखाओ मुझे, देन यू सी द सीटी। एंड आई टेल माई एवरी पीजी कि आप इसी तरह जीवन भर काम करेंगे तो आपको अच्छे क्लिनिशियन बनने की एक सौभाग्य मिलेगा। और सीटी देखेंगे सबसे पहले तो शायद उतना सौभाग्य नहीं मिलेगा। So that's very beautiful things in clinical medicine is there, provided you practice it.
सर वेरी ट्रू सर, आपने बिल्कुल सही कहा सर। हिस्ट्री टेकिंग पहले भी बहुत इम्पोर्टेंट थी, आज के सिनेरियो में भी इम्पोर्टेंट है। और हिस्ट्री टेकिंग में जितना हम टाइम देंगे पेशेंट को, जितना ज़्यादा इंटरेक्ट करेंगे, जितने उससे क्वेश्चन पूछेंगे, फैमिली हिस्ट्री, पर्सनल हिस्ट्री, सारी हिस्ट्री जब लेंगे, बहुत सारी चीज़ें उससे जो हैं एक जो है प्रोविजनल डायग्नोसिस मन में एक बन जाती है। उसके बाद में फिर इन्वेस्टिगेशन की बात तो बाद में आती है, जस्ट टू कंफर्म द डायग्नोसिस। थैंक्स।
Actually, we are running short of time, so we are closing the session. Thank you.
यादव जी हमसे पूछ लीजिएगा।
थैंक यू सर।
थैंक यू सर।
क्या करें भाई, जाएं आप नीचे कि अभी हम हैं ऊपर? जल्दी करो यार, टाइम हो रहा था।
Thank you, sir. May I request Professor Behra sir to please come on to stage and felicitate our speaker and chairperson. Professor Rajan Prasad sir. Dr. Ram Narayan Narrawat sir. Professor Ajay Verma sir. Dr. Atul Tiwari.
Moving ahead to our next session, because of some urgent work, we are preponing the session of Dr. Gaurav Pandey sir. Our next session is about food allergies and eosinophilic esophagitis. May I request the chairpersons to please grace the stage and take their seats. Dr. Ajay Kumar sir, Professor, Department of Medicine, KGMU. Dr. Anil Gangwar sir, Consultant Gastroenterologist, Vivekanand Hospital. Dr. Satish Kumar sir, Assistant Professor, Department of Medicine, KGMU.
So good afternoon. Now we would like to invite Dr. Gaurav Pandey. He is Professor in Department of Gastroenterology in SGPGI, Lucknow. He is one of the most energetic, enthusiastic academic leaders in the field of gastroenterology of this era. So definitely we are going to enjoy his lecture. Sir, now over to you.
Okay, Professor Prasad, Professor Ved Prakash, respected chairperson, it's indeed an honor to be back here. My parents are alumni of this institute, and this is the first time I got an opportunity to come and discuss a topic with you. It's a real privilege. So we had fantastic lectures about how to diagnose allergy. I'm going to discuss two small aspects of allergy. One is food allergy and other is eosinophilic esophagitis. So I'll be discussing on these headings. So first of all, the important point of food allergies, is it allergy or is it food intolerance? Both in common terms are taken as this one and same thing, but they are completely different. The food allergies are adverse effects because of immunological mechanisms, while tolerance can be referred to difficulty in digesting or metabolizing a food product. Food intolerance is pretty common. It's around 20% of population has food intolerance, and especially in gastroenterology, we see a lot of people with irritable bowel syndrome, and people with irritable bowel syndrome up to 50 to 80% may have food intolerance. The important issue is it is not immunological. So if you have adverse food reaction, it can be immune mediated or non-immune. Immune mediated can be IgE mediated, that is predominantly have clinical symptoms of anaphylaxis, urticaria, oral allergy syndrome. Non-IgE mediated are basically enteropathy or involving the gut. You can have mixed IgE and non-IgE mediated and cell mediated. While non-immune mediated can be metabolic, it can be milk intolerance, it can be coffee intolerance, or because of toxic materials or others. These are just to give a overall heading, non-immunological adverse effects of food. It can be gluten, reflux, carbohydrate malabsorption, seafood, intolerance to caffeine, so many other things. The list is pretty long, but this is just to give an overview of non-immunological adverse food reactions that are not food allergy. Coming to epidemiology, the issue is it affects the quality of life. It's confused with food intolerance. Allergy is different. And the burden is up to 10% of Western world, and India up to 6% of people may have this. It's predominantly seen in children, male predominant in adults, it's females more than males.
So prevalence of food intolerance, if you look at the percentage of food intolerance in people who have bronchial asthma, if you just take asthma patients and ask the history, so 60 to 70% of people will have intolerance to dairy foods or seafoods or some types of fruits or grains or meat. Nuts is again a very common sort of food allergy. So they go hand in hand. Asthma is separate and food intolerance is separate, but many of these people with asthma have definite food intolerances. The burden it's in two phases. One is in the young, the other is in the adult phase. In India, predominantly we see this in the second phase, adults between age 20 to 50 years of age, and multiple foods. There's a whole list of more than 2 dozen foods that can cause that. The prevalence of food allergy in adults can be seen up to 26% and children up to 20%. So this you see a graph of prevalence of self-reported adverse effects to any food. In India, if you take a proper history, you can get 20% of people coming to OPD with self-reported adverse effect to milk or gluten or peanuts or seafoods, or in multiple foods you can have this allergy, and 20% is a big number. Coming to prevalence of sensitization to any food, again this number is more than 20%. Up to almost 28 to 30% of people in India, studies have shown that they can be sensitive, they can have sensitization to a particular food. So coming to symptoms of food allergy, symptoms are adverse health effects that are reproducible. The manifestation depends upon the mechanism of action, IgE mediated, non-IgE mediated or mixed type. Variations can be, in infants it can be eczema, in adults commonly oral allergy is a common syndrome that people have. So what are the common manifestations of IgE mediated and non-IgE? So IgE has the more severe manifestation of urticaria, angioedema, oropharyngeal symptoms, respiratory system symptoms like asthma, allergic rhinitis, conjunctivitis, GI and anaphylaxis, that is the most severe one. Non-IgE mediated are basically linked to GI tract, that they can have proctitis, proctocolitis, enteropathy of small bowel, proctitis with proctocolitis involving rectum and colon. Occasionally they may have food-induced pulmonary hemosiderosis, protein-induced enteropathy. Celiac is again a common issue that we see on day-to-day practice in our OPDs, and skin allergies. Coming to the mixed picture of IgE and non-IgE mediated, we can have atopic dermatitis, eosinophilic esophagitis and eosinophilic gastroenteritis. So in a nutshell, we have three different classes, IgE, mixed and non-IgE mediated. Coming to the clinical manifestations of IgE mediated, since IgE is systemically involved, it has multiple manifestations depending from skin involvement to eye involvement, respiratory tract involvement, cardiovascular, GI and neurology. So manifestations can be many folds, multi-folds, and each patient may have multiple organs involved because of IgE mediated allergy. So history becomes very, very important. What are the factors that make these allergy reactions more severe? If the person can have more severe food allergy if he has concomitant asthma, he takes alcohol or any other drugs like aspirin, which can increase the intestinal permeability. Because here the gut-brain barrier is altered and you have more immunogenic materials going into the systemic circulation and more IgE productions. Some food allergy are linked to exercise, exertion or stress, as psychological stress was discussed in the last lecture. Concomitant viral infections, lack of sleep, stress and during menstruations. So these factors can make the food allergy much worse. The common offending foods are egg white, hen egg white, cow's milk, peanuts, tree nuts, sesame foods, fish, shellfish, wheat, soya bean, kiwi, apple, carrot and peaches. With that, there is a lot of cross reactivity to pollens and to plants. So there are multiple plants and pollens that cross react to that. If you do skin prick test, you can be sensitive to apples, but if you take the history, patient may be eating apples and may not have any allergy. This is because of cross reactivity pattern that these skin prick tests show on testing. So the common types of IgE allergy are oral allergy syndrome, seafoods, peanuts and cow milk. These are the 4 common types that we see on day-to-day practice. The oral allergy syndrome is the commonest. Thankfully, it is a mild form, and basically it's the heat labile proteins which within these foods that cross react with allergic pollen proteins that are there in the environment. In India, this is one of the studies published way back in 2016 showed the common allergens that we see on a day-to-day practice. So shrimps are the commonest and lenticels are least common. The incidence varies from 16% to 8%. So pathogenesis, food allergy can be class 1 or class 2. Class 1 can have up to severe allergic symptoms and anaphylaxis. Basically, it is because of primary sensitization via GI tract with digestion resistant food allergens. And class 2 allergies are respiratory sensitization followed by cross reactivity with easily digestible food allergens. So that is the basic difference between how class 1 and class 2 food allergies are precipitated. Again, class 1 are more severe form and are because of primary sensitization by GIT with digestion resistant food allergens, and class 2 is respiratory sensitization followed by cross reactivity. So clinical manifestations normally involve cutaneous, GI, respiratory and anaphylaxis. This is the most severe. Cutaneous are atopic dermatitis, DH, acute urticaria, angioedema. GI includes enterocolitis, colitis, esophagitis, proctocolitis, enteropathy and acute allergy syndromes. Respiratory are rhinoconjunctivitis and bronchospasm, and anaphylaxis obviously leads to shock. So again, history becomes very important. Family history, personal history, age of onset, first time when he develops, breastfeeding, occupational environment history, symptom types. It's IgE mediated that we discussed a whole plethora of symptoms or non-IgE mediated. So history again becomes very, very important once you want to analyze the type of allergy and which subtype it falls into, IgE or non-IgE or mixed type. Again, a number of organ involvement, duration of onset, all these things are very, very important, especially if you want to assess the allergic component of the person. Again, to diagnose, acute is IgE mediated and subacute or chronic is cell mediated. This is just a broad overview. Acute allergic presentation are obviously IgE antibody screening or skin prick test has to be done. Negative rules out hypersensitivity reaction, but positive IgE is not diagnostic. It has to be followed by challenge tests. And then you have the cell mediated allergic reactions with biopsy based on clinical site involvement. So these are the few common diagnostic modalities that are used. Oral food challenge, though the gold standard, is expensive and impractical, not commonly done. The skin prick test is commonly done. It has high sensitivity and high negative predictive value, though the specificity is low. Allergens are induced subcutaneously to detect the IgE reaction to subcutaneous because of masses to the subcutaneous allergens, and you develop a wheel, and how big is the wheel? It's less than 3 mm, more than 3 mm, or how big it is. So multiple allergens can be tested during one go in skin prick test. Others are there but not very commonly used. So coming to management, what you have to do is to identify and eliminate the offending agent if it is one. If it is multiple, again it becomes a challenge. Education is very, very important depending upon history. And look at IgE mediated allergy that can cause anaphylaxis. So these patients should have an injection kind of epinephrine that is now commonly available in West to tide over an acute sudden reaction. Therapeutic interventions, avoid allergens, carry epinephrine auto-injectors. Novel therapy includes immunotherapy. Immunotherapy can be oral, sublingual or epicutaneous. Its benefits are desensitization versus obviously there is some challenge of risk of adverse reactions. Long-term strategy is not only to avoid but avoid with treatment. Introduce less allergen forms of food first and raise the reaction threshold. It can be done by oral immunotherapy, and omalizumab anti-IgE may help. So this is a nutshell, the picture that tells you about what are the various therapeutic modalities. It can be oral immunotherapy, mucosal allergen immunotherapy, biologicals including omalizumab, and gut microbiota alteration. That is an upcoming developing field. Not much evidence is there, but definitely one of the important mechanisms through which food allergy can be tied over. So coming to immunotherapy, it is happening and catching up fast with all of us. It can be oral, sublingual or epicutaneous. Oral is basically used for food allergies specifically. Sublingual is for multiple environment allergies, and epicutaneous various allergies, it's still under evaluation. So food allergies, oral immunotherapy, GI tract, since it gets absorbed in GI tract, the goal is to build tolerance, reduce reaction. Sublingual is for all environment allergies. It's basically given below the tongue. It basically is absorbed from the mucous membrane and induces tolerance and decreases symptoms. So a recent paper on allergen immunotherapy and or biological was analyzed. It was a systemic review and meta-analysis. It had around 40 trials with more than 2,240 patients. So they gave a thumbs up to oral immunotherapy and epicutaneous immunotherapy. What is the effect of adding biologicals to it? It's still a science in evolution. So this study of 40 trials based on this gave a big thumbs up to immunotherapy. Addition of biologicals may help, but obviously it's an evolving field. This was in 19. Then we have multiple papers coming after 19. This paper of omalizumab to treat multiple food allergies came in February this year. They said that if you gave omalizumab for treatment of multiple food allergies, you look at the response over placebo. Around 70% of patients were able to tolerate more than one food through which they were allergic to. So at least 75% of patients could tolerate, at least 50% of patients on omalizumab could tolerate. So biological have definitely altered the amount of food allergy and the number of food allergens that are there with immunotherapy. Recommendations to prevent food allergy: early life dietary interventions, introduce food allergic foods during 4 to 6 months window, go slow, avoid maternal tobacco and encourage breastfeeding as has been discussed. Coming to complications that are predominantly esophagitis and gastroenteritis, I will be discussing eosinophilic esophagitis after this. And obviously anaphylactic shock is the most dreaded and severe one for which a person should have adrenaline injection. Prognosis does depend upon many allergic limitations, however nuts and shellfish persists. Coming to the second topic of the complication because of that, one of them is eosinophilic esophagitis. So what is eosinophilic esophagitis? It's a chronic immune antigen mediated esophageal disease. It's an immune antigen mediated, involves the esophagus, characterized by esophageal dysfunction. It can be motor or mucosal, histologically by eosinophil predominant inflammation. Symptoms can be dysphagia or food impaction, feeding problems, pain or vomiting. How do you diagnose? When you take esophageal mucosal biopsy on endoscopy, more than 15 eosinophils per high power field diagnosis esophageal eosinophilia. The pathology is same as food allergens. You have inflammatory protein mentioned on the first. Inflammatory proteins react with cellular receptors, lead to proliferation of immune cell population that lead to inflammation, lamina propria damage, fibrosis, dysmotility, that's again a mechanical problem, and increased epithelial permeability. So from the esophageal lumen involves the squamous epithelium and then the lamina propria and muscularis. So the pathology also, the symptoms also evolve on pathology. If the person develops dysphagia, it means lamina propria or muscularis is involved. He has formed a stricture. If it's just pain, it may be just a mucosal involvement. So it depends upon the degree of involvement, the clinical symptoms does vary. Symptoms in adults predominantly, it has been probably long-standing dysphagia, food impaction, muscularis mucosa is involved. In children, it's feed intolerance, failure to thrive, regurgitation reflex, predominantly mucosal involvement, though pain, nausea and vomiting may still occur in both. So again, importance of history. Again, ask the patient again and again, do you need liquids to eat meal or swallow the food down? Food does not go down naturally. Do you cut or puree your food? It's difficult to eat solid foods. You want more liquid or more watery content in food. Are you a slow eater? You take longer time to eat compared to all your family members and friends. You are still at the table, chewing your food slowly. You turn away from foods or avoid pills. You are not able to swallow pills. These are very important history points that we commonly miss. Do you use concomitants or to lubricate your food like water? Do you avoid social situations for fear of impaction or avoid eating on social settings? These are very important clinical settings for patients diagnosed with eosinophilic esophagitis. EGD with esophageal biopsy is necessary. You have to take biopsy at least on 2 different locations, proximal and distal half. 6 biopsies are required. There is a particular score that tells us the severity of disease. The score looks into the edema or the loss of vascular pattern, ring formation or trachealization of the esophagus. You look at the grade 3 formation of rings. These are circular rings that are going from top to bottom. So advanced disease, mucosa is involved. Exudates in the esophagus that are white plaque, seen again in the third picture very clearly. Longitudinal furrows are formed and strictures and out strictures can form. So endoscopy gives you the grading and severity of the disease. Again, these are endoscopic features showing the ring and exudates that are there in edema formation and furrows seen very clearly. This is again endoscopy picture correlating with histology, multiple esophageal rings, linear furrows, and in histology you can see more than 15 eosinophils per hyparchy. You can see the pink dots that are eosinophils. Again, you can see eosinophilic abscess on the right side, and you can see a well-formed stricture there, more than 15 eosinophils per hyparchy. So, upper GI endoscopy gives us a reasonable idea of the severity of disease and does correlate with the symptoms that the patient has. This is high-resolution manometry. Upper GI endoscopy tells us about the lumen. Manometry tells us about the distensibility. How is the peristalsis of the esophagus? Is the esophagus able to accommodate or not? Distensibility is normal or reduced. If it is reduced, it can have a fibrostenotic pattern or a spastic pattern or a non-reactive fibrostenotic pattern. So manometry helps us subclassify the mechanical problems of esophagus. There are multiple emerging options to diagnose that, including tissue samples and few complementary studies, including the esophagogram, double contrast barium, that is commonly done for a long time. So the primary goal is to improve the symptoms and quality of life, improve nutrition, prevent complications, prevent food impaction, stricture and perforation. Treatment endpoints are based on symptoms and histology. So look at the symptoms, try to find out various treatment modalities to cure his symptoms, histology, and obviously endoscopic activity to look at remission of disease. Once you start the treatment, these allergies are very difficult to get rid of completely. So you have to realistically look at the severity of disease, and once you assess the response, is it complete normalization, partial response or non-response? There are definite criteria of histology based and clinical symptoms and endoscopy to define complete normalization, response and histology, depending upon what he had and what he developed with therapy after 4 to 6 months. So initially when a patient comes to us, the most important thing is to rule out secondary causes of esophageal eosinophilia. You should not rule that out. Most important is GERD, that is so common in our population. So again, a proper history taking will give you a clue. Again, there is a whole list of secondary causes of esophageal eosinophilia. That is ruled out. We are looking at eosinophilic esophagitis. Look at the severity after endoscopy, then decide about the therapy. So get an upper GI done. Look at the upper GI. Is it normal or you grade through the severity? ERFCR scoring that we discussed in detail, or you have a focal stricture that is there. So look at the severity on endoscopy. If it is normal, do biopsy. Eosinophilic esophagitis is proved, then consider treatment. First choice is PPIs, that works very well in this. If that fails, then topical steroids, dietary intervention. If stricture, it requires dilatation. So first simple things for us clinician on eosinophilic esophagitis: stricture present or stricture absent. If stricture absent, we are very happy. We need not dilate the patient or go for aggressive therapy. Medical therapy. PPIs are the first. After PPI, it is oral steroids. If that fails, then comes the dietary therapy. Empiric elimination, targeted elimination, or elemental formulas. And if he has strictures, it is endoscopic dilatation that we commonly resort to. Rarely do we require surgery here. So for patients who do not have a stricture, eosinophilic esophagitis proved on biopsy, PPI 8 weeks. First line PPIs, our routine PPI for 8 weeks, the BD dose. PPI responsive, you are very happy, patient has benefited, that's the end of the story. If he does not respond to PPI, then you consider topical steroids as a second line. Topical steroids, with that, plus minus dietary therapy. Now topical steroids, commonly it can be in the liquid form like you have budesonide, powder form like fluticasone, or inhaled fluticasone. So how to make this liquid slurry, all these has been given. You have to add honey, or you add honey with the sucralose packets, or you dilute that so that the viscosity is increased and it stays in the esophagus for a long time. Your purpose has to get budesonide in the esophagus for a long time, so you add honey and other agents that increase the viscosity. And then you have powder form or inhaled form also helps. And then you have to maintain these people on long term. So what is the evidence for steroids? Most of the guidelines, American Society do recommend topical glucocorticoids. The recommendation is strong, quality of evidence is good. It does benefit patients with eosinophilic esophagitis. Topical steroids, which one? Fluticasone, budesonide. It's around 70% versus 78% to budesonide. Budesonide slightly nudges above fluticasone. Head-to-head trial, you see percentage of people with histological response. Budesonide slightly better, but p-value is not significant, 0.38 versus fluticasone. Total ERSRS score response, budesonide, fluticasone, p-value is 0.06. It favors budesonide, but p-value is not significant. So you can choose either budesonide or fluticasone. Challenges are maintenance dose, not very well defined. Minimum dose to maintain remission, not very well defined. In initial responders, when you reduce the steroids, again there is a risk of disease coming back. Because 1 year data, once you reduce the dose, 36% only maintain histological remission, and 5 year data, only 16% do that. So that's a challenge, how long to continue topical steroids. If you have a stricture requires dilatation, it can be through the balloon, wire guided, or simple boogie dilatation. Once you have done that, symptoms are persisting, then comes the role of targeted diet, elemental diet, and if that fails, long-term steroids or biologicals. So elemental diet, elimination diet can, first elimination diet, then elemental diet. Elimination diet can be 2, 4 or 6. First eliminate dairy and wheat, that are the most common. Doesn't work, eliminate dairy, wheat, egg and soy, that is again for 6 weeks. If that doesn't work, then go for 6 food elimination diet. That includes dairy, wheat, eggs, soy, nuts, fish or shellfish. So from 2 to 6 food elimination diet, you will catch, these are the common 6 allergens that cause a food allergy, then you should be able to catch which of them is causing food allergy in more than 90% of patients. Then you can start on elemental based diet or empirics. After that, introduce food one by one, and then target the elimination diet. Biologicals, evolving food. Dr. Alok Nath would be talking about biologicals, so I'm just giving the names that can be used. These are all upcoming ones. Dupilumab, benrazolimab, phase 2 evidence to suggest it's useful in food allergy. Drug called CC93538, again phase 3 trials are ongoing. Phase 2 trials just suggest great improvement in food allergies. And lerontelimab, which is again a monoclonal antibody to sialic acid binding immunoglobulin like 8. Again phase 3 trials are ongoing. So for food allergy, all these four biologicals do suggest some promise in near future. Meprazolimab again is a monoclonal antibody to IL-5. It's FDA approved for asthma. Multiple trials for food allergy are still ongoing. So for future directions, new biomarkers biologicals should help. Though the issue is adherence to treatment. Adherence to food, very difficult to manage. Adherence to biologicals, long-term, oral steroids, long-term, very, very difficult to manage. So strict adherence to any treatment form is challenging in these patients. Again, lot of moral support has to be given from family and physicians alike. And treatment many a time has to be personalized based on history. History is very, very important when you treat this. So have a personalized treatment approach. So coming to take-home points, diagnosis requires symptom severity. You have to assess them. Current line of treatment includes PPI as the first line. Dilatation of esophageal strictures is again, any dilatation or therapeutic procedure does have complications. So better to avoid patients reaching that point, and cost-effective personalized care should be given. Thank you.
Thank you so much, sir, for delivering a wonderful and exceptional session. Sir, thank you so much for your sharing knowledge, and we have really achieved a lot from you. Now questions are welcome from the house, and only few questions are welcome.
Any question from the audience? As sir wonderfully covered, this is the common topic is the food allergy, and the rare topic is the eosinophilic esophagitis and the eosinophilic gastroenteritis. Usually this topic is usually underlooked by the physician and even gastroenterologist because of the eosinophilic esophagitis has very variable presentation. In the rarely have the dysphagia, we get in the advanced cases when there is stricture formation. And new therapy about the biological, that the dupilumab, I want to ask about the pulmonologist, do they have about the any experience in the bronchial asthma, or because we don't have experience in eosinophilic esophagitis. This is the only FDA approved medicine available in the USA. Is it available in India? Alok sir?
There are large number of good randomized controlled trials for the use of dupilumab in moderate to severe uncontrolled severe asthma, and they have been known to decrease exacerbation, decrease the oral corticosteroid dose, as well as they reduce the number of exacerbation ED visits, and decrease the dose of inhaled corticosteroids also. So there is good experience of dupilumab in bronchial asthma. For eosinophilic esophagitis, I am not aware of any good randomized controlled trials. Except for dupilumab, we have IL-5 anti-IL-5 therapies also. This is dupilumab is IL-4 against IL-4, and benralizumab, reslizumab, and mopelizumab. These are three monoclonal antibodies which are there against IL-5 anti-IL-5 therapies. And these have wonderful results in moderate to severe uncontrolled bronchial asthma, and decreasing the oral corticosteroid. Those who are OCS dependent, in those patients, the OCS dose comes down. The number of exacerbations remarkably comes down to the tune of 70% reduction in exacerbations, and sustained benefit in these patients is also seen. These are controlled there is now literature that they are even controlled at the end of 5 years also. There is sustained benefit and improvement in lung functions also. So there is good number of mepolizumab is available in India, benralizumab is available in India, dupilumab is also available in India. Now newer ones, that is tezepelumab, that is for non-atopic asthma. I mean non-eosinophilic asthma also, that is useful. That has also been launched in India, but the wider availability is for IL-5 therapies, and omalizumab obviously was the first one to be launched, and we have 20 years experience of, more than 20 years experience of omalizumab now.
Thank you, sir. Sometimes patient, when we advise about the topical steroid, inhaled steroid, fluticasone, then patient says, oh, this is the asthma medicine, why you use in the eosinophilic esophagitis? Then we can say to the patient, basically you have the asthma of the esophagus. This is the eosinophilic esophagitis, then we can counsel like this. Thank you, sir.
Dr. Kaur, one question. Fantastic coverage of both the topics, as usual. So, two questions. Number one, suppose we are sitting in a gastroenterology clinic or in suppose general medicine clinic. Most of the food allergies or even eosinophilic esophagitis, they will present either with dysphagia, abdomen, diarrhea. A lot of diseases also will present. When to suspect these two topics?
Basically, my experience has been, we hardly see severe form of anaphylaxis. In our day-to-day practice, we do not see IgE-mediated reactions. They normally go to emergency medicine or general physician when they have severe and florid manifestations. We normally see non-IgE-mediated food allergy or food intolerance. Food intolerance or IBS, we are experts, you know, as soon as patients say, all of us would say, okay, this is IBS. So it doesn't require a lot of rocket science. A lot of experience for everybody, I'm sure that is there. Coming to the non-IgE mediated food allergy, that requires detailed history taking. History gives you a clue. How severe, how bad, when it started, what were the exacerbating months or exacerbating psychosomatic issues that the patient had, and how has it manifested. What is the progression being like? So if you go to detail, give 5 minutes extra for these patients, you should be able to diagnose most of them.
Thank you. Where would you like to put the manometry in the algorithm, in the workup, in the eosinophilic esophagitis? Manometry.
Manometry, yes. So manometry, basically, commonly, what you do is that if the esophagus does not distend, again it's a problem. Second thing, once you are doing a manometry, you just instill 5 ml of water. Look at the peristalsis. You have your thing for
probably I could not explain the question to you. We are suspecting a dysphagia present eosinophilic esophagitis. So in the algorithm, when to order manometry? We did barium upper GI endoscopy.
If he has dysphagia and he does not have a tumor or a frank stricture, you should go ahead with the manometry. It can be achalasia or it can be eosinophilic esophagitis or any of these motility disorders. Achalasia, again, multiple subsets are there. So, and how to suspect, even if you are not seeing a stricture, once you are doing an upper GI, look at the distensibility. You are not able to distend that. Doing an upper GI, just instill 5 ml of water. Look at the peristalsis. Peristalsis is not happening. You may have a normal GE junction, but absence of peristalsis is simple water ingestion. You should think that probably there is something else to it that you are missing. Go and then ask for a
Thanks a lot. Now we can. So any question from the house? If not, then we can close the session. Fantastic. Enjoyed a lot.
Thank you, sir. I now request Professor D. Vega, sir, to kindly come to stage and felicitate our guest speaker and chairperson. Dr. Gaurav Pandey, sir, please come on stage. Dr. Ajay Kumar, sir. Dr. Ajay Kumar, sir. Dr. Anil Gangwar, sir. Dr. Satish Kumar, sir. We will, we will begin inauguration ceremony in a while. Please be seated.
नहीं बोलेंगे जब आएंगे। I'd like to think that here and there, when I'm gone, there shall remain a happier spot that might have not existed had I toiled for gain. That I had taken gifts divine, the breath of life and manhood fine, and tried to use them now and then in service of my fellow men. These beautiful lines from the poem Compensation by Edgar Albert inspires us to return to the society what we have gained from it. And this holds apt and true to us doctors and our medical education, where we continue to learn and grow throughout our lives to serve our patients, our fraternity, and the population at large in the best possible way.
Thank you, sir. So, we will begin the inaugural function by inviting on stage our esteemed dignitaries who have joined us here. On the behalf of department, we welcome our Chief Patron, Dr. Sonia Nityanand Ma'am, Honorable Vice Chancellor, KGMU. Welcome, ma'am. Taking our event further, we welcome our chief guest, Padam Shri awardee, Professor Digambar Behra sir. He is an ex-professor and head of Department of Pulmonary Medicine. He is Director, Pulmonary Medicine, Fortis Healthcare, Mohali, Punjab. Welcome, sir. Moving ahead, we heartily welcome our guest of honor for the event, Dr. Pinky Joel ma'am, IAS. Now I would like to invite our special guest, Professor P.C. Kathuria sir, Senior Consultant, Department of Allergy and Asthma, BLK Super Speciality Hospital and National Allergy Center, New Delhi. Welcome, sir. Professor V.K. Jain sir, Department of Respiratory Medicine, MG Medical College, Jaipur. Welcome, sir. Professor Suryakant Sir, past President of Indian College of Allergy, Asthma and Applied Immunology and Head of Department of Respiratory Medicine, KGMU. Welcome, sir. We cordially welcome Professor Dr. Rajendra Prasad Sir, Organizing Chairman of Allergy Asthma Conclave 2024, ex-Director VP Chest Institute, Nainital Academy of Medical Sciences and Director Medical Education, and Professor Department of Pulmonary Medicine, Eras Medical College and Hospital. We also invite on the dais our guiding force and mentor, Professor Ved Prakash Sir, Head of Department of Pulmonary and Critical Care Medicine, KGMU, and Organizing Secretary of Allergy Asthma Conclave. I would like to invite Professor Alok Nath Sir. Okay. I would like to invite Professor Suryakant Sir, Post-President of Indian College of Allergy, Asthma and Applied Immunology and Head of Department of Respiratory Medicine, KGMU. We also invite on the dais our guiding force and mentor, Professor Ved Prakash Sir, Head of Department of Pulmonary and Critical Care Medicine and Organizing Secretary of Allergy Asthma Conclave 2024. Welcome everyone. Now we request our Organizing Secretary, Professor Ved Prakash Sir, to felicitate our esteemed dignitaries with sapling. First, I request him to felicitate our Chief Patron, Dr. Sonia Nityanand Ma'am. I request him to felicitate our chief guest, Professor Digambar Behra, sir. So please welcome Professor PC Katuria, sir. Professor VK Jain, sir. Professor Alok Nath, sir. Professor Suryakant, sir. Professor Rajendra Prasad, sir. Now I request our chief guest, Professor Sonia Nityanand ma'am, to felicitate our organizing secretary, Professor Ved Prakash. Welcome. To welcome our I request Dr. Pinky Joel ma'am to come on the stage, please. Welcome, ma'am. She's a IAS Mission Director, National Health Mission, Uttar Pradesh. Welcome, ma'am. I request Professor Ved Prakash sir to welcome Pinky Joel ma'am. With this, May I invite our chief guest and the honorable dignitaries seated on the dais to light the auspicious lamp.
दीपो हरतु मे पापं सन्ध्यादीपो नमस्तुते दीपो हरतु मे पापं सन्ध्यादीपो नमस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदा शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदा भोगी ब्रह्मारूपस्तवं ज्योतिषा प्रभुराव्या भोगी ब्रह्मारूपस्तवं ज्योतिषा प्रभुराव्या आरोग्यं देहि पुत्राश मति स्वच्छाहि मे सदा आरोग्यं देहि पुत्राश मति स्वच्छाहि मे सदा शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदा शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदा
Thank you for that beautiful recitation of Saraswati Vandana. Now I would like to invite our organizing chairman, Professor Rajendra Prasad sir, to kindly give the welcome address.
So good afternoon. Chief guest of today, Professor Behra, we are good friends for so many years. And then the dynamic Vice Chancellor of this university, Sonia Nityanand. Then Madam Pinky, I met her last time in last function probably here in the same hall. We were introduced to each other. Basically, whatever I know about her, she's basically a dental surgeon, so one of us. And then on the dais, there are so many senior, at least Dr. V.K. Jain, if I name them, he's my senior. When I was house officer, in those days, it was the nomenclature. He was the chief resident Mai. So we have worked from that time, I must say from 1976 to this time. So last more than 50 years, we are working together. Then we have our students, I must say, like Dr. Suryakant, and then Dr. Ved, and then Alok. I say them is to Alok, although the Ved and Suryakant were direct students, but I must say Alok is an indirect student. So, distinguished audience, many senior people are sitting in the audience, delegates, ladies and gentlemen, persons from press, media. As an organizing chair of this Allergy Asthma Conclave 24, first I welcome you all for this conclave. You know the word allergy and asthma, I'll not take too much time, but what I'll say, there's a great morbidity and mortality with both the diseases. You know, allergy is a very common, what has been said in the morning, that out of 3, 1 is suffering from one or another form of allergy. And in times to come, probably every other people will suffer from allergy. As far as asthma is concerned, the asthma, ideally, to my understanding, whatever I have a scientific knowledge about asthma till date, nobody should die of asthma. That is my feeling. And that is not what science also says. Nobody should die. But it is very unfortunate. Around 5 lakh people died asthma in previous years globally. India is not far less. Unfortunate part about India is that India has, out of those 5 lakhs, about 43% share is of India. Although the India population share is just around 20-22%, but you know the death from asthma share is more than 40%. That's very disturbing and very disturbing. And if I can trace out what is the cause, why people of asthma dying, it is only because of the poor education, maybe of doctors, maybe of patients, maybe of society. So very aptly, this word Asthma Day 24, if you read the theme of word Asthma Day, education, empowers. And that I am believing for last more than 40 years. So what I am trying to say, that the things are, education is a very important in preventing these deaths. Here I would not be able to stop myself by saying that recently, you know, NMC has made one rule which we are opposing as a chest physician, that during the MBBS curriculum, the Department of Pulmonary Medicine or TB chest, whatever you call respiratory medicine, is not essential. Well, that can be thing, but what I believe, if the teaching is not done by these people, and now we are teaching for last 50 years, at least KGMC department was 50 years back was established, more than 75 years, I believe. 46 it was. 46, yes. So when we are teaching, this is the state of affair of the doctors, and it is the state of affair of the people, of the society. And if these subjects will not be taught effectively, I don't say that it will not be taught. It will be taught by our medicine people, colleagues. But you know, that will, to my understanding, with this much of seniority, probably I said only senior than me is Professor V.K. Jain here in this audience, and one of the Dr. Muzammil, otherwise rest of, or most of them have been our students. So I think we should educate, as you do. Theme this year is also very, very appropriate, that education empowers patients of asthma. With these few words, I once again welcome you all and wish this conclave a grand success. Thank you very much.
Now I invite our chief patron for the evening, our Honorable Vice Chancellor, Professor Sonia Nityanand, ma'am. So Sorry, ma'am. I would like to invite our guest of honor, Dr. Pinky Joel, ma'am, to share her thoughts on the occasion.
Very good evening to all of you. Respected VC ma'am, Dr. Sonia, Dr. Rajendra ji, we met last time. Thanks for remembering me, and with the nitty-gritty also, you remember my qualification also. Professor Behra Sahab, and respected and dignitaries on the dais, and my dear friends here. So I'm sorry for a little bit late because I was engaged in a meeting. And I thank personally Dr. Ved Prakash for considering me to come and just have some understanding and knowledge of allergy, especially the asthma and other allergies related issues. Being ND NHM as well as a health secretary, definitely we deal with lots of health related issues, and sometimes very small things get left out because the bigger things like our communicable, non-communicable diseases, they take the front seat. But as Dr. Rajendra ji has already briefed you the basic background of asthma, कैसे उसका incidence है across the world, and what is the fatality rate and how we are doing it. And in our routine life में भी हम लोग देखेंगे आसपास में we find कि कितने लोग confused में रहते हैं कि उनको asthma है भी है कि नहीं है, because it's not that easily diagnosed. उनको समझ में नहीं आता कि it's because of asthma, and there are lots of allergies. Like I myself had an allergic rhinitis when I was in college. So a very seasonal one. It used to come and go. मतलब छोटा सा टॉवल लेके बैठते थे. Especially it used to happen during exams only. पता नहीं क्यों होता था ऐसे. तो बाद में देखा कि वो तो coincide कर रहा है सीजन के साथ में. खासकर जब गेहूं का जो कटाई है उसके साथ में it used to, and September October में जब pollens का जो मतलब अच्छा खासा flowers सब जगह होते हैं. It just happened and it went off automatically. उस समय मैं खूब ट्राई किया लेकिन नथिंग. आई डोंट नो व्हाट वाज द रीज़न इट स्टार्टेड, एंड बिकॉज जब हमने एक बार ट्राई किया कि टेस्ट किया जाए तो देयर एन नंबर ऑफ टेस्ट. किस एलर्जी का टेस्ट करेंगे, वी रियली डोंट नो. बट डेफिनेटली एलर्जी इज़ अ सिम्टम ऑफ समथिंग विच इज़ ऑलरेडी एग्जिस्टिंग इन आवर सराउंडिंग्स. सो द कॉजेटिंग एजेंट इज समवेयर एल्स. जैसे हम आज बात कर रहे हैं कि बाहर बहुत गर्मी है, क्या ये गर्मी अचानक हुई है? नो. सो देयर इज़ अ रीजन बिहाइंड इट. कि क्या रीजन है उसके पीछे? कि रीज़न ये है कि क्लाइमेट चेंज में आपको फील हो रहा है. हमारे जो बड़े बुजुर्ग, बहुत ज़्यादा नहीं, 2-3 जनरेशन पहले के ही लोग रहे हैं, जो आप उन्हीं को देख लीजिए, अपने दादा दादी तक ही जाइए, पेरेंट्स को अगर हम छोड़ भी दें एक स्टेज में, तो उनको इस तरह की बहुत ज़्यादा, मैंने तो कभी नहीं देखा कि मेरे किसी दादा दादी को जो 100 साल के होकर they left for the heavenly abode, उनमें से किसी को जुकाम या बुखार या खांसी भी होता था. रीज़न यही था कि क्लाइमेट हैड रियली प्लेड अ बिग रोल, और उनका हेल्दी लाइफस्टाइल. दो चीज़ें आई वुड, बिकॉज आई एम नॉट एन एक्सपर्ट इन टू इट, सो आई कॉन्ट गो इन टू द एक्सपर्ट थिंग्स, एंड वो एक्सपर्ट्स के लिए छोड़ देते हैं, आप सब एक्सपर्ट स्पीकर्स के लिए. बट जो मुझे लग रहा है कि हम सब लोगों को वी शुड प्लांट मोर ट्रीज, we should save more water, we should use as far as possible. हालांकि मुश्किल है, जो डीजल पेट्रोल हम लोग खर्च कर रहे हैं, अगर हम उसको कम कर सकें, जिसके पॉल्यूशंस बहुत ज़्यादा, जिसकी वजह से पॉल्यूटेंट्स क्रिएट होते हैं. काफ़ी हद तक एनजीटी ने और हमारी डिफरेंट कोर्ट्स ने और लोगों के खुद के लोगों के अपने एक्टिव कंट्रीब्यूशन से पटाखे कम हुए हैं. दिवाली पे, हर चीज़ पे हम शादी ब्याह में खूब पटाखे बजाते हैं. वी डोंट नो कितने लोगों को उससे एलर्जी है, खासकर जो एस्थमेटिक है उसके लिए लाइफ कितनी हेल हो जाती है. वी ऑल नो कि इट इज़ सो डिफ़िकल्ट टू रीच टू सम पार्ट्स ऑफ द कंट्री ड्यूरिंग पर्टिकुलर सीजन्स. एग्रीकल्चर में हम लोग पराले जला देते हैं, इंस्ट्रक्शंस हैं, मगर हर काम गवर्नमेंट नहीं कर सकती है, हर काम इंस्ट्रक्शन से नहीं चलता है, हर काम कानून से नहीं होता है कि सिर्फ कानून है, कानून का इम्प्लीमेंटेशन है. सो एज अ गुड सिटीजन्स आई थिंक we need to focus on, apart from the medicine part, diagnosis, treatment and prevention, we should be focusing on our community का क्या contribution होगा उसमें, that we should be focusing. NHM में एक बहुत छोटा सा component है climate change को लेके, which we take care for heat, लू लग जाना से, सर्दी में कुछ issues हैं इस तरह के, but specifically talking on allergies, I think we still have to open our book to read the chapter. So good, you gave me an idea and a topic to think upon it, and the people who will be dealing with this, because जब हम लंग्स की बात करते हैं तो लंग्स में बड़ी बीमारियों को लेके ही हम सीमित रह जाते हैं, लेकिन इनकन्वीनियंस और प्रोडक्टिविटी किसी इंसान की अगर घटती है तो उसकी फाइनेंशियल सिचुएशन पे भी असर पड़ता है. तो प्रोडक्टिविटी कब घटती है? जब उसकी रूटीन की चीज़ों में दिक्कतें आती हैं. बहुत बड़ी चीज़ है जैसे कैंसर है या उसको कोई बहुत बड़ी न्यूमोनाइटिस होगी तो वो हॉस्पिटलाइज हो जाएगा, ठीक हो जाएगा. बट अस्थमा, इफ़ इट इज़ लाइक इट्स देयर फॉर एवर काइंड ऑफ. तो ऐसी चीज़ें जो वंस फॉर एवर काइंड ऑफ हैं और देखने में बहुत छोटी हैं, जिस पे हम लोग नॉर्मली ध्यान नहीं देते हैं. आई अप्रिशिएट द होल टीम ऑफ KGMC कि इन लोगों ने आप लोगों ने इतना इसको एक स्पेसिफिक कॉन्क्लेव बना के यू हैड कॉल्ड सच गुड एस्टीम्ड स्पीकर्स एज वेल एज you are sensitizing us, and I am thankful to you all also to sensitize me also on this topic. But this will, if this is taken up at a very serious stage, because there is lots of IC need to be done. बहुत लोगों को पता ही नहीं कि हम अस्थमा का करना क्या है, आइडेंटिफिकेशन कैसे है और ट्रीटमेंट कैसे है. वी डोंट नो, एक्चुअली मेजॉरिटी ऑफ अस डोंट नो. बीइंग मेडिकोज यू मस्ट बी नोइंग इट, बट एज एन आम आदमी मुझे नहीं पता है, या एज एन आम आदमी हमको नहीं मालूम है कि हम सरकार और हम लोग क्या कर रहे हैं उसको लेकर. So good, you have given me a topic to think and ponder upon it. Thanks for calling me, and I'll not take much of your time. So I feel gratitude towards Dr. Sonia for thinking of me, and Dr. Ved Prakash and Dr. Rajendra ji for especially mentioning my name. Thanks a lot. Thanks all of you, and just listen, क्योंकि छोटे छोटे चीज़ों से लाइफ, जो डॉक्टर की और वकील की लाइफ वही होती है जो जितना ज़्यादा सीखेगा, जितना ज़्यादा सुनेगा, जितना ज़्यादा प्रैक्टिस करेगा, वो उतना ज़्यादा औरों से बेहतर होगा. वरना 5 साल की पढ़ाई तो आप सभी करते हैं, 5 साढ़े 5 साल की. आप में और बाकी लोगों में अंतर क्यों होता है? क्यों एक बहुत बढ़िया एक्सपर्ट हो जाता है कि नहीं उसके पास जाओ, उसके पास मिलेगा इलाज, जो है वो बता देगा. ऐसे हम सुनते हैं, पता है, उसके पास चले जाओ बस एक बार आप दिखा दोगे ना कुछ ज़रूर समाधान बताएगा और उसकी दवाई लग जाएगी आपको. वाई? बिकॉज दे आर रिसेप्टिव, दे हैव वो भूख है नॉलेज की कि सीखना है मुझे, और कंट्रीब्यूशन है. वो सिर्फ मनी नहीं हो सकता, इट कांट बी मॉनेटरी, इट इज़ बियॉन्ड दैट. देयर इज समथिंग कॉल्ड एज अ पैशन. जो भी आप कर रहे हैं, जहाँ भी कर रहे हैं, जिस भी फील्ड में आप हैं, डू योर वर्क पैशनेटली, लव योर वर्क. सो डेफिनेटली मुझे पता नहीं है कि इसका क्या ट्रीटमेंट होगा या क्या, व्हाट विल बी द फ्यूचरिस्टिक पॉइंट ऑफ व्यू, क्योंकि आजकल AI आ रहा है, मेडिसिन आर वर्किंग सो फास्ट, जेनेटिक काउंसलिंग्स आ रही हैं. वी डोंट नो व्हाट कुड बी द फ्यूचर ऑफ मेडिसिन, इट इज़ ट्रैवलिंग सो फास्ट. सो जितना अगर आपको उतनी स्पीड से अगर आपने कुछ सीखा या समझा या पकड़ा, देन यू विल बी रियली यूजफुल इन द सिस्टम. अदरवाइज सिस्टम उन लोगों को भूल जाता है जो अपने आप को कंट्रीब्यूट करना भूल जाते हैं. They don't want to upgrade themselves. So with that, I would like to thank again. Good day. Thank you.
Now I invite our Honorable Chief Guest, Professor Digambar Behra sir, to deliver his message on the occasion.
Respected Vice Chancellor Madam, Dr. Pinky ji, Professor Rajendra Prasad, Professor Jain, Dr. Kathuria, Dr. Suryakant, Dr. Alok, and Beth, and ladies and gentlemen, a very good afternoon to all of you. At the very outset, I appreciate and I congratulate Dr. Beth for this nice conclave that he has arranged today on the occasion of the World Asthma Day. I'll just, ladies and gentlemen, I'll just like to talk to you about three things specifically. One is about the asthma and the World Asthma Day and the issue of allergy in India. I gave a talk about an hour ago about the situation of allergic diseases in India. And second thing, I'll talk about the specialty of respiratory medicine. I must comment on that. And then thirdly, something as I am deeply associated with the Indian Academy of Asthma, Allergy and Clinical Immunology as its current president. And also I could see that Ved has written that it is in collaboration with the National Academy of Medical Sciences. So it is written there. So being the incumbent president of NAMS, I am going to take over very soon. I also like to take this opportunity to tell something about National Academy very briefly. Now starting about the specialty of respiratory medicine, you know, the scope of respiratory medicine has changed very dramatically over the years. The specialty has become now a super specialty. Earlier our training in the country was by and large TB centric, because that was a main problem of the country. It is still the main problem, and I think I have got also some request for Madam Pinky. I will put some request and some demand to her also because of the current situation. Madam, I will also like to tell you something about that. But anyway, now coming back to then, way back in 1989, I remember at PGI, so we decided we should make it bring it to a little higher pedestal because it had a reason. Apart from TB, we had other lung diseases which are growing, which new, and I think one of them is the allergic diseases, bronchial asthma, lung cancer, pollution-related diseases, interstitial lung diseases, and so on. So at that time, the then head of the department, late Professor Dr. S.K. Malik, so he encouraged us, my senior colleague Professor Jindal and myself, we are three faculty members, we decided, yes, there should be a super specialty course of respiratory medicine. So I think as usual, we doctors usually fight with each other. So there is a lot of resistance about the establishment of DM course in respiratory medicine, but somehow Dr. Malik tried to persuade the senior people at that time who matters about respiratory medicine in the country to have this as to give their consent. Although PGI was out of purview of Medical Council of India, it has its own academic committee and decision making powers. But anyway, it was ideally decided that we should take everybody along. And then that was, so you went ahead, and then still people went to the extent of protesting it and, countering it at the level of the High Court, Honorable Punjab and Haryana High Court. But anyway, we won the case, and then that is now the history. In the country, there are now 26 institutions are having, the course of DM in pulmonary medicine, and now so far we have got more than 100 students working all over the country. And Alok is, I'm sure, one of them. He himself is running a DM course here at SGPGI. We are very proud of that. And as regards the KGMU, again, I will congratulate both Suryakant and Ved to have this DM course starting here. And Madam, this is a great step. I remember at that time, the Vice Chancellor, Professor Ravikant, he spoke to us, he took our opinion. And then first thing I told him, sir, first I will ask Suryakant, because what is his opinion. If he says, then only we will give our consent and we will agree, and will not our consent means we will advise you, yes, you go ahead. And it is so nice of Dr. Suryakant that he also agreed, yes, we should do it. And I remember Professor B.K. Jain, myself and Dr. K.B. Gupta, we came and we recommended this fellow Ved and Ajay to be in the part of this system. And now the KGMU is one of the centers for DM. So that is how the specialty has grown, and it has a reason why I am telling you this story, because beyond the tuberculosis, it still continues to be a problem. I should say it is the greatest major problem of respiratory disease. But unfortunately, what is happening, while we grew in the line of DM and all that, again I must admit and I must confess that the super specialty also has created problem. Many of our respiratory physicians now, they are somehow trying to, as I could say, drifting away from tuberculosis. It is going to the, I do not know why they are more interested about other issues like intervention pulmonology. You see, for about allergy, people are not very much interested to go into the allergy. Allergy is just not asthma. Asthma is only one allergic disease amongst the many other allergic diseases. And that is what the ECAI is trying to, that is the Indian College of Asthma Allergy, to percolate this message through these respiratory physicians and our other colleagues like the gastroenterologist, the ENT specialist, and then the dermatologist, etc., to have a combined work about the allergy part. One thing I was telling you to talk about Madam Pinky. Madam, you see, we have got we have got National TB Elimination Program, where the Honorable Prime Minister has got the mission of ending TB by 2025. I don't think that is possible. We know that it is not possible to eliminate by 2025. But this is a great step that is being taken. But somehow what is happening, there are, Madam, we need your help for that as a, as the mission director. So there are certain difficulties, issues that we are facing at the state level. Because we are all working, I think all people, respiratory physicians sitting here, we all work for there is a national task, there is a task force mechanism where all the medical colleges are part of it. So what we feel, many things are, lacking at the state level. We don't get proper coordination. I am not telling there is a lot of improvement as far as UP is concerned, because I am associated with it since 2006 with this task force mechanism. Now there is a great improvement, but still there are issues like shortage of medicines, the medical, particularly I am talking about medical colleges. Every medical college is not functioning effectively, let me put it that way. And although Dr. Suryakant is now, and earlier it was Professor Rajendra Prasad, now Dr. Suryakant, so he is the chairman of this zone now. He was earlier the STF chairperson. So then obviously they are going to tell you its nitty-gritties, what are the difficulties. I am sure you yourself is a medical person, so you will be understanding the difficulties. And to help the program, we need your support and your blessings. And now coming back, ladies and gentlemen, today's theme is the, educate to empower. Obviously, I think this is a very appropriate training. We have got many advancements about understanding the mechanism of asthma. We discussed, and Professor Rajendra Prasad talked to us about the problem of bronchial asthma. Actually, what is really lacking? We all know that asthma is not curable, and asthma is a lifelong disease. It never, leaves you. It keeps on coming up and on. So it is a lifelong disease. It is a chronic disease. So that's why there are many myths and many misunderstandings, and many people get frustrated getting the same disease like any other chronic disease. So what happens? We need to educate the patient. We need to educate ourselves, that is the doctors, and also we need to educate the society. I think all three, at all these three levels, and of course the government is a part of it. The government also to be educated. Let me put it that way, in a very straight way. So how we are going to educate the patients? The patient must understand. Many times there are many myths and many misunderstandings. That I think Dr. Birinder Singh put that up very nicely during his talk. how people are misled, people have a different, they may not, it is very difficult at the very beginning. Most of the patients, they don't accept that they have got asthma. They will tell something like, मेरे को दमा है, मेरे को, मेरे को allergic bronchitis है. I don't know what is wrong with the word asthma. Why people are afraid? What is the stigma? What is the hesitancy in accepting that I am having asthma? they will घुमा फिरा के आपको बताते जाएंगे मेरे को अस्थमा नहीं है, ना ही मेरे को थोड़ा खांसी हो गया. The moment you tell them अस्थमा, इनका मुंह सूख जाता है, तो कहेंगे नहीं नहीं वो तो अस्थमा हो नहीं सकता, मेरे को अस्थमा क्यों. Many things that as the physicians, as clinicians, we all do that. We have all, that is our experience. But I think that is one thing the person must understand, that he has got asthma, and he must understand that this is not totally curable. He has to only change some of his lifestyle, some lifestyle modification is required, and he has to take medications as and when it is required. And the second thing about the inhale, then another very important myth is that okay, मैं इनहेलर में क्यों लूँ, इनहेलर लेने से इट इज हैबिट फॉर्मिंग, मेरे को ना ये हैबिट बन जाएगा. भाई हैबिट इज रिक्वायर्ड. आप रोज क्या, मैं इनको कहता हूँ भाई आप क्या रोटी नहीं खाते हो, आपको तो रोटी खाना पड़ता है, दिन में तो 3 दफा रोटी खाते हो, आपका यू टेल दैट इट इज हैबिट बन जाएगा. इट इज नॉट हैबिट फॉर्मिंग, इट इज रिक्वायर्ड फॉर अस. सो इट इज रिक्वायर्ड, इफ इट इज रिक्वायर्ड यू हैव टू टेक इट. एंड देन द myth about steroid, yes, I think all those things you have to understand them. And as Dr. Rajendra Prasad told, actually no patient should die of bronchial asthma. Then the second thing about the education for the physician also required, because we need to, explain these things to the, if you can't explain our patient, you have to spend little more time. In the busy practice, we try to, because that is what I see. You see, while I was working in PGI, that is, then I was seeing about 60-70 patients. That was my, ये मेरे हिस्से में आते थे, because being a senior person and the professor or head, so I was getting the less number, but again within a period of 3 hours or 4 hours you have to see 60-70 patients. But in a, while sitting on the, so therefore what is the time, how much is the time I spend, I could not spend much time. But I think we have to find time and explain things to the patient. So now I am working in a private sector, so where I get lot of time because appointment is given. So then there is a time to explain. So that we have to make a balance between our time and to explaining to the patient. So that is again all our physicians, all our chest physicians should be educated to spend time to explain to the patient how to take inhaler, why to take inhaler, all his or her concerns. And all these things have to be explained. And then I think one of the most important things is the use of inhaler. Because inhaler is now the current method of treatment. You have to take inhaler. So question is how to take inhaler. That has to be, taught to the patient repeatedly, and each visit it has to be verified and taught. That is what most of us don't do. ले लेना आप खुराक twice a day, आप ले लेना. That's all. That is the. I think that is not correct. Neither that is fair. So that is another thing. I think we have to verify and re-verify. Then obviously the society is to be taught, the government is to be taught. So COPD and asthma, that is a, it is with the NCDC program, that is non-communicable disease. It is part of the non-disease. But question is, the government is supposed to give some minimum drugs, some minimum inhalers. So that should be made available. Maybe Madam can start, BP can start as a model. They should make these drugs available in the dispensary, in the place. This is a essential medicine recommended by WHO, and the government has accepted it. I remember 3-4 years back, for WHO Southeast office, we had made a recommendation to the government, and we have made guidelines how it is to be done. So I am thinking, since the government has put chronic respiratory diseases, that is COPD and asthma, so these drugs should be available. Many of our asthma patients, they don't afford, they cannot afford, and they don't have got access to the inhaler. Forget about the biologicals which are just now available for severe asthma. About 5% of asthmatics are having severe asthma. In India, if you have got 37 million cases of bronchial asthma, that is the figure. So if 5% of that has got severe asthma, who will need further therapy? So if we cannot provide inhalers, simple inhaler, which cost about 200, 300 rupees, many of our patients are not. So I think that is what for the government, they have to take up this issue, how these people should get their inhalers. So ladies and gentlemen, the topic for this year, that is which Gina has said, that is educate to empower, that is I think very apt, that is very appropriate. So all of us need to be educated, the government, the administrators, the society, the patient, including the doctor. Then only we can give better service to the patient with allergy, with having various allergic diseases. And obviously we need to have a combined effort of all the 3-4 specialties we have told. This ICAI is a combination of all those, their members are, they belong from each society. And as an association, many of the professional associations actually, they have also got a role. So ICAI from our side, actually our treasurer is Dr. Kathuria, and he is a very eminent allergist and the immunotherapist of the country. So I think all of them, they know. So we are trying to, through the various educational activities in the form of asthma chart, various camps, etc. But that is, I think, not enough. Every one of us, every society should be, should be devoting their time to educate people. And as now I was telling you to talk about the National Academy. So institutions or you all know National Academy of Medical Sciences is an autonomous organization. It is a organization of all the specialties. That is the difference between the professional society and the National Academy. National Academy has got the members and fellows from all the medical and the dental specialties of the country. So it is a combined effect of the medical and the dental fraternity. So, and then we have got one of our major activity, the CME or medical education. So this will be, I am sure we will see, and I will see to it that this will be one of the topics that will be taken up. We are taking up different CME. So I think I will just invite all of you to become fellows. Please apply for these fellows, for its members. There are different guidelines. So ladies and gentlemen, we did few words. I think we should, again, I will again request you, we should be educated ourselves, and we will try to educate and try to give something to our patients and to the society. So with these few words, I again wish this conclave a great success, and which actually a great success. Since morning we are all listening, and there are very nice topics, very nice talks. You have chosen very good speakers. So thank you very much again, Beth, for inviting me for this meeting. Thank you.
Thank you, sir. Now we invite our chief patron for the event, Honorable Vice Chancellor Ma'am, Professor Sonia Nityanand Ma'am, for her blessings and message.
Thank you. Dr. Behra, Padam Shri Dr. Behra, who's the chief guest for today's function. Dr. Pinky Joel, IS, who's the mission director and a doctor herself. And since there are a lot of people from SGPGI, I would like to also highlight that she's been the additional director of SGPGI in the past. And at least I also would like to acknowledge that when she was there, she was also in the medical education department, and she played a very important role in my setting up of this STEM. I mean, very generously supported with funds my setting up of the Stem Cell Research Center at SGPGI. Dr. Kathuria, Dr. Jain, my teacher, Dr. Rajen Prasad, Dr. Alok Nath, a very dear colleague of mine, and Dr. Suryakant. All the other esteemed faculty who have come from the different parts of the country to share their expertise and knowledge in the conclave today. All the esteemed faculty members of King George's Medical University and participants. A very warm welcome to all of you on behalf of the university to this very, I would say, a very important conclave on allergy and asthma organized by Dr. Ved Prakash and his team. So congratulations, Dr. Ved Prakash, on organizing this very important conclave. And we all understand that asthma is highly prevalent. I mean, at least I think 5-6% of the population in India would be affected by asthma, and especially it's much higher in the pediatric age group. And yet I feel it's a condition in which I think there's still a lot to understand. I mean, if you see asthma, you see allergy, they stand on a platform of understanding the immune system of the body. On one side, you have immunodeficiencies. On the other side, you have a hyperimmune system which manifests in the form of either allergies, asthma, or autoimmunity. So it's an interplay of the immune cells, the stimulation of the immune system in an aberrant manner, and any person who wants to really become an expert in the field of asthma or allergy has to have a very deep understanding in this field, because all the recent developments in therapy have come out of understanding the pathogenesis. I especially feel very deeply for children who are affected by asthma, because it's missing of school days and you know, hospitalization, very traumatic to the child, very traumatic to the patients. And it's a responsibility which is borne by pediatricians along with the respiratory / pulmonary medicine department. And an aberrant immune system so early in age makes you feel that you really need to understand why that aberrancy sets in at such an early age. You know, we always think of primary immunodeficiencies, how to treat them, how to classify them. But this is another way of the aberrant working of the immune system at a very early age. As Dr. Behra highlighted, there is a need in medical colleges, in medical schools for the development of this branch. I think there are very few centers where actually allergy testing is present. I mean, I know that we often had to send patients to the private sector for allergy testing, and it's heartening to know that now allergy testing is present in the medical institutes, in the government medical colleges also. And as Dr. Pinky Joel said, I myself, I think all of us have been a victim of allergies, most of them being respiratory, but a large bulk also being dermatological skin allergies. And it's important to identify, because then you can avoid the allergen if you have good allergy testing facility. And I can tell you my example. I had an allergic rhinitis and I suffered for a long time, and then when I went to Sweden, I went and got myself checked up, and they said, well, you know, it used to come during the summer months. And I could never understand, and they said it's always aggravated when there is heat and there is a congestion of the nasal mucosa. So when I started taking precautions for that, and it gradually came down, in the last 2-3 years I've been free of it. So what triggers what in in an individual, we don't know, but if identified, at least one can avoid it. So it's a very appropriate topic today, very appropriate labeling of the World Asthma Day 2024, that asthma education empowers. And I think the whole enclave today is basically focused on empowering us by imparting asthma education. So again, I would like to congratulate the organizing team for organizing this conclave and thank all the faculty who have come to give lectures in it. Thank you.
Thank you, ma'am. Now I request Professor Ved Prakash sir to kindly come forward and felicitate our dignitaries with mementos. May I request Professor Digambar Behra sir, our chief guest, Padma Shri Professor Digambar Behra sir, to please come forward. May I also call forward the Honorable Vice Chancellor ma'am, Professor Sonia Nityanand ma'am, to please come forward to felicitate our chief guest. I request Ved Prakash sir to please felicitate our patron, Professor Sonia Nityanand ma'am. I request Dr. Pinky Joel ma'am, IAS, to please come forward. May I now request ma'am to please honor our eminent guest, Professor P.C. Kathuria sir, with Excellence Award for his extraordinary contribution in the field of asthma, allergy and applied immunology. May I now request ma'am to please honor Professor V.K. Jain sir with the Excellence Award for his extraordinary contribution in the field of asthma, allergies and applied immunology. I request you, ma'am, to please felicitate our special guest, Professor Surikant sir. May I please request you, ma'am, to please felicitate our special guest, Professor Alok Nath, sir. And he's also our scientific chair. Now request I request you, ma'am, to please felicitate our organizing chairman, Professor Rajendra Prasad, sir. At last, may I request you, ma'am, to please felicitate our organizing secretary and mentor, Professor Ved Prakash, sir. Thank you, honorable dignitaries. Now I request Professor Ved Prakash, sir, to please come onto the mic and deliver his vote of thanks.
Thank you, Dr. Mrityunjay. At the outset, I would like to thank all who are coming from the many parts of the country to deliver the talks. And first of all, our chief patron and guiding force, Professor Sonia Nityanand ma'am. Thank you, ma'am, for being with us and always guide and bless us in the every step we take with your permission and with your guidance and blessings, ma'am. So thank you for being with us. Our chief guest of the function, Padam Shri Professor Digambar Behra sir, who is the guiding force with Professor Rajendra Prasad sir in the creation of this Department of Pulmonary and Critical Care Medicine at King George's Medical University and being running the DM course first time in Uttar Pradesh with us and Dr. Alok Nath also in PGI. And I would like to thank Dr. Pinky Jovel ma'am, always guiding us and always considering whatever we have the demands to take these programs up to the village level. She is always considerate and guiding us and helping us for the funding also. So thank you, ma'am, for being with us always. And I would like to thank Professor V.K. Jain sir, senior most professor and on the dais for being always being with us and coming long way from Jaipur. And I would like to thank Professor Kathuria sir to be the part of the function and to be the part of the workshop also. And I would like to thank Professor Rajendra Prasad sir, B.C. Roy awardee, teacher of teachers, and always guiding and being present at every time. And I would like to thank Professor Suryakant sir, who is my mentor, my guide, to be with us. Thank you, sir. And I would like to thank Professor Aloknath sir, who is always ready and made such a wonderful program, scientific chair of the this conclave. So thank you, sir. I would like to thank Professor Viren Singh sir, who come a long way from Jaipur to deliver the talk, and he left early. I would like to thank my teachers, all the dignitaries present here, the faculties from Sanjay Gandhi PGI, from Lohia Institute, from KGMU, and from respiratory medicine and other departments, Department of Medicine, and all other delegates from all over the region. I would like to thank you for participating. I would like to thank our media, who plays the pivotal role in the awareness program we want to spread up to the village level. So they are doing the great job. So thank you, media, for being with us, and thank you, Pharma, for supporting us to organize this program. Thank you, Lupin, Cipla, Glenmark, and all other partners to make this program possible. And at last, my wife, Dr. Manju, is here, my son, my children here. So thank you, Manju, for being with me always. Thank you. So thank you all.
Thank you, sir. May I request everyone to please stand up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाए तब जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे जय
Thank you, everyone. You all are requested to proceed for lunch. Next session will begin after the lunch. Next session will begin at 3:15 after lunch.
बिल्कुल बिल्कुल
सही कह रहे हो।
यहाँ पे बोलेंगे तो
स्टार्ट करो. इनका लगा हुआ. हाँ. चालू है. चेक करो रजत. हेलो हेलो चेक.
Welcome back, everyone. We'll begin with our next session, skin and its allergic reactions. May I request the chairperson to please grace the stage. Dr. Ajit Kumar Sir, Senior Consultant Dermatologist, SGPGI. Dr. Haider Abbas Sir, Head of Department, Emergency Medicine, KGMU. I now request the chair to please kindly introduce our speaker and start the session. Thank you.
Good afternoon, all of you. May I welcome Dr. Parul Verma, who is an additional professor in the Department of Dermatology at KGMU. She is a fellow colleague and she will talk on skin and its allergic reactions. Welcome, Dr. Parul.
Thank you, sir. Very good afternoon to all, and first of all I would like to thank the organizers for giving me this opportunity to present on skin and its allergic reaction. So in 20 minutes it's difficult to cover everything in skin and allergy. Every allergic reaction can have some or the other manifestations on the skin, maybe it food allergy, drug allergy and so on. So today I'll be talking about those disorders which are primarily dermatological skin disorders, which include urticaria, contact dermatitis and atopic dermatitis. These are primarily skin disorders with obviously an associated component, internal component. So first let us see what is atopic dermatitis. It's a very, very common skin condition which we see day in and day out in our OPD, and if we classify the eczema, so it comes under endogenous dermatitis, or what is the talk all about which you are listening since morning, asthma and all those things, which is endogenous. So it's endogenous dermatitis. Other conditions which come under endogenous dermatitis are hand eczema, discoid eczema and so on. But nowadays it's said that they are nothing but adult manifestation of this atopic dermatitis. So if we see, we use this term atopic dermatitis only in children, we are actually decreasing its prevalence. So if we combine everything, it's so common, and it's every one of us has suffered with some type of eczemas or skin inflammation. Then the other category is exogenous dermatitis, which includes contact dermatitis or irritant contact dermatitis. So atopic dermatitis, what is that? It's nothing but a chronic relapsing inflammatory skin disease primarily affecting children or in those who have inherent tendency to produce IgE in response to the allergens. Allergens can enter through your skin, they can enter through your mouth, or you can inhale them, anything. So there is a background atopic tendency. It affects 1/5 of all individuals during their lifetime, mostly in children, that to majority before 5 years of age. And the good thing is that it gradually improves with age. These children obviously are at risk for other allergic disorders like food allergic, asthma, allergic rhinitis, allergic conjunctivitis, and they suffer, like it said that a child with moderate to severe atopic dermatitis has 50% risk of developing asthma and 75% risk of developing hay fever. So they are all interrelated somehow. So this is a classic atopic triad: atopic dermatitis, hay fever and asthma. Or you sometimes get atopic march, which they progress from atopic dermatitis to hay fever to asthma. Most important is IgE mediated pathogenetic involvement, though there is now a role of type 4 T cell mediated disorder. That's why the role of atopic patch test is nowadays in for atopic dermatitis. So I'll be talking basically on a skin point of view. So why this dermatitis occur? The pathogenesis is obviously complex and there is like IgE mediated. So what happens in the skin? Most common pathogenesis is there is a mutation in the filaggrin gene which leads to defective keratinization and defective formation of NMF. What is that? NMF is natural moisturizing factor. Once this is lost from your skin, it's like lipids of your skin is lost, your skin will become dry and cracked and allergens can easily penetrate through your skin and you can be sensitized to them. So acute stage is characterized by Th2 differentiation and increase in interleukin 4-5. Later on Th1 cell response is also seen and now there is an emerging role of interleukin 17. And other important thing is in this eczematous skin, the antimicrobial peptides like defensins and cathelicidins are decreased. So these children are very prone to superficial infections. They may be viral, they may be pyogenic bacterial infections. So basically, atopic dermatitis is a complex disorder which in children who have a genetic background and when they interact with the environment. So looking at the pathogenesis, now I have talked about how these pathogenesis can enter through your skin. It can enter, you can inhale those allergens and so on. So what are the risk factors? Hygiene hypothesis. Earlier it was thought that it's more prevalent in Western countries because, and now, but we are seeing in India, there are its prevalence has increased a lot. So more clean or more sophisticated a child lives within an environment, there is more chances of developing atopic dermatitis. No direct correlation with breastfeeding. One should breastfeed the child if he or she has atopic dermatitis. Then I've already genetically filaggrin gene is the strongest known genetic factor for atopic dermatitis and atopic marks we have already seen. How do it presents? Classically it presents as early onset itchy eczema localized to typical sites that are flexures of elbow, knee in an atopic patient. Obviously you take history of atopy in your patients and we take history of atopy in our patients. So as you can see there are itchy erythematous plaques which are distributed over vital fossa, then abdomen, then wrist. The light actually is very much shiny here, so it's getting the orange hue in all the patients. In this you can see multiple erythematous tiny papules, they can coalesce to form plaque. This child had severe involvement of the face with erythematous papules. All of this is appearing to you as orange lesions, but they are not orange, they are basically erythematous lesions. It itches. If the child does not itch, think about something else. So atopic dermatitis is itchy and you can see this small child, he is itching so much. As the child will grow up, so much psychosocial impact it will have on his life. He will like say, I am always itchy, how can I go to school? How can I play with my colleagues? They say you have skin lesions, though they are not transmissible. This is not infective. As the disease progresses, the lesions become lichenified. Sometimes the lichenification is seen in early onset disease as well. What is lichenification? Increased skin marking, thickening and hyperpigmentation. So this is an adult patient which have a lichenified eczema on the foot. It's itchy. You can guess the itch by the excoriations which he is having. He is itching, that's why there are excoriations. See the hyperlinearity, xerosis present on the foot and multiple lesions present on the foot. This is a classical eczematous plaque, itchy, oozy, crusty. So this is like classical eczema. Sometimes it's ring shape, we call it discoid eczema. So, sometimes it's present on hand, we call it hand eczema. Hand eczema is a totally different actually an entity. We can have a lecture of 1 or 2 hours on hand eczema itself. There are so many etiological factors. So this is again a scaly lichenified plaque on the shin. Again this is a lichenified eczema. So it can have various presentation, acute stage, chronic stage, subacute stage. And criteria, essential criteria is itch, eczema with typical morphology. This one should have, then you can have important features and associated features. Important features I have already said, early age of onset, atopy, dry skin. Then you can have multiple other associated features, the atopic diathesis, which we call like allergic shyness, keratosis pilaris, you can see here, hyperlinear palms and soles, then multiple follicular keratosis known as keratosis pilaris. One may have darkening on the under eye area, allergic shyness, and P. alba, pityriasis alba on the face, that is white patches on the face. All these are associated features of atopic dermatitis. The important thing here is how does it aggravate? Hot water. When a child comes to you, general advice is don't use so much of hot water for bathing because it increases the skin dryness, stress increases it, irritants, less use of perfumed or harmful chemicals on your skin. It's very, very important because these patients are more prone to secondary contact dermatitis or irritant dermatitis because your skin barrier function is lost. And obviously it increases in winter, and with synthetic clothes you should wear light cotton clothing. Complications we have discussed, it can be bacterial, viral, like we call it eczema, herpeticum, various pyodermas. It itself can cause stress and lots of quality of life distress, and obviously when you give drug there are side effects related to it. Lab investigation, usually for disease IgE levels are increased, but we do not recommend routine monitoring of allergic specific IgE because allergic testing is not recommended as a result of many false positive results and unnecessary dietary and other restrictions for the patient. Effective therapy, here it's very important. See, two things are written: restore barrier function and control of inflammation. So moisturizer is not just a moisturizer in the case of atopic dermatitis, it's a therapeutic thing. You restore your skin barrier, the disease will 50% reduce. So choose your moisturizer, thick, thin, lotion, cream, gels, whatever suit you. Apply several times a day, apply immediately after bath. You can apply the moisturizer and then we give like wet towel to wrap around. This is wet wrap therapy. All these components reduces itch, increase your lipid content of your body, reduces cracks and fissure, and decrease the disease severity. So moisturizer is a very important treatment modality here. This we have already discussed. This we have discussed. Then you can give antihistamines and psychological support, avoid use of perfumes, cosmetic products, and educate the patient. Specific therapy obviously is topical corticosteroids for limited disease, and systemic therapy for, again, see, steroid application is it's an art. You have to prescribe steroid depending upon the site of involvement. You can't give super potent steroids on application on the face. Similarly, mild steroid will not work on your hand or foot lesions. So choosing the type of steroids, frequency of its application, reducing tachyphylaxis by giving breaks in your steroid application is very important. And obviously RCTs are there to demonstrate its role. Then once your disease is controlled with suppose I am talking about mild disease, you can continue with the maintenance therapy with calcineurin inhibitor, which includes pimecrolimus and tacrolimus. Sometimes they are very effective in children and very important for their maintenance of the skin lesions. If you have a systemic disorder, then you can, for moderate to severe disease, you can use oral steroids or cyclosporine. After steroids, we prefer cyclosporine even in children. Other immunosuppressant which can be used are methotrexate, MMF, that is mycophenolate, and azathioprine. There is some role of light therapy. These are the neo drugs. Crisaborole, it's very much in the market. Topical crisaborole for atopic dermatitis, that is PD4 inhibitor. Then dupilumab, it's a costly drug, but yes, few centers have used it with good results. Then omalizumab, here it's not recommended. It will be, you will see that in urticaria. Then apremilast and IVIG. Other medication you can use as per need, like antibiotics and antiviral, but routine prophylactic use of antibiotics should not be done. Food specific free diet is not recommended in patient of atopic dermatitis until unless there is a specific history. So it should be based, food should be restricted only on basis of clinical experience and good food diagnostic procedure by a specialist. As in they have got the report of allergy to this, and then we restrict. And it has also been seen the consumption of elimination diet free of highly sensitive food in pregnant women doesn't prevent your child in for developing atopic dermatitis. There is though some role of probiotics. You can undergo, child or adult can undergo routine vaccination until unless if the disease is in erythroderma, that is involving a more than 90% body surface area. You can first stabilize the disease, clear that area, and then go for routine vaccination. These are the associated syndrome. You can read it. Commonly we see with ichthyosis vulgaris, it's commonly seen in our day-to-day OPD. Now that was atopic dermatitis. Now we come to contact dermatitis. As I told you earlier, the atopic dermatitis include all the type of that was endogenous dermatitis. This is exogenous. Yani ki bahar, it's something from outside, it's affecting your skin. So it can be divided into allergic and irritant. Allergic here, allergy is delayed type 4 hypersensitivity reaction. So there are two phases. I'll just tell you. There are two phases. One is sensitization phase, one is elicitation phase. When you are sensitized, suppose you are wearing a bangle for the first time, but you are wearing it the first time, you may not get that allergic reaction. But when you wear it in the second time, your T cells are sensitized to it. And that will induce the eczematous reaction or the lesions on your body. So the common etiological agents which we see, the allergy which we see commonly is nickel, then the allergy to hair dye, parthenium. I'll show you examples of all these. Neomycin, many of us keep on applying neomycin on the post-op wound. Even the betadine we keep on applying, and we are seeing so much of allergic reactions with these agents. So we try to avoid all these things. Obviously, depending upon the occupation, farmers are more exposed to the plant allergen. Similarly, someone working in a salon is more exposed to hair dye application. If again the person who is atopic has more chances of developing contact dermatitis. And depending upon the phase of presentation, as I have told you earlier in atopic, similarly, if it's acute, you get lots of erythema, edema, oozing and all those things. When it's subacute or chronic, there is more of pigmentation, thickening of skin and scaling. ABCD, that is airborne contact dermatitis. It's a very, very common entity. Parthenium is not a native plant of India. It was brought out from outside, from US to India from a shipment, and now it has found place everywhere in India. It's actually present everywhere, and it's the commonest cause of plant dermatitis. The sesquiterpene lactone is present in that trichomes, the fine hairs which are present in this parthenium, and which are in the air and causes mainly through type 4 hypersensitivity reaction, though there is some role of type 1 also. It can have following pattern. Let me show you with the help of example. This is a classical ABCD patient, airborne contact dermatitis. You can see the multiple scaly erythematous plaque which is present on the eyelid, on the forehead, on the face of this patient. Another patient with similar lesions present on the periocular area. Sorry for the light, it's very misguiding, orange hue. All the skin color has become orange. So he has involvement of nasolabial fold, eyelids. Why these sites are important? Because here the allergen get trapped. They get trapped at the folds, and initial reaction is a ABCD pattern, airborne contact dermatitis. And it usually increases in summers. You can see on the exposed part he is getting multiple erythematous papules and plaques. Again, this female, she had acute reaction, lots of erythema, oozing, involvement of entire face, and there was erosions. Now look at this female. She is a case of chronic CAD pattern, that is chronic actinic dermatitis. Now the disease has become chronic. It is more localized to the exposed part in the form of thick lesions. So she has lesion over the dorsal of hand, V area of chest, and some lesions on the nose. So this is ABCD pattern, this is CAD pattern. Sometimes you can only have hand and foot dermatitis, only lesions on the hand and foot, only lesion on the perianal area. So these are the other morphological pattern, or sometimes mixed pattern can be there. You can have ABCD pattern, something in between ABCD and chronic actinic dermatitis. So once the patient comes or of contact dermatitis or ABCD, we take history of occupational seasonal change, how did the lesion progress. Here the patch test is very important in contact dermatitis. Here we recommend and do patch test for this. And you can, this is a positive reaction to parthenium. You can see here we have various series. You have a workshop on patch test, so you can learn more about it later. It's a chronic course and the sensitivity remains. So you have to take adequate precautions, explain to the patient, give barrier creams, moisturizer, sun protection, then treat. See, because of limited time, I have to rush with all this treatment modality. You have to give, again, the management protocol is almost same as atopic dermatitis. Now, contact dermatitis to hair dye, it's again a common entity, usually seen due to PPD, that is paraphenyl diamine, or the color additive colors. Its patient usually give history of itching and while application of hair dye. It can be localized to your scalp area or face area, and sometimes it can spread all over the body. Sometimes it can even cause anaphylaxis, hair dye application. So be careful, use hair dye but carefully. So this is hair dye, contact dermatitis to hair dye. Here you can see the thick lichenified skin because of hair dye application. This is your bindi kumkum related dermatitis, very commonly seen. Sometimes it can be due to glue which is present on the bindi which the patient applies. Sometimes due to direct kumkum which he or she applied, due to sindoor which is applied orange red color. This is nickel dermatitis. Nickel is present in your metallic substance, in necklace, in the button. So you can see only that area where the button is in contact, this patient has developed erythematous papules. This was contact dermatitis to the anklet which the patient was wearing. So because of chronicity, it has become a lichenified lesion. Systemic allergic contact dermatitis. Systemic allergic, once you, suppose you are sensitized to a thing and then you inhale or ingest particular substance which have that thing for which you are sensitized, you can get systemic contact dermatitis, or termed as systemically reactivated allergic contact dermatitis. And it can mimic any pattern it can mimic. It can mimic your hand eczema, it can mimic your stomatitis. Most common, what is the most common pattern is flare-up of earlier patch test reactions. This is the most common form seen. So I have to rush. I should go for urticaria or leave it? 1 more minute, okay. So the gold is no more inert, we have contact dermatitis to gold also. Irritant I leave, basically it's not an allergic reaction, it's a non-specific reaction to the substance, like you apply Dettol and you get this type of reaction. So it's a non-specific reaction because of the irritation of the substance which you have applied on the skin. All these are irritant dermatitis, I leave this, then coming to urticaria. What is urticaria? Urticaria is nothing but sudden development of transient wheals or angioedema or both. Wheals is circumference superficial edema on the skin, mainly it's in the dermis, while your angioedema is little bit deeper. It's in subcutaneous or deep dermis. Difference is urticaria resolve within few hours, angioedema takes more time to resolve. Angioedema can be severe if it involves your respiratory tract. Urticaria can be divided into acute urticaria or chronic urticaria depending upon the duration, less than 6 weeks, more than 6 weeks. Most of the time it's ordinary urticaria when we don't know the trigger, but there are times we know the trigger, which can be sun, which can be water, which can be vibratory equivalent, which can be pressure, which can be exercise, which can be cholinergic urticaria. So you can, sometimes it can be food, sometimes it can be drugs, and it's commonly causes urticaria. So it's mast cell mediated disease. Most of the time, due to IgE or non-IgE dependent mechanism, it degranulates mast cell and then there is histamine release and other things come. So basically it's mast cell dependent histamines and leukotrienes which leads to vasodilation and increased permeability. While there is a mast cell independent theory also which also causes vasodilation and increased permeability, that are through bradykinin and other mediators. So basically history is enough. History is enough, patient will come, we get itching, we get wheals, it resolves in few hours, or when we take Avil, it resolves. This is a classical history we get. So actually for diagnosis, you don't need any investigations. You just take a proper history, take history of any triggering events, take history of drugs, measure its severity, measure the quality of life. We usually get thyroid profile, total IgE and routine blood counts. But allergy testing, we don't do. We take history. History is very important. If patient says, "Mujhe egg lene se hota hai," then don't take egg, or drug lene se hota hai, then particular drug is important. Management is basically, you have to educate the patient that disease can remain for few days to few years. We don't recommend any diet elimination until unless we get a clear history. remove any trigger like drugs or other things if they are there, and around in 20 to 50% of patients, remission is achieved within 1 year. We start the treatment with second generation antihistamines, which is non-sedating. If it gets controlled with this, it's okay, or you can updose. Updosing is the second step which we do, up to 4-fold. Our second line treatment is a second line treatment if there is no response to standard dose. So usually we use cetirizine, fexofenadine, bilastine, loratadine. So bilastine has even shown to be effective in the cases which were initially not responding to your levocetirizine and fexofenadine. No antihistamine is actually superior to other. There is no trial to show that levocetirizine is better or fexofenadine is. If any patient, some patient may respond beautifully to fexofenadine, some can even respond nicely to cetirizine, some will respond to hydroxyzine. So the omalizumab, we all know it's a newer thing, chronic. We give this when the modalities have failed or it's not responding. We can either give omalizumab, then we can even use cyclosporine. It also works very nicely in cases of urticaria. Ligelizumab is the other drug which is not available in India. The person who have higher Ig levels show more better response to omalizumab. Then there is bipotastine, again a newer drug which have shown to be effective because of its multiple mechanism of actions. Other drugs, I have already told you, there are cyclosporine, methotrexate, dapsone, oral steroids. Oral steroids, don't give at the first when the patient gives with urticaria oral steroids. The role of oral steroids in urticaria is only required when there is severe flare of urticaria, severe angioedema, when your antihistamines are not working, or the patient is pregnant and you have a severe flare. Then, or in some case of drug allergies, we use steroids. Steroid is not the first line. Many prescriptions, every prescription which come from outside, we see steroids has been prescribed along with antihistamine. This is the last slide. Don't go with this bulky slide. Basically, it's to show that ordinary angioedema is histamine mediated, while hereditary angioedema is bradykinin mediated, which is non-mast cell mediated disorder. And the treatment for hereditary angioedema is totally different. Thank you. These are not skin allergies. So everything is not skin allergy. This is fungal infection and psoriasis.
Thank you, Dr. Parul. With the limited time that you have been provided, you have covered a fair number of topics. And we are running late, so we have been requested not to entertain too many questions. But I will entertain one if there is. I don't see any raised hands, so let us not wait anymore and just wind up the session. Thank you, Dr. Parul. Once again, there are no questions. Your talk has been so lucid.
Thank you, sir.
And thank you, organizing committee, for giving me the honor of chairing this session.
Thank you, ma'am. I now request Professor P.C. Kathuria, sir, to come on stage and felicitate our guest speaker and chairperson. Dr. Parul Verma, ma'am, please come on stage. Dr. Ajit Kumar, sir. Dr. Haider Abbas, sir.
For our next session on biologicals in asthma, choosing the right drug in right patient, I would like to invite our chairpersons to the stage. Dr. Anand Gupta, sir, Senior Consultant Pulmonologist, Balrampur Hospital. Dr. Ravi Bhaskar, sir, Head of Department Respiratory Medicine, Integral Medical College. Dr. Rakesh Kumar Chaudhary, sir, Senior Consultant Pulmonologist, Sahaj Hospital. I now request the chairpersons to kindly introduce our next speaker and initiate the session.
So moving on to next session, that is biologicals in severe asthma. See, we all know asthma is a broad category, and we see so many patients who are not improving. They come revisit, they say, yes, we still have symptoms. So the problem, these patients we categorize into difficult to treat asthma. That is, there may be problem ki faulty inhaler technique, there may be problem like non-adherence to treatment, or we have not properly seen all the comorbidities of the patient. So after we have seen all these things, and then also there is a subgroup of patients who are not improving, then we categorize these patients as severe asthma. And we have different biologics options like omalizumab, benralizumab, mepolizumab, dupilumab. So to delve into complexities of these severe asthma and biologics, we have Professor Alok Nath sir, who is Head of Department of Pulmonary and Medicine in SCPGI. He is expert member for Indian Guidelines for Bronchoscopy and IPF. His area of interest is interventional pulmonology and ILD. He has over 70 publications and more than 300 citations. So I request Professor Alok Nath sir to start his discussion on biologics in severe asthma. Over to you, sir.
Thank you, Chairperson, and a very good afternoon to all of you present in the hall for this session. I'll be talking about the role of biologics in asthma. There is a large body of evidence which is accumulating for the efficacy of these agents in management of moderate to severe asthma. However, one is actually started with an amount of evidence and is unable to select which biologic agent would be appropriate for treating which subset of patients with asthma. So as Ravi very rightly described at the outset only, that severe asthma is asthma that is uncontrolled after maximal optimized therapy and the treatment of contributory factors that are responsible for the inadequate control of the disease. That is, if the patient is already on high dose inhaled corticosteroids plus a second controller for 1 year, or he or she requires oral corticosteroids for 50% in the previous year to prevent it from becoming uncontrolled, or it remains uncontrolled despite maximal standard medical therapy and management of comorbidities. The magnitude of problem is that in 2019, close to 4 lakh deaths were described globally because of asthma. In India, India contributes to more than 40% of those deaths. The largest survey till date conducted in India, that is the InSearch, reports a prevalence of around 2% for asthma in adults, and with 1/5 of those patients remained uncontrolled even on maximal therapy. So severe asthma which constitutes to around 5 to 10% of the cases and constitutes this group has severe symptoms despite maximal doses of inhaled corticosteroid and long-acting beta agonist combination. And when the compliance, adherence, technique, and the management of comorbidities all have been taken care of, the prevalence comes to be around 3.6% of asthma has really uncontrolled asthma in general population. So this diagram just summarizes what I just said, that if the patient comes with symptoms of suggestive or typical of asthma and he is not controlled on the standard medical therapy, he can have simple symptoms due to asthma. He can have symptoms in asthmatic because of other causes such as complications such as dysfunctional breathing, vocal cord dysfunction, gastroesophageal reflux disease, anxiety, respiratory muscle deconditioning, obesity, tracheomalacia, wrong diagnosis, that is he may or he have COPD or bronchiectasis or some other related conditions such as bronchiolitis and congestive heart failure. Unless all these things have been addressed and all these comorbidities have been taken care of, difficult to treat and severe asthma should not be used interchangeably. They are not synonymous. It is a subset of difficult to treat asthma, which is severe asthma, which should have a battery of investigations and detailed evaluation, after which we should embark upon the use of biologics in these patients. So broadly, we classify asthma into atopic, non-atopic, eosinophilic asthma and neutrophilic asthma. Based on all this, we have actually classified asthma into broadly two types of phenotypes, because asthma is no more a single disease now. Asthma is almost like a syndrome which has got different presentations, different things in different population, different subgroups, and they have very much different response to standard medical therapy. So this is the era of precision medicine, when each patient's therapy should be individualized and the patient should be evaluated for his or her presentation, and that is why some phenotypes have been identified. The other word is endotypes have been identified, in which the mechanism of action or mechanism which is involved in persistence of symptoms or development of asthma are different. So these phenotypes and endotypes will make our life easy for identification of a patient which for an appropriate biologic therapy. So there are two main phenotypes which have been described, that is T2 high and T2 low. We'll come to know about this in the later slides also. T2 high is commonly severe. It is more steroid responsive. It is responsive for T2, TH2 mediated immunity suppression, and it is got a eosinophilic pattern, and there is history of atopy, and mostly a common non-specific marker for allergy, that is IgE, is raised. Conversely, the T2 low, that is the low TH2 cytokine family, it may be less severe, although it is not always true. They do not respond nicely to corticosteroids. There is absence of eosinophilia. Comorbidities like GERD and reflux, GERD and obesity are common in this, and these are neutrophilic subset of asthma, and they respond poorly to TH2 pathway inhibition. So looking at the pathways, once the allergen comes and hits to the mucosal membrane of patient who is predisposed to have asthma, the dendritic cell catches the antigen and presents it to the naive, that is innate naive T cells, which later on differentiates into TH2 cells and releases cytokines such as IL-4 and IL-13, which activates B cells and result in formation of antibodies, that is IgE mediated, and also degranulation of mast cells. Other ways, the same TH2 cells also releases IL-13, which leads to airway hyperresponsiveness and also goblet cell hyperplasia, and also recruitment of eosinophils, which is mediated predominantly by IL-5. So this pathway is the allergic eosinophilic airway, inflammation, which is called Th2 pathway. And the other is the same antigens plus viral infections, smoke, inhaled toxins, and virus and pollutants. If they come and they activate the other pathway, which is mediated by IL-33, IL-25, and TSLP, which is mediated through the natural killer T cells, and they activate the innate immunity, and they also these are the subgroup which are low eosinophilic airway inflammation, and they also produce IL-5, IL-13, but they are not to that extent, and they do not have a good response to the suppression of the allergy immune system. So what we have is that the biologic therapies which are targeting the T2 pathway in asthma is anti-IL-5, that is such as mepolizumab, restizumab, benralizumab. These are the various IL-5 therapies. And to the left, you can see anti-IgE therapy, that is omalizumab, which blocks the IgE pathway. Now there are IL-4 and IL-13 inhibitors also. So that is dupilumab. This pathway inhibits the recruitment of B cells through a little more upstream pathway. Omalizumab acts at a downstream level. And highest in this hierarchy is the anti-TSLP, which is the most upstream blockage of the whole allergen cascade, and it acts, or it is efficient even in non-allergic asthma also, that is non-atopic or non-eosinophilic subtype or phenotype of asthma also. So this is the reiteration of the previous slide only, that omalizumab is anti-IgE, anti-IL-4A, that is dupilumab is anti-IL-4 receptor alpha, and mepolizumab is IL-5, restizumab and mepolizumab, and IL-5 receptor alpha inhibitor, that is benralizumab, acts on anti-IL-5 receptor alpha. So these are the various biologics which are available to us for use or for control of moderate to severe asthma. GINA 22 recommends that either on the track 1 or track 2, when you have exhausted step 4, comprehensive evaluation for the eligibility of a patient for biologic therapy should be done, and that a phenotype based treatment should be given to a patient who is not well controlled even after step 4 of GINA guidelines. So I'll just take one by one these all these biologics and the evidence in favor of or the evidence that in which subsets of these patients these are effective. Omalizumab, we have got the largest experience. It is anti-IgE. It is recommended for people more than 12 and less than 12 years of age also. The dose is basically calculated by the serum IgE levels through a normogram and according to body weight, which can range from 175 international units to 750 international units. That is the maximum dose. And the age in which it has been prescribed is in amongst less than 6 years also. Our adults and adolescents can be safely prescribed this. So efficacy data in the 28-week randomized placebo-controlled double-blind parallel group multi-center study of around 400 patients with severe asthma, there was 26% reduction from baseline in clinically significant exacerbation rates, and it was found to be quite effective in reducing the number of exacerbation as compared to placebo. In a similar 48-week study, that is extra study, omalizumab resulted in 25% reduction in rate of exacerbations, and it has got a modest oral corticosteroid sparing effect also, which was sustained at 24 months with a reduction in oral corticosteroid use also. In a systematic review of multiple trials, it was showed that asthma exacerbation rates were decreased by 37% and with omalizumab as compared to placebo, with also improvement in quality of life. And in real world effectiveness, another meta-analysis showed of 86 publications which had recruited more than 10,000 patients that omalizumab caused significant reduction in asthma exacerbation rates, both requiring hospitalization and not requiring hospitalization, as well as improvement in asthma control questionnaire rates. So the largest experience or the longest experience for a biologic which we have is currently an omalizumab, which is widely available also. And I mean, with the point of view of cost, the cost also has come down, and now it is available at lower costs in market also. Now coming to IL-5 therapies, Cochrane database had a systematic review and meta-analysis including 6,000 participants of eosinophilic asthma with who are on at least medium dose inhaled corticosteroids with poorly controlled disease that was described by more than 2 exacerbations. And in this systematic review, 4 studies with mepolizumab, 4 reslizumab, and 5 studies with benralizumab were included. And in this systematic review, asthma exacerbations were reduced to approximately to half, and there was modest improvement in validated health-rated quality of scores, but did not exceed to the minimal change which is required. And there was no serious adverse events. These are the various studies: Sirocco, Andy, Zonda, Bora, and Meltemi study, which have described up to the 70% reduction of asthma exacerbation rates, and exacerbation-free patients described in 3 of these studies were up to 5 years also in one of the studies. So long-term and safety data both are there, with sustained improvement in lung functions in all these studies which were conducted for benralizumab. This is the slide which shows that the benefit was sustained, that in lung, the improvement in lung function characterized by improvement in FEV1 was sustained even after 56 months also in long-term follow-up studies with benralizumab. So benralizumab is safe. With commonly reported adverse events were nasopharyngitis, worsening asthma, and very mild upper respiratory tract symptoms. However, serious infections and reported were very low, and there were no reported increased prevalence of helminthic infection, which is a common fear in everybody's mind, that if you wipe off the eosinophils from the body, the person might be more susceptible to parasitic infestations, but that was not found in 5 years safety data of benralizumab. Similarly, mepolizumab, it is also used in patients from 6 years of age, above 6 years of age, in adults also. The dose is 100 milligrams subcutaneous every 4 weeks, and it has got a 32-week randomized double-blind trial, MENSA, which decreased exacerbations by 47%, and in another study, DREAM, again significantly decreased exacerbation rates, and it has also a steroid-sparing effect, that 50% reduction in doses of oral corticosteroids were seen. Similarly, reslizumab, although it is IV preparation, not available in India, but it is also a very effective agent according to the results available. These are the few trials which showed that reslizumab resulted in reduction in the frequency of asthma exacerbation in both the studies done by Castro et al. And another study in which both the doses of the dose ranging study, in which the FEV1 and the lung functions and exacerbation rates both were decreased at the end of the study, that is 16 weeks. It also has a oral corticosteroid sparing effect as mepolizumab and benralizumab, and the national, the control randomized control trial, which was a 24-week period. In this, a press release was announced that this trial did not meet its primary endpoint for reduction in daily corticosteroid dose. Another agent which we have is dupilumab. It is IL-4 receptor alpha inhibitor. Similar results have been reported for this also with not many adverse effects. So because of shortage of time, I'm running quickly through these few slides. Dupilumab has also got oral corticosteroid sparing effect as benralizumab and mepolizumab given demonstrated in a study Quest, which was a 52-week study in more than almost 2,000 patients of moderate to severe uncontrolled asthma, and the benefits can be seen in this graph. That was 48% and 46% reduction in annual exacerbation rates as compared to placebo. Tezepelumab, which is TSLP inhibitor, showed its efficacy in about 1,000 patients in a Navigator trial, and in this also there was significant decrease in annual exacerbations, and it is licensed by FDA to be used in asthma irrespective of the phenotype because it is upstream. I will take another 2-3 minutes. It is upstream and it does not take into account the TH1 or TH2 pathway. This is one biologic which can be used in non-atopic asthma also, as well as even in COPD also. So this is the overview of currently available biologic therapy, and a table in which main effects on asthma, which can be seen that they reduce exacerbation, decrease glucocorticoid dose, decrease hospitalization and ED visit, and the results are almost comparable for all the biologics. So is there any one agent which is superior to other? A series of systematic reviews have been published because of the lack of head-to-head comparison of any of these molecules, which is not been done, I think, purposely by the industry because of conflict of interest and competition, because one will lose the market over another if they will compare this head-to-head. But people have tried. The onus comes back to us to analyze the data and to churn the data and find out which one suits for us. So a series of systematic reviews have been done which have concluded that efficacy-wise all the biologics are actually same. A Bayesian network analysis which compared mepolizumab, benralizumab and dupilumab also showed that all these agents are comparable in efficacy. However, there was a footnote that tezepelumab has the greatest improvement in exacerbations. They have more than 75% probability of reducing exacerbation rates, and they can be used irrespective of the phenotype. So now comes the clinical algorithm. What do we learn from this? That if a severe patient with severe refractory asthma comes, we have to first off find out whether the patient is allergic or has a eosinophilic phenotype. If the patient is allergic, which is characterized by a high anti-IgE levels, then the treatment is anti-IgE therapy, that is omalizumab. If the patient responds to it, we continue it. If the patient does not respond to it, we should measure the absolute eosinophil count. If it is more than 300 per microliter, we go to the cascade of the eosinophilic phenotype, which is characterized by a total eosinophil count of more than 300. If the patient has total eosinophil count more than 300 and patient is severe uncontrolled asthma, anti-IL-4, IL-5 or TSLP, anti-TSLP, any of them can be tried. However, if the patient does not have eosinophilic phenotype, anti-TSLP can be given. If the patient responds to the therapy, continue. If the patient does not respond, then if he belongs to a eosinophilic phenotype and has not responded to anti-IL-5, then tezepelumab can be tried. So how to choose a biologic agent? What did we learn from this algorithm? Omalizumab is appropriate for patient who has got severe asthma, that is more than 2 exacerbations per year, raised IgE, and who is sensitized to perennial yellow allergen or associated with urticaria and chronic rhinosinusitis with nasal polyposis, CRSWNP. So if a patient has got severe asthma with raised IgE, has sensitization to aeroallergen, omalizumab is the drug of choice. However, if patient has got eosinophilic variant, that is absolute eosinophil count more than 300, present and also has chronic rhinosinusitis with nasal polyposis, then or the patient has got oral corticosteroid dependent asthma, mepolizumab is the drug of choice. However, if the patient has got severe eosinophilic asthma, same OCS dependent, benralizumab can be tried, because benralizumab is not effective in patients with CRS WNP. Dupilumab, as we know, that it is also effective in severe eosinophilic asthma who are oral corticosteroid dependent regardless of eosinophilia. So these in this patient, if the patient is OCS dependent, does not have eosinophilia, he can be given this. Tezepelumab acts regardless of eosinophilia. So this is a last slide, that if you have a severe asthma, go for biomarkers. If PINO is more than 25 parts per billion, eosinophil count more than 300, 150 was the cutoff in most of the studies. But if the eosinophil count is more than 300, IgE more than 300 to 700, or present of a perennial aeroallergen. If the patient has got eosinophil dominant, go for anti-IL-5 or receptor alpha. If the patient is PINO dependent, that is more than 25 parts per billion, give dupilumab. If patient has got allergic dominant, give omalizumab. And patient has multiple elevated biomarkers, all agent possible comorbidities and patient factors should be distinguished. Now, the patient should also be assessed for urticaria, presence of chronic rhinosinusitis with nasal polyposis, chronic urticaria, atopic dermatitis, patient, whether the patient is from the reproductive age group or not, or the patient has developed EGP, is actually not asthma, but a mimic of asthma in which higher eosinophil counts are there. So patient has to be seen in detail, and patient should be evaluated very carefully whether the patient is candidate for this drug. And third, which is not the least, is participation of the patient, because it is the patient who will take the decision finally. And if an acceptability of the regime or the drug by the patient and the caregiver, because all these injections all these drugs are in injectable form, subcutaneous therapies. A caregiver or the person should be able to inject it to herself or himself, or a person at home should be available to provide this therapy. So that the decision is always combined decision with the patient and the doctor and their caregivers, with considering all the factors, financial, emotional, psychological, all factors, and then after assessing them for a appropriate biologic agent. So as I told you, if the person does not respond to omalizumab, he can be switched to anti-Th2 pathway. If the patient is does not respond to IL-5, he can be switched to IL-4R. If the patient does not respond to IL-5R, then does not respond to any of the downstream pathway, that is IL-5, IL-13, IL-4, then tezepelumab can be tried, and anti-drug antibodies should be ruled out. Thank you. Any comments or questions?
आपने बड़ा लूसिड प्रेजेंटेशन दिया बायोलॉजिकल पर, जो बड़ा टफ टॉपिक है। हमारे ख्याल से पीजीएस को काफ़ी समझ में आई होगी बात, क्योंकि टाइम का कांस्टेंट है, तो क्वेश्चन तो नहीं ले सकते। पुनः धन्यवाद।
थैंक यू।
I request Professor Rajendra Prasad sir to please come on to stage and felicitate our guest speaker and chairperson. Professor Aloknath sir. Dr. Anand Gupta, sir. Dr. Ravi Gupta, sir. Ravi Bhaskar, sir. Sorry. Dr. Rakesh Chaudhary.
Moving ahead toward our next session, new diagnostic test in allergic disorder. May I request the chairpersons to please come on stage. Dr. A.K. Singh, sir, Senior Consultant Pulmonologist, Chandan Hospital. Dr. Muhammad Arif, sir, Assistant Professor, Department of Pulmonary and Critical Care Medicine, KGMU.
So as we have heard the last two presentations, allergy is like, it has such a spectrum that it is asthma which is mild and intermittent, or it is severe, and the skin where there could be a simple allergy which doesn't require anything, or it could be so bad that it can lead a psychological, psychosocial impact on the patient. This spectrum makes it enigmatic as well as difficult to treat. And then making a diagnosis of it is always difficult. What allergen? So we are going to look at the newer diagnostic test in allergic disorders, and to deliver this talk there is no one else other than Dr. P.C. Kathuria, sir, whom we know he requires no introduction when it comes to allergy, and has dedicated his whole life on allergy, and there are like so many classes that he conducts in New Delhi for allergy. He is a senior consultant, Department of Allergy and Asthma at National Allergy Center, BLK Super Speciality Hospital in New Delhi. And then he has a vast experience, enormous amounts of presentations, publications which have been cited, and has holded various positions in various societies. So if I'm going to read all that, it will take a lot of time. So I would like to invite sir to give his presentation.
So, good afternoon, everybody. My greetings to all. Thank you, Chairperson. And my gratitudes to the organizing chairman, Dr. Rajendra Prasad, Dr. Ved Prakash, and all the key personals behind this. With due regards to all the senior faculty members, really it is a proud moment for me because I belong coming back to my parent institute. Friends, everything is involving in this institute, in this world. So is the medicine and so is the allergen immunotherapy. Started way back in 1910, the subcutaneous immunotherapy, and 1986, the sublingual immunotherapy. My statement starts with anybody can do skin test or the blood specific IgE extract based or component based.
But the most difficult part is how to correlate the sensitization with the history of the patient. Whether the sensitization is true, whether the sensitization is specific, is genuine, or is it a cross-reactive sensitization. And the difficult part in our clinical practice of allergic is how to select the genuine allergens for our allergen immunotherapy. You see, there are two patterns of asthma. The first pattern is there that the patient is in a state of the IG inflammation, because 80% of the children and the 50% of the adult, they are allergic, atopic, IG mediated. Now this IG inflammation is the initial, further it will go to the chronic inflammation, then it will lead to the remodeling, tissue destruction, and then it end up in a fixed area obstruction. So prevent this chronic inflammation, you have to catch the first initial window period of opportunity. That is the time where our allergen immunotherapy is effective. Now we don't define asthma, allergic rhinitis or atopic dermatitis. Now we look for the high T2 inflammation by looking at the biomarker and the diagnostic parameter. So you see, if you have to select the patient, you have to look for the stratification and the further purification where the response to the allergen immunotherapy will be more effective. So these are the tests available with us. Skin prick test, intradermal skin test, prick test, extract-based specific IG, component-based specific IG, nasal provocation test, oral provocation test. Among the most updated tests in 2024 is the component-based specific IG, which we will discuss. And another test which we have are the rare tests, that is the for the T cells. And that is basically we do the patch test. But unfortunately, this patch test is not standardized so far. Though the lymphocyte LTT test, ELISpot test are there in the genetic marking, but still they are still experimental. But the basophil activation test is now coming up in a big way. Now another certain tests are with us, which will differentiate on the base of the history of the patients, like in case of the angioedema, recurrent anaphylaxis, or HAE, or idiopathic type, then we have to go for the complement activation, serum tryptase, or the other tests we should do it. Now, if you look at the history, as the Rajendra Prasad has given the importance of the history, but the history gives us a diagnosis whether the patient is allergic or non-allergic, but it does not tell us the sensitization. Then what we have to depend on the skin test and specific IG. Specific IG gives us a pattern of the sensitization, which type of the pattern of sensitization patient is there. But it still does not tell us the severity of the disease. It still does not tell us the genuine sensitization or a true sensitization or a cross-reactive sensitization. Then comes the test is the molecular test. This is the era of the molecular test now. And we have to go for this molecular test in certain selected patients of which give us a true, which give us a specific, which give us a genuine sensitization to rule out from the non-specific or useless sensitization. Because there are many patients, you will see 80% of the patients, they are polysensitized. You have to look for the pattern of the sensitization. Among the pattern, then you have to purify your patients. And then lastly, we do the NPT, the nasal provocation test. The 30% of the patients of the allergic rhinitis, they are not diagnosed by the skin prick test or the blood-based or specific IG. Then we have to go for the nasal provocation test. So there is a pattern of the diagnosis. Initially, long back was there that we take the history, make the diagnosis, then go skin test and perform the component-based test. But now in 2024, the pattern has changed now. Now you have to go down up. Means you patients of infants and children, where you cannot go for the skin prick test. Then you have to go directly for the CRD test, the component-based test, and then you plan according to the history you can go. Another way is there, you integrate yourself.
according to the patient's specific, you should know that which test should be preferable for which group of the patient. Now, these are the tests which you should know. The skin prick test is for respiratory allergy, and the another test is a specific IG extract-based test is done, and third, the latest is the CRD test, or we call it molecule-based test. Now, if all these three tests does not give us a specific information, then you have to go for the BAT test, the basophil activation test, and the mast cells activation test. And because these tests are there, because nobody wants the provocation test. No parents want children to go for the again suffering again. Then you have to go for this. If these tests fail, then we go for the provocation test. Lastly, to rule out the food allergy or drug allergy and the. Now I just give you the history of patients of the nocturnal wheeze. How will you proceed? You suspect nocturnal wheeze. This patient has a history of the rhinitis for the last 10 years. Then you look for the variability. Give peak flow meter to the patients. Look for the variability morning and evening. Variability is there. Then you look for the reversibility by giving the ICS lab as a therapeutic trial. Now diagnosis is with us that it is a uncontrolled asthma as by the PFT has been done, as the PINO and the ACT value has been explained. But what will you do further? How to diagnose? You go for the skin test, and then you go for the specific IG also. These tests are done in, but these tests are positive. Pollen are positive. 1, 2, 3, 4, all these pollens are positive. But this positivity does not lead to anything. Among these 6 positivity, how will you select? Then you plan for the immunocap system, that is the CRD, and this CRD will tell us that this number 1, the FELP1, FELP5 is a genuine, is specific, is a true sensitization, and you plan for the allergen immunotherapy for this. You see, now we are in this era of evidence-based as well as in the era of the molecular. So these are the disease eliciating. We want allergen immunotherapy to give so that the efficacy should be equivalent to the 90%. There are many things in the allergens. Some of the allergens, they are called major allergens, which are disease eliciating molecules. Another allergens, they are cross-reacting allergens. And some of the allergens, they are user allergens, which cannot be diagnosed on the basis of the skin test or the specific IgE. Now this patient has been diagnosed as a grass pollen allergy, genuine sensitization, with these sensitizations, and you plan for allergen immunotherapy, give long-term ICS LAVA till the symptoms are controlled, or on demand basis you give for the antihistamine. Now another case is there. Now you do the skin prick test, but still you are confused. How many tests is positive in this way? Then you go for the still extract base, still you are confused. You can't select until and unless among these 7 or 9 positivity, but once you CRD, that is the answer, that is the genuine, specific and a true sensitization for which you can plan for allergen. So these patients we look in our practice like not only the one disease, but associated with the comorbidity. Like this patient has got the persistent rhinitis, asthma, food allergy. What will you do? You do the skin test, you do the specific IgE, but where is the finding? Still you stand nowhere. Then you go for this is the phylum, grass pollen is more than 100, cypress is there, all these are positive. Now if you take back the history of this patient, the female patient has a history of the oral allergy syndrome. Before that there was a food allergy talk, and the third male patient has got the history of the 3 times history of the anaphylaxis. Patient has a history of a rhinitis, patient has a history of a asthma, patient has a history of the oral food allergy as well as associated with the anaphylaxis. Both these patients, they differ. Skin test and the extract base does not give any of our landmark indications that this is the responsible allergens for ongoing inflammation. So it is found here that in female patient, this is positive to the malon and this is positive to the pallium. Now, if you look at the male patient, again the dust mite and the peach is positive. Now, positivity of these allergens indicates certain specific disease. If watermelon is positive, by the extract base it indicates the patient has got a pollen foot syndrome. But the positivity of the peach contains the PRUP component. It indicates the patient has got a LTP syndrome. So later on the CRD done, CRD further purified, and we make the diagnosis that this patient needs the grass pollen allergy immunotherapy and the another patient needs house dust mite as well as the grass pollen allergy immunotherapy. So if these tests should based on the specific history along with the history of the correlations with the skin prick test and CRD. Now, if all these tests does not indicate, you see what is the idea behind it? We want specific, true, genuine allergens. Like this patient, now this group is there, this allergen is there, it predicts that the patient is a case of the development of the asthma. If this is a positive, it means that this case is may develop of oral allergy syndrome, but when this genuine allergen is positive, it indicates that this patient needs allergen immunotherapy. So we are in the molecular based diagnosis, and we must know that if you are giving the extract based, it contains many components. That it contains allergen, non-allergen, useless. That is why the most of these patients of this, they get adverse reaction. They have got a variable efficacy. They don't even respond and they run out from our therapy. But once you know that this patient is there, he has got a disease eliciting molecule by the component, at least we can tell this patient the efficacy will be tune of the 80 to 90%. So there are certain parameter of CRD, certain cross-reactive and certain they are genuine because some of the allergens they are missing in our skin test, they are missing in our extract base, but they are present in our component. Like this Tri-A90 component present in the wheat. Now if you have heard the wheat dependent exercise induced anaphylaxis, now it is coming up. You can diagnose only on the basis of the CRT and other component like red meat allergy. You can't diagnose unless the alpha-gal is diagnosed by the CRT. So there are certain primary allergens which can be diagnosed. You have to differentiate, you have to rule out the cross-reactive allergens because the species-specific allergens needs allergen immunotherapy rather than these cross-reactivity allergens. So we should know CRD is at the top if you are in doubtful cases of the allergy. We need right patients, moderate to severe allergic disorders and mild to moderate allergic asthma. You did right allergen also. You see, there are these 33 allergens are very common in our Indian practice. And you have to look for which allergens is a specific and genuine. And there are very well controlled studies has been done on the pollen, on the house dust mite, alternaria and the other things. These are the universal allergens. If somebody thinks that I will take allergens only for India, it is the pollen. Otherwise, universal allergens are there all over. So, but polysensitization is a problem for this. And to rule out the polysensitization, one has to go for the CRT. Now, this is the latest which has come in 2024. If you combine both SPT as well as the CRT component base, you can at least achieve the target. Now, dose is very important. Like you know the dose of the amoxicillin, you must know the effective dose. And that is only possible if you put one or two allergens in the extract. Crude extract has been used for years and years in India. That's why we are not so successful. We should not use the crude extract. We should use the purified extract. Product formulation is going on, which contains the main allergen, not the cross-reactive allergen. Like this is the product-based evaluation, depends on the efficacy. So right duration is very important. First year we give immunotherapy. There is a synthesis of the immunoprotective antibodies, IgG4. Second year there is a consolidation. And the third year there is a synthesis of the T-reactor, D-reactor, ILC2 reactor. So like this, I just give you an example of the house dust mite. You know the house dust mite is a major allergen. In our practice, this is like a king. But one should know which is the disease eliciting molecule in the house dust mite. It is the DERP1, DERP2, and but DERP1, DERP2 has got a cross reactivity with the hormone. So how will you select this? And this you have to go for the component dose. Because DERP1, DERP2, DERP23 is used all over the world as a major allergen. But DERP10 is not a major allergen. It is a cross-reactive allergen. So our extract should contain only the DERP1, DERP2 and DERP23, not the DERP21. That is called the standardized allergen extract. So like DERP1, DERP, these patients most of the time they have got a one symptoms is there that they get rhinitis. But due to the spreading of the molecular mimicry, tomorrow the person will be also sensitive to the other molecule of the dust mite and he will develop asthma. So this is DERP10 is a cross-reactive. So, but DERP11 is used in the major allergen in atopic dermatitis. So each disease has got a specific and a purified allergen. So AIT against house dust mite is effective for treating atopic dermatitis in patients sensitized to this. So now I just give another example. If my patient is sensitive to this, equivalent to the histamine skin test positivity is there. I will not do on. I am a purified. I am a specific. I will do put the allergen immunotherapy because there is no case of any polysensitization. But there is a doubtful is there that skin test is doubtful, extract base is doubtful. Then I will plan for the component and look for it and advise the allergen immunotherapy. Third way is there that the patient has a no history and patient has got a positivity is also doubtful, then I will go for the nasal provocation and I will wait observation period. So these are the criteria we make it in guidelines. GINA guidelines came for allergen immunotherapy and these based on certain criteria means you look for the symptom control, you look for the exacerbations, but GINA guidelines does not tell us the bronchial hyperresponsiveness. Even YAKI guidelines also has gone further to use the allergen immunotherapy if the patient is atopic allergic at the top rather than to increasing the dose of the ICS LABA. So with this, I will stop it here because of the time constraint, but thank you very much for listening because this is for taking time.
Thank you, sir. A wonderful talk. We have covered all the tests available with us for diagnosing allergic patients, right from skin prick tests to specific IgEs to component resolved diagnostics and even basophil activation, mast cell activation test. We have stressed on their positives and negatives and interpretation. How do you interpret this in cases of polysensitization? Thank you, sir. Due to paucity of time, we will be closing this session. Thank you once again.
Thank you, sir. I now request Professor Ved Prakash sir to kindly come on stage and felicitate our guest speaker and chairperson. Professor P.C. Katuria, sir. Dr. A.K. Singh, sir. Dr. Muhammad Arif, sir. Moving ahead towards our next topic, allergic rhinitis and its surgical aspect, I request the chairperson to please grace the stage. Dr. Sachin sir, Assistant Professor, Department of Pulmonary and Critical Care Medicine. Dr. Atul Tiwari sir, Assistant Professor, Department of Pulmonary and Critical Care Medicine.
Good evening, all of you. It has been too late. Not wasting much more time, I would like to invite Professor Sunil Kumar sir for delivering a talk over the allergic rhinitis, its surgical aspect. Sir, welcome. Sunil sir is professor in the Department of ENT, King George Medical University, Lucknow.
Thank you, chairpersons and audience. Allergic rhinitis and its surgical aspects. There is a lot of discussion over the allergic conditions, allergens and allergen, and various tests for allergic conditions, skin allergies, food allergies. I am talking about the allergic rhinitis. The allergy of the nasal cavity in pharyngeal sinuses is termed as allergic rhinitis, and it is an IgE-mediated immunological response to airborne allergens. Approximately 80% of patients with asthma have accompanying symptoms of rhinitis, and up to 60% patients with asthma have sinusitis and rhinitis. Onset is common in childhood, adolescence, and early childhood, and symptoms often diminishes in older age, but may develop or persist at any age. Prevalence is a global health problem. Prevalence is around 15 to 20%, higher in pediatric age group. Approximately 80% symptoms develop before the age of 20 years of age. And allergic rhinitis is not a severe disease, but significantly alters the patient's quality of life, social life, like school performance and work productivity. And it causes substantial burden over the quality of life and cost of therapy. Etiology, there is a lot of discussions since morning. Inherent allergens, pollen from trees and weeds, mold spores, house dust, debris from the insect, house mites, food allergy, and genetic predispositions are there in cases of allergic rhinitis. Symptoms, basically diagnosis of allergic rhinitis purely on the clinical basis. What is nasal discharge are there? You can find running nose, nasal obstruction, sneezing and itching in the nasal cavity, itching of the palate, eyes and pharynx may be associated with the allergic rhinitis. Signs, there are various signs in case of allergic rhinitis. One is allergic sinus. You can find here the blackening, darkening just below the lower eye. Allergic solute are there. Patient tries to clean the nasal cavity, and you can find your allergic solute. Again, in this diagram, you can have the typical crease just above the tip of the nasal cavity. That is peculiar of allergic solute in case of allergic rhinitis. Clinical features, apart from typical clinical features like running nose, nasal obstruction, itching, there might be otological symptoms, pharyngeal symptoms may be there, and in addition to laryngeal components. Pathological features, there may be sensory dysfunction because of the nasal cavity. There is physiological disturbances because of change in the oxygen tube leading to rhinitis media with diffusion and retracted tympanic membrane in case of children. Pharyngeal features, you can find a granular pharyngitis, lymphoid follicles over the posterior pharyngeal wall because of the recurrent irritation from the nasal discharge. You can find here the adenoid facies because of the chronic adenoid hyperplasia. You can see here the long thin face, pinched nose, malaligned teeth, open mouth, and these are the typical features of adenoid facies. Laryngeal findings, you can find hoarseness of aspiration may come to the hoarseness because of the edema of the vocal cord. There are certain consequences of allergic rhinitis because of the rhinitis. There is recurrent sinusitis over there. It may accompany the recurrent sinusitis, nasal polyposis, serous otitis media, that is also termed as otitis media with diffusion, orthodontic problems, malaligned teeth, bronchial asthma. 30% of allergic rhinitis have tendency to develop the bronchial asthma, and even bronchial asthma patients have tendency to develop allergic rhinitis. Treatment, there are a lot of discussions this morning about the treatment. Antihistaminics that is can be given as a local form, such as elastic nasal sprays are there. Systemic antihistaminics in form of cetirizine, leocetirizine, fixofenadine, bilastine. These are the day by day improving as previous systemic antihistamines were causing sedation these patients. Decongestants either in form of local, such as nasal drops are there, such as xylometazoline, nefazoline, and systemic decongestants are there like pseudoephedrine and phenylephrine. Mast cell stabilizers, corticosteroid can be given in the form of topical steroid nasal spray as there, in form of mometasone or fluticasone, systemic prednisolone, and methylprednisolone. Usually in allergic rhinitis, usually topical steroids are better because of the less chances of systemic absorption. Montelukast also added with the antihistaminics immunotherapy. It's nowadays the treatment is going on for some specific allergic rhinitis patients. Associated surgical problems, apart from the medical problems, there are certain surgical problems that can be associated with the allergic rhinitis patients, such as David nasal septum. If the patient has David nasal septum that is causing a nasal obstruction, medical treatment cannot relieve the complete symptoms of allergic rhinitis such as nasal obstruction. Concobulosa, that is one condition that is pneumatization of middle turbinate. Sinusitis, if sinusitis is there, there might be little improvement or no improvement in the medical treatment of allergic rhinitis. Nasal polyposis are there. Sometimes there is turbinate hypertrophy leading to nasal obstruction. Here in this diagram, you can see here the severe David nasal septum that is causing the nasal obstruction. In this patient, you are giving the medical treatment for allergic rhinitis. Patient may not have the better improvement because of the obstruction is because of the DNS. This scan you can hear the David nasal septum that is pressing the lateral nasal wall and completely obstructing the nasal airway. Here is the concobulosa, there is pneumatization of middle turbinate. Normally, this is the normal side. There is no pneumatization of middle turbinate. There is generally thin middle turbinate. When there is a concobulosa, there is pneumatized middle turbinate. That is responsible for the nasal obstruction. That may be associated with the allergic rhinitis patient. The endoscopic picture, the huge middle turbinate that is because of the concobulosa. In this diagram, you can see here the beta concobulosa. Both sides there is nasal obstruction because of the aerated middle turbinate. In such cases, you have to go for the surgical treatment. Otherwise, medical treatment for rhinitis may not improve all the symptoms. Again, here is a pyocele of the pyocele and the micropyocele of the ethmoids and the middle turbinate. These are may be associated with the conditions. Again, there is nasal polyposis. Nasal polyps may develop in cases of allergic rhinitis. Allergic rhinitis can be associated with or without nasal polyposis. This diagram you can see here the nasal polyposis completely obstructing the nasal cavity. Again, this diagram you can see here the nasal polyposis. Otitis media with effusion because of the nasal obstruction and adenoid hypertrophy. There may be fluid collection in the middle ear. You can see here the bubbles like structure. Bubbles is typical of otitis media with effusion in cases of adenoid hypertrophy along with allergic rhinitis. and sinusitis, especially in cases of children. And here you can see here the grommet insertion is to remove the middle ear effusion and the further to prevent the further complications of otitis media effusion. You have to go for the surgical treatment in the form of grommet insertion. Now the surgical treatment in cases of associated problems are there with allergic rhinitis such as bronchiolitis, sinusitis, turbinate hypertrophy, Deptt nasal septum or further polyps. What hypertrophy? We have to go for the surgical treatment to prevent the further complications of allergic rhinitis and to give the symptomatic relief to the allergic rhinitis patients in the form of excision of bronchiolitis. Turbinate plasty are there. We have to remove the turbinate, reduce the turbinate size to prevent the excessive nasal obstruction. Septoplasty, ASTHMA done for the Deptt nasal septum, polyp removal in the form of functional endoscopic sinus surgery. And if there is adenoid hypertrophy, you have to go for the adenoid surgery and grommet insertion. The take-home message: allergic rhinitis is a typical medical condition, but you have to rule out the surgical conditions associated with allergic rhinitis in the form of turbinate hypertrophy or nasal polyposis. And we have to look for the cardinal symptoms in cases of allergic rhinitis such as rhinorrhea, sneezing, itching, and nasal obstruction. There are comorbid conditions like asthma, adenoid hypertrophy, ocular symptoms, pharyngeal nasal symptoms in the form of osteoporosis and vocal cord edema. And diagnostic nasal endoscopy is must in all cases of allergic rhinitis to rule out and to treat the associated surgical comorbid conditions, even in case of asthmatic patients. In cases of asthmatic patients, we have to rule out the chances of allergic rhinitis and associated comorbid conditions that are surgical, might be surgical. Those who have to treat for the surgically to improve the condition of the patient. Thank you. This is all about the surgical aspect of the allergic rhinitis patients.
Thank you, sir, for such a nice presentation. Most of the audience in this hall are physicians, so they are not their understanding of surgical aspects of management of allergic rhinitis is very low. So they all are getting benefited by your lecture. Thank you once again. Thank you, sir.
Thank you.
Thank you, sir. I now request Professor Ved Prakash, sir, to come on stage and felicitate our guest speaker and chairpersons. Professor Sunil Kumar, sir. Dr. Sachin Kumar, sir. Dr. Atul Tiwari, sir.
Our last session of the day, allergen immunotherapy and overview. I would like to request the chairpersons to please come onto stage. Dr. Ram Narayan Rawat, sir, Senior Consultant Physician, Balrampur Hospital. Dr. Anand Gupta, sir, Senior Consultant Physician, Balrampur Hospital. I request the chairpersons to please take their seat and introduce our next speaker.
We are little bit late, so we are going little fast. So the speaker is, I am giving the introduction of the speaker, Dr. Vikram Kumar Jain. His present status is consultant in CEO, Rohit Hospital, Jaipur, and his additional past status is additional principal professor in HOD, TB chest diseases, SP Medical College, Bikaner. Area of interest is allergy, asthma, and COPD and TB. Now over to Dr. Speaker, sir. Please, sir.
Thank you, chairpersons, a very scanty audience. Being a very senior person, I am the last best man. Generally, you find the seniors, citizens are given most preference in most of the place. Here I have been given the last preference. Anyhow, because this topic is very important. The allergen immunotherapy. Overview. The purpose of this is not trained to anybody, not making expert to anybody, just to create the awareness and sensitization of this subject, because it's very important in our allergy practice. And I am the alumni of this institution. And this year I am completing the 5 decades. I entered in 1967 in this institution, completed MBBS, DTCD and MD. Thank you. So I will take this part. These are my content. I'll be starting from introduction, history, definition, mechanism, and immunological changes. What are the rational indications? How will you select the extract? And what are the various indication, contraindication, various routes? And I may be touching not only the adverse reaction, but some part recent developments in this. We know since morning we have heard many lectures. One of the most important lecture by Dr. Rajan Prasad, how to clinically diagnose the suspect the allergic diseases, and Dr. Kathuria told about the newer diagnostic as well as the gold standard skin tests for diagnosis. So these are the two important steps, proper clinical history and the skin test or the serological test or recent the CRD. All are very important. After making confirmed diagnosis, then point is that we have to, how we will make the vaccine ARD. We all know the allergic disease are very common, and one thing is very important. Immunity includes the active and passive immunization. And you know the definition, what is active immunization? The active immunization is usually the vaccines. And the AIT is also vaccine. That's this allergen immunotherapy is active immunization. Passive immunization we give by ready-made antibodies. When we use the allergen extract for immunotherapy purpose, call it the vaccine. The objective of AIT is to use this AIT properly, safely, effectively in clinical practice by physician using standard quality of allergens, a vaccine, and he should be trained also. In history, if you find the Persian Jenner developed polio and smallpox vaccine, and in the immunotherapy, Noon and Freeman, about 24 years back, he started on by using serial injection of pollen extract in patients of grass hay fever, and he find very beneficial effect. We were using the various terms like desensitization, hyposensitization. Now we are not using presently these because we cannot completely desensitize the person by any means. Or hyposensitization means incomplete desensitization. Recently we are only universally accepted, the term is the allergen specific immunotherapy, and this is universally used, and the purpose is just to develop the immune tolerance. What is the definition of AIT? Is the administration of gradually increasing quantity and concentration of allergen specific vaccine to an allergic subject having IgE mediator hypersensitivity, reaching to a maximum dose which is effective for relief, not only for relief the symptom but also reduce the medication with the subsequent re-exposure to the natural allergens. Nowadays the vaccine which we are using is a medicinal product, and most of the countries the authorization is and certification is very, very important. The first, before the 1997, there were a lot of controversy of using the AIT is not effective. Among the physicians, they were not accepting. There were a lot of, this subject has always been debatable and discussion always, sometimes controversy. But when this paper came in 1997, which was endorsed by more than 7 or 8 international and national bodies and other recent more than 250 trials, says that allergen immunotherapy is definitely effective for the patient with allergic rhinitis and asthma, only IgE mediated. And when the extract is, these are the various references where I have taken my topic of content, which are evidence-based literature published in this reference. I'll not go detail, but when the disease of allergic develop, they are basically two phases. First is the development of allergic sensitization by initial exposure of the allergens, and because an activation of Th2 pathway, and important interleukins are IL-4, which actually initiate and activate the B cell which will produce the IgE, and later they will attach to the mast cells, and they will, when there will be a re-exposure, the person may turn into the active allergic diseases, maybe rhinitis, asthma, or both, or rhinoconjunctivitis. So there are two basic phases. So where the interleukin, lot of have been said of the IL-4, IL-5, IL-13, these are the important interleukins. They play the role. IL-5 mainly play to the activation of eosinophils, IL-4 and IL-13 activation of B cells and produce more. Then what is the mechanism? Basically the AIT developed the immune tolerance to the allergens, and because of multiple immunological changes are occurred in the body during as well as even after immunotherapy. Early stage is a rapid desensitization, then there is early tolerance, and late stage there is a sustained and long-term tolerance. Initially there is a effective cell desensitization leading to initially increased IgE. Mast cell, basophil, they will decrease. Mediator in histamine will increase. And these are the other important changes immunological, which I will take later on, which will ultimately develop at the end of the sustained tolerance. So these are the immunological change, which is a mechanism of immunotherapy is very complex, and there is a multifactorial sequential activation, and basically there is a shifting of Th2 to Th1 pathway, there will be initially increase of Ig antibodies and later they will be decreased. There will be increased immunoglobulin G blocking antibodies, especially the IgG4, and there will be also, as I said, the Th1 response will be more active. That's why they will increase interferon, and there also decrease of IL4, IL5, IL13. So these are, and there will be further decrease of the various mediators, and there will also decrease T helper cells or increase in T suppressor cells. So these are the tissues. There will be changes in tissue level. The tissue reactivity will also be reduced, and there will be decreased BHR and tissue response, as I said, and target cell reactivity will be there. What is the rationale of prescribing the immunotherapy? This is very important. The diagnosis must be correct, based on clinical and well as based on skin test. And if it is not possible, then you can go for various serological tests, like last test or recently, as Dr. Kathuria said, CRD is much better. But there are multiple queries we will not discuss here. So first is the proper diagnosis. Second is the complete allergen avoidance is not possible. Symptoms are not fully controlled with pharmacotherapy, or pharmacotherapy is causing the side effect. And when patient is not agreed to accept the long-term pharmacotherapy and the compliance or the adherence for long-term medication is poor, or sometimes the patient absolutely refuses for pharmacotherapy. Now, disease indication as Ig mutated, whether it's allergic rhinitis, rhinoconjunctivitis, or asthma, or the insect sting allergy, especially Ichneuthora, and atopic dermatitis. These are the important indications where the immunotherapy is definitely effective. The various type of allergens which we are using, no doubt the pollens, they are aeroallergens. There may be pollens, they may be the house dust mite, fungi, insects, and maybe the other insects in the form of Ichneuthora. So these are the various allergens, and that has to be selected as per the report of the patient, which allergen is positive or which group is positive. So this I will not go, because these are the animal data. We can use the insect. Cockroach, using the cockroach allergens, the results are very encouraging. Generally for food allergy, peanut, cow milk, and eggs we generally use. Bacterial vaccine has got no role in the allergen immunotherapy. Now we are using the various type of extract in making the vaccine. They may be aqueous, they may be depot and modified vaccine. And these modified or depot vaccines are either physically modified or chemically modified or in combination. And newer vaccines are all coming in pipeline. The routine in our practice in India, or even most of the world part, we are using the most commonly aqueous vaccine. This is a heterogeneous mixture of allergen and non-allergy material, because CID is best, which will tell the specific part, which will you can mix it. So because of many problems with the cross reactivity, this aqueous vaccine is rapidly absorbed. It is less stable. It is causing more allergenic reaction and causing less immunological immune changes and causing more systemic side effects. The modified report preparators are better. They produce more immunogenicity and less allergenicity. They may be there are various agents we were using. I will not go there. The physical modification can be done by aluminum calcium phosphatase, and chemical modification can be used by using various chemicals which can be modified with, and these modified vaccines also called the allergoid. The advantage of modified depot vaccines are they are slowly absorbed as compared to aqueous, need only fewer injections, and as I said, they are more immunogenic and having the less systemic side effect, but the local reaction of allergoid or the Deptt preparations are more. How to prepare the vaccine? When we use the extract, we call the therapeutic vaccine, and selection of allergen extracts and their quality must be very good. It is based on better local knowledge of aerobiology must. Whenever anybody practicing AIT in clinical practice, they should have a proper local aerobiology knowledge, both not only globally but also at the district level or the state level or national level. The knowledge of, then you should also know what are the culprits available in the indoor and outdoor. When the best is the one or two allergens in a vaccine is the best, but when there is a polysensitization, then ideally the 3 and 4 allergens are best, but however, not more than 5 allergens we cannot take in a vaccine. And these monoallergens are more practiced in the USA, but the in Europe, they prefer the monoallergens, but in the USA they also say that polyallergen vaccines is also effective. And the Indian guideline, which came into first in 2009 and then 2017, which also advocate that even the polyallergen vaccines are also effective as compared to also mono. These are the contraindication, absolute contraindication when the asthma is not controlled, or when there is a severe asthma, when FEV1 is less than 70%, malignant neoplasm, pregnancy, we never start the AIT, children below 2 years, absolute contraindication, AIDS, and various mental or psychiatric disorders. The relative contraindication is better. Patient on beta blocker, cardiac disease, chronic infection, immune deficiency or use of immunosuppressant, autoimmune disease, children between 2 to 5 years are the relative contraindication. HIV CD4 count when it is more than 200, and mild to moderate psychiatric disorder. Now, other contraindications, when there is a repeated severe reaction during immunotherapy, we can defer it. If there is a repeated severe reaction during subcutaneous immunotherapy or even the sublingual, when there is a poor compliance, and in pregnancy, as I said, new pregnancy never start the immunotherapy AIT, but when patient is already on immunotherapy and then ladies have pregnant, then we can also use the we can continue the immunotherapy. We can temporarily defer this immunotherapy if there is a severe attack of asthma, intercurrent infection, high risk pregnancy. The route of immunotherapy well accepted is subcutaneous, but the sublingual immunotherapy is as good as subcutaneous in India. The DCI and other recommended government bodies have not recommended sublingual immunotherapy in India. People are using it, they are using with their own benefits but otherwise there is no recommendation by any scientific body. Nasal and bronchial routes are not routinely practiced, but however research adverse reaction is more common with subcutaneous, where their systemic reaction are common, and there may be acute exacerbation of disease or maybe sometimes very rarely anaphylaxis. Local reaction may be wheal erythema, diffuse swelling. Late reaction may be local nodule, which is more common in allergoid or Deptt preparations. The systemic and fatal reactions are not very common. They have been reported in the literature and they are very, very less. Near fatal or fatal reactions are very rare. So it's not that if there is these are already there, fatal reaction, doesn't mean that we should not use the allergen immunotherapy. There is a definite schedule of subcutaneous immunotherapy which we are practicing routinely. The purpose is we start with minimum dose and concentration. We took a different type of concentration taking more dilution and increasing the more concentrated. So we start initially with 5,000, then 500, then 50, and we start with minimum dose of 0.1 ml, and every twice week in a week we increasing dose from 0.1 ml to 0.9 ml of 5,000 and 500 concentration. 50 we do it weekly and then gradually increase the concentration for after 2 weeks, 3 weeks, and later monthly. So 1.5 year, after 1 year, we get the maintenance dose and we give the monthly injection, and this is a schedule already available, and this is the we give to the patients the first vial. There is a color of the vial. The green color is the highest dilution, followed by blue color, and then totally will have a red color, which is of highest concentration ranging from 1:50 to 1:100 dilution. Non-injection immunotherapy is also available, which has come in the form of sublingual, oral, and nasal route. That can be considered as a viable alternative to SCIT, because many patients are not, the acceptability with the SCIT is not very adequate. That's why, so this is especially in the children, the acceptability is very poor. That's why the slit or the recently the tablets are recommended more, and the oral routes is also being. So sublingual immunotherapy is as effective as subcutaneous immunotherapy. It is slightly less than the meta-analysis of various studies confirm that slit is slightly lesser effective than subcutaneous, but it's the acceptability much. Why there is a failure of immunotherapy? Because of improper selection of patient in terms of diagnosis, selection of allergen, inadequate duration of immunotherapy, poor compliance, improper education, less duration, premature stoppage of immunotherapy, and if sometimes the patient developing the reaction or to the newer. These are the newer developments in immunotherapy, and these are the in relation to various routes, molecular technology for recombinant allergens, which are much better than and more safety, and there is a, also we are using immune modulating agent, and we are using also biomarker for monitoring clinical efficacy, and we are also using the various biological in with the immunotherapy. These are the newer routes: intralymphatic, epicutaneous, oral immunotherapy. Intralymphatic is short duration. We give US guided 3 injections at 0, 1 month and second month. So within 3 months, 2 months, we completed the duration of immunotherapy. The results are encouraging but not in clinical practice. Epicutaneous in another introduction, and this where we use the 6 patches at an interval of 6 weeks, and this is very good. Results are encouraging. Still there is a first phase and second phase trials are available, and they probably, but long term effect is not. The oral immunotherapy is viable treatment option for food allergy, widely used to treat the peanut milk and egg allergy. And role of monoclonal antibody in combination with AIT, I think Dr. Kathura is more expert of using. He is using the omalizumab before starting the immunotherapy 2 months, and then 2 months during immunotherapy initially. The results are encouraging, and there is meta-analysis and multiple studies are available that the using monoclonal antibodies in combination with AIT is very effective. Last but not least, the future of immunotherapy is very promising, and anybody interested, but it's a time consuming. You need a detailed knowledge, trained, and properly you should also have a patience, and patients should also have a patience. And there are more than 250 trials have confirmed this definitely reduces the medications and the symptom score. We need a adequate proper training and of aerobiology, and then we should have a training from either Patel Chest or various other institutes are giving training fellowships, and I think then here in department, Dr. Baird has also started fellowship in the allergy and immunotherapies. We should always use the standard of the quality of the allergens, and these are. So I end my talk because I could not give in detail, and I am the last batsman. I am very much afraid to be early out, so I am not taking so forcefully my lecture. Thank you very much for patiently hearing. Any questions?
Sir, this is the last lecture, but not the least. I think allergen immunotherapy is very important lecture. You have covered each and every aspect of the topic very nicely. You have covered, sir. I think we are quite late. So, if any question from the audience, and
during workshop they may ask.
Thank you, sir. Thank you.
Thank you, sir. I now request Professor Ved Prakash, sir, to kindly come on stage and felicitate our guest speaker, Professor V.K. Jain, sir. Dr. Ram Narayan Rawat, sir. Dr. Anand Gupta, sir. Well, this brings down the curtain to this wonderful evening. Thank you for listening, inspiring, encouraging, for being here, and most importantly, for giving your time and making your presence. Next, we'll be proceeding for workshop. The first lecture on workshop will be held here in Seminar Hall by Professor P.C. Katuria, sir, on how to write a prescription for allergen immunotherapy.
Again, my greetings. I have brought some cases for you just to sensitize you, that so that you go through the history. There it is now. You see, history is significant, I told you. But after the history, then you plan for the selection of the right patients is most important. That can be done only by the right history. Then the allergens is also very significant, which I told you. And these are the allergens we deal in our practice, that which allergens is more specific for selected patient. And the dose is also important, and the duration is there. These are the fundamentals. But there are certain more things are there which we should know. Number one is there that once you mix the allergens, how to write the prescription is the talk, but mixing is more important. And the fundamental lies, there should not be any cross-reactive allergen. I told you in my first talk that cross-reactive allergens are not going to have any efficacy. It is the significant major allergens which is most important, and the dose is there. Now, if you look at the another case, now this patient, if you note it, that patient of allergic rhinitis and allergic asthma. Now I will compare one case, Tejpal 14 years and Ram 7 years have been both referred for consideration of the allergen immunotherapy. They have a severe allergic rhinitis and both remain symptomatic despite maximum pharmacotherapy with good adherence to the therapy. Now, stage 4 is symptomatic in the late spring and early summer months and is sensitized to the grass fodder. It is a seasonal case. It is not a perennial case. But if you compare with the Ram suffers from a perennial symptoms and is polysensitized. Poly means if you are two group of the allergens are there, house dust mite, cockroach and toad. So how will we proceed for this patient? Now allergic rhinitis sensitized to pollen. All over the world, now competition is going on, subcutaneous, especially in the European and USA countries, that if pollen are there, then equally effective subcutaneously as well as the sublingually. That's why the tablets are available, and it is the tablet which is 100 times more dose of the subcutaneous. But now look for the RAM, allergen immunotherapy sensitized to this group of the patient. What will you do for this patient? So choice is there. Here the subcutaneous is there. Because the RAM has got a perennial allergen, polysensitized allergen, no role of the sublingual immunotherapy. That is most important take-home message. Now another is there. Now 7 is nothing to add, mild to moderate. But once you give the subcutaneous immunotherapy, FEV1 should be more than 70%. You see, whatever the guidelines are there, it is only the FEV1. And there is no exacerbations for the last 12 months. So these are the special indication. Otherwise, in pediatric also, people used to say in severe asthma, but if FEV1 lung function is there, normal and no exacerbation, AIT has been successfully administered. And now we use the biological. With the advent of the biological, especially the omalizumab, we have a track record of 20 years. In all our patients, they first take 2 injections of omalizumab and it reduces the adverse events, and then we further continue our allergen. So polysensitization is a big problem. So these patients, they need subcutaneous immunotherapy if the patient is allergic to more than 1 or 2 allergens. Now this is the graph which we say mixing is there. So if you are another case is there, 8 years old boy, history of a nasal blockage all year around the 4 years, persistent, clear, what is nasal discharge becomes troublesome, constant sneezing, itching, everything, shortness of the breath, what will you do? Now it is again the perennial problem is there, and these patients, they were sensitive to the house dust mite, and these were put on the allergen immunotherapy. Most of the children we have seen that if their case is a perennial, suspect it is a house dust mite allergen, and then pollen, basically the size of the pollen is hardly 5 to 250 microns, but the size of the house dust mite is very equal 2 to 5 microns. It directly go into the lower airways and can induce the ongoing inflammation. Now, most of these patients I will show you are having the dust exposure. Now, this case is there, they have got a sneezing, nasal cough, tightness, symptoms are exacerbated during the dust exposure. He has been treated successfully with antihistamine, and again after a year, and the patient was instructed to go for the test, and the patient was positive to that. Now this patient is a pollen, Prosopis parthenium mite. But now if you go back to the history says that he has no seasonal exacerbation. He has got a perennial symptoms and only to the dust exposure. So that history correlates with the positivity, and then you plan which of the allergens we use for allergen immunotherapy. The answer is only the dust mite, even if the pollen are positive. Because if you treat one single allergen in an effective dose, even in a polysensitized patient, aim is to activate the Treg cells. Once the Treg cells are synthesized in our system, patient will get response. Now these patients, most of these patients, usually farming is done, bronchial asthma, FEV1 is more than 70%, the rhinitis also. Now there are 3 pollens are there, and most of these 3 pollens, now this is a tree pollen, number 1 if you look at, and the second one is the weed pollen, third one is the grass pollen. So pollen combinations can be done, and with a dilution as per advice. Now another case is there, symptoms are there, history of atopy, exposure to the house dust mite, again FE1 more than 70. I just give you take home message. FE1 more than 70%, perennial cases, select the allergens accordingly, and then give for. Now, this is the amaranthus parthenium dust mite. But problem is there, we have got an unstandardized allergen. This is the difference between standardized allergen and the unstandardized allergen depend on the how much of the major allergen is present in the extract. If major allergen is there in standardized, I am not worried. I will not, my patient will not get any adverse event. But if the unstandardized allergens, I am worried, then we plan for the other therapy like omalizumab. Another case is there, that is again this case of a bronchial asthma, moderate rhinitis, allergic asthma stand. Now here this is a standard, acroid. We have used acroid a lot of initially it was the NY. So even the acroid is available from abroad. And these are the safest cluster immunotherapy where is the least adverse events due to these. But another case is there. Now this case has got a holoptilia, argibone and a ASTHMA. Now what will India do? If you have got an unstandardized allergen, then the build-up dose will take 7.5 months. So unstandardized, though it is effective, but the time taken, and during these 7.5 months, patient will get viral infection or any infection, and patient will stop the treatment. That is the problem. But if you use standardized allergens, then the patient will continue within a 4 to 6 weeks. Patient will have a build-up dose, and build-up dose will continue, and the patient's symptomatology will be decreased. So another case, if you look, that persistent seasonal increase, seasonal cases there, rhinitis, alternaria, chenopodium. Now, second take-home message. This is a wrong prescription. Means we must understand that there are certain incompatible allergens. You can't mix them. Pollen wilt has got its own, mite has got its own, and the fungus has got its own. And this is a case, it's an alternaria. Alternaria is a fungus. So you can't mix. This is a wrong prescription. So take a message that incompatibility should not be there once you prepare the allergen prescription. Now this another case is there, environmental. Environmental risk is more important. Now this patient has got basement flooring consists of the carpet, and he used to get symptoms. His symptoms described are compatible with there is no pet, no smoking, but dampness. The patient was sensitive to the aspergillus, penicillium, dust mite, all were there. But if you look at this, how will you plan? Because penicillium, aspergillus, we don't give any allergen because they are not the standardized allergen available. So we plan only for the pollen and house system. 70% of the patients in our practice, they are on a pollen and house system. Hardly 5 to 10% they are on the fungi arteria. So occupational allergic rhinoconjunctivitis, the house is still, now this patient needs avoidance. History of it did not confirm home environment. So this is an occupational factor. He was working in a rice factory and he was sensitized, and once you do the avoidance of this, then the patient gets. Now this is another case, 10-year-old boy with a 2 years history of a marked eye itching, sneezing, nasal congestion, clear, what in April, May, also in August, September. Now this is a case of change in the symptoms. So you suspect that these patients will have got a sensitivity to the pollen. So he was having sensitivity to the tree and wheat pollen, and the patient was planned accordingly on the basis of the positivity. So pollen avoidance is not practical. People they say avoidance. No, it is not. You have to immune. You have to test first, treat and train the immunity. That is the aim only. Because earlier you train, it is better. Otherwise, these patients will develop ongoing inflammation. So these patients, they are also the tree, mold and wheat pollen sensitized. Most of the patients, if you look for it, that if you want your patient has come with a antihistamine, you don't know, patient does not know, then go for the positive and negative control. Dr. Jain will show you the practical demonstration of it. So skin prick test is done, and these patients, they were sensitized to mix for a process whenever use candidate. So aim is there, take home message from me that no cross-reactive allergen in the allergen extract. Second is no incompatibility, means high protease allergen should not be mixed in a low protease. Third one is the effective dose, and fourth one is the duration is very effective. So general rules are there, and these are the how to calculate the dose. This is exercise which you need to learn from us, and these are the books which you can take it and you can go through it. And thank you very much.
Thank you, sir. Finally, we would like to express our gratitude to all the sponsors, organizers, and volunteers who have made this event possible. We hope that this event will serve as a catalyst for the greater awareness and it will inspire us to work towards a healthier and happier future for everyone. On that note, I would like to take my leave. Until next time, thank you. Kindly proceed towards the workstation. Workstations on second floor, PFT lab.